Assalamualaikum warahmatullahi wabarakatuh. May peace be upon us all. Shalom, Om Swastiastu, Namo Buddhayo, Salam Kebajikan. Distinguished delegates, ladies and gentlemen, a very, very good morning. Selamat pagi. And welcome to the second and final day of the second ASEAN Academic Conference on Disaster Health Management here in the beautiful and historical Yogyakarta Special Region. Delegates, ladies and gentlemen, we begin our day by looking into a philosophy that is near and dear to the heart of the people of Yogyakarta. Hamamayu Hayuning Bawono. The true essence of life is to keep a balanced relations between men and each other and between men and nature and all the creatures within it. Very much in line with our theme of the event, One ASEAN, One Response. Delegates, ladies and gentlemen, we have such an exciting day ahead. 3 invigorating sessions will be in our agenda today, including at the end, later on in the day, the closing ceremony and the handover of chairmanship from Thailand to Indonesia. And now, without further ado, we will start the 4th session of the conference, shining a light on the topic Case Study Reports on DHM Practice and Experience. Allow me to introduce our moderator of the day. He is the Chief of Medical and Professional Staff of Jose B. Lingat Memorial General Hospital of the Philippines. He plays an active role in various national and international public health emergencies and planned events, having served as drill master and mentor for the regional collaboration drill of the ARCH project and team lead of the PEMAD deployed for earthquake response operations in the Republic of Turkey. And now, with great pleasure, let's welcome Mr. Alfonso C. Danak.
Okay, and a pleasant good morning to all of you, and welcome to our second day, our last day for the second ASEAN Academic Conference on Disaster Health Management. This will be our 4th session, and as we gear for its last day, this session will deal on our case study reports on various disaster health management practices and experience. This will be divided into 2 parts. For the first part, Malaysia, Singapore, and Thailand will present the EMT response practices of their respective ASEAN member states. While on the second part, we will see the experiences of the different AMS of EMT of Indonesia, Philippines, and Japan on their deployment during the magnitude 7.8 earthquake in Turkey. To begin this morning's session, the first part will have 4 presenters, and our first presenter will discuss the 2019 Pasir Gudang chemical incident, the impact of transdisciplinary approach on emergency medical services. We bring you Dr. Rashdan bin Rahmat, an emergency physician from the Emergency and Trauma Department of the Hospital Sultan Ismail Johor Bahru, Johor, Malaysia. Please welcome Dr. Rashdan.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera. Very good morning to all the distinguished experts and participants. Thank you, Mr. Moderator. First and foremost, I would like to take this opportunity to extend my gratitude to the organizers for allowing me to participate in this great conference, meeting new faces, exchange views, not forgetting the warm hospitality of Yogyakarta and the busy streets of Malioboro. By the way, I'm Rashdan bin Rahmat, an emergency physician working in HSI Johor Bahru, which is Hospital Sultan Ismail, not Hospital Safety Index. I'll be talking about the chemical incidents that we faced back in 2019 in Pasir Gudang and the impact of the transdisciplinary approach on the emergency medical services. I have nothing to disclose. Sorry. I have nothing to disclose, no conflict of interest. And this will be the contents of my presentations. And we'll see the impacts of the transdisciplinary approach on the emergency medical services, as we have heard speakers mention about, the previous speakers mentioned about this transdisciplinary approach. Let us begin with looking at the statement by the then Deputy Prime Minister of Malaysia back in 2019 in Geneva. Yes, we all know that Malaysia is not a disaster-prone area, though we do have high-frequency, low-impact disasters such as floods, landslides, storms, and haze throughout the year. And we also have the main disasters, fires, and recently, because this was made in 2019, she mentioned also about the gases, chemical pollution. And in order to tackle all these things, we need to engage all the government agencies, along with the state, federal authorities, experts, private sectors, and civil societies. That's what we are here today. And being a part of the ASEAN member states, we play our major roles in engaging with the risk reduction activities, initiatives in this area. I believe that everyone agrees that we have to move away from the traditional ways of managing the disasters, which is known to be ineffective, to the new approach that we need to engage more people, more authorities, including the academia, not forgetting the civil societies, so that we can have collaborations for an efficient disaster management. To do this, we need to have a team-based approach and foster our partnership, public, private, not forgetting the academia, and of course our civil societies, to have a better partnership, collaboration, to have a collaborative manners in disaster management, not forgetting the flexible, integrated communication and information systems to be in hand. Sorry. I should press one only. Okay, talking about the transdisciplinary approach, what do we mean by that? It's defined as an approach in which all players and stakeholders in various disciplines and sectors working together to achieve a common goal. We move forward from single disciplinary working in silo to multidisciplinary, interdisciplinary. Now we are talking about the transdisciplinary approach, which means working beyond our own discipline to implement new knowledge in practice for a common goal. And being an emergency physician, working in the second biggest hospitals in Johor Bahru, in Johor state of Peninsular Malaysia, the emergency medical services is very close to me. It is a service aiming in providing a proper and organized emergency services, catering for the illness, injured patients, victims, as well as providing the pre-hospital care and transport the victims, the patients to the healthcare facilities where we will give them a proper, better treatment and management whenever it is needed. And as I mentioned just now, I'm working in HSI Johor Bahru. Johor is the southern states of the Peninsular Malaysia, and Pasir Gudang is just nearby, which about 20 kilometers away from the state capital. It is heavy industrial area, which cater the main industries, mainly the petrochemicals, located in around the Johor port, the two big ports, the Johor port and the Tanjung Lansat port, with a population of more than 500,000. And for the healthcare facilities, we have one health clinics located in this area. And HSI, or Hospital Sultan Ismail, located about 20 kilometers away. Okay, to cater for the emergencies, as this is a high-risk area managing the petrochemicals and the heavy industries, back in 1988, the local authorities established Pasir Gudang Emergency Mutual Aid, or well known as PAGEMA, to get together the government agencies and high-risk industries to assist in protecting the public from injury and health hazards, preventing loss and damage to property, safeguard the environment, and last but not least, working with other contingency plans, including agencies at the national level. So this is kind of public-private partnerships between the government agencies and the industrial players. So as we can see from the pictures, they have been involved in many activities, as well the incidents happening in Pasir Gudang. Back in 2008, when there is a fire explosion in one of the tank in the petrochemical areas, where they have to respond for a few days, getting all the involvement of the agencies working together to deal with the incidents. And 2019, the one that I'm going to share with you in the next few slides. And we do have our annual drills to get all the agencies and the industrial players together. Yeah, coming to this incident that I am going to share with you today. Back in 2019, on the 7th of March, as early as 9 in the morning, we start to receive distress calls from the publics going through our call center, MERS 999, the Malaysia Emergency Response System, Response Services 999 through our Medical Emergency Coordinating Center, the MCC. We receive a distress call saying that the students from two schools, the primary and the secondary schools of Pasir Puteh, Taman Pasir Puteh, which is in Pasir Gudang, they start to have breathing difficulties, dizziness, nausea, vomiting, and some of them even fainted. So it went on for 2 weeks, involving nearly 6,000 victims. Nearly 1,000 were admitted, and 25 were admitted to ICU, and half of them were intubated and ventilated, including one of our healthcare personnel. And later it was found that the source of these bad smells, bad odors, later on was found from the dumping site at the construction site of the bridge over the Kim Kim River. So this is Kim Kim River, the Pasir Gudang chemical incidents back in 2019. I would like to mention about these incidents which happened in phases. On the first day of the 7th March 2019, when we start to receive victims with all the symptoms that I mentioned just now from these two hospitals. Yes, when we combine the primary and the secondary schools, there will be more than 1,000 students. So we immediately activated our hospital emergency external disaster management plan. We deploy our teams to the incident site, and they start managing the patients, the victims, the students, including the school staff at the medical site at the ground zero. And after all the victims, nearly 40 of them being managed on that day, the authority declared ended of the operations later in the afternoon around 1 p.m. So 7th of March was on Thursday. Our holiday is on Friday and Saturday. That's weekend for us in Johor. And they decided to close the schools on Sunday, where it's supposed to start the schools, but they decided to close for the cleaning purpose. When it reopened on the 11th of March, on the day 5, early in the morning, the symptoms starts. This time involving more students and more schools surrounding the first primary and the secondary schools of Taman Pasir Puteh. Again, it ends on that day after several victims being managed, either incident sites or being taken to the hospitals. On the day 7 or the 30th of March, things getting worse. So the State Disaster Management Committee decided, instead of just managing the patients at the medical base at the incident site, they start opening the community hall of the Taman Pasir Puteh to cater for more victims and more patients. As you can see there, it's a very chaotic situation. And later on the second week of the incidents, when more and more schools, more and more victims, more and more students getting involved, they decided to close all the 111 schools, primary and secondary schools, including the institutions in Pasir Gudang area, because they have to cater for this one, and they move to cater the victims to the indoor stadium of the Pasir Gudang. As you can see, the last slide, the last picture there, they have a well-organized beds to cater for all this. Just imagine you have to cater nearly 6,000 victims in 2 weeks' time. And the main responding hospital is Hospital Sultan Ismail, which is, I mentioned just now, located about 21 kilometers away from the incident site. And you can see if 21 kilometers, it will take about 25 minutes, half an hour for the ambulance for one way, and to and fro will take about nearly 1 hour. So we manage about 20% of the total number of patients, starting from the 36 patients on day 1. So it's escalated up to more than 1,000 for the total periods of that 2 weeks. And out of that, 1/3 were admitted and 13 were intubated and ventilated. Fortunately, luckily, alhamdulillah, thank God, that we had no mortality, even though we managed more than 5,000 victims for these unfortunate incidents. We thought 20th of March was the final day and everybody was happy. We go back to our normal day-to-day works. But beyond our expectation, 3 months later, 20th of June 2019, again the same symptoms reappear. In the afternoon of 20th of June, again on Thursday. So today is Thursday. I hope nothing bad happened back home. And I always told my staff, if you want to take leave on Thursday. Because 7th of March, Thursday. 20th of June, Thursday. And I happen to be the physician on call on that day, so I have to lead my team. Again, this time in Sekolah Agama Taman Mawar Pasir Gudang, where we have more than 1,000 victims, but this time more than 2 months period, again we have no death. And this is on the 20th of June. The situations, we were more alert. I lead the teams of my emergency medical team, managing the patients, and so on and so forth. We keep on receiving the victims till end of August. These are the list of the chemicals involved. Pay attention to the acrylonitrile because of the cyanide release. Luckily, we don't have to give the antidotes, as none of our victims have the high levels of cyanide toxicity. This is how we activate our emergency medical services. The moment we receive the calls from the MERS 999 through our call center, and then we dispatch the calls to the various clinics, hospitals to respond, And on top of that, we have the state and the National Crisis Preparedness and Response Center, CPRC, to coordinate the whole process. Transporting the patients, the distance is our main challenge, main issues, because we require more ambulance, we need more staff, staff will be exhausted because of the hot weather, and patients can deteriorate because of the traffic congestions and the journey. And luckily, we have this assistance from the PAGEMA members. They give the assistance in terms of the ambulances and the manpowers from their ERT. I think I need a grace time because of these issues. Okay. We have ongoing discussions with the authorities, actions, views, science visits, joint trainings, development common SOP, and we bridge the gap, improving the networking, and we are doing the one language practice. Even our public health counterparts, they come up with this new layout plan for the indoor stadium of Pasir Gudang. They have a very nice arrangement, the green zone, yellow zone, and the red zone for the patients. Even they have the where to put the decon area for the fire and rescue personnel, the hazmat team to do the decontaminations for the victims if we have to face the things again. And again, I would like to emphasize about the impact of the transdisciplinary approach, working in an integrated and connected way using a common plan to achieve the shared goals with the State Disaster Management Committee, supervised by the NAMA at the federal levels and assisted by the PAGEMA at the local levels. They coordinate all the agencies, private sectors, the municipal council, the local council, including academia and the civil society, to work together hand in hand. You can access this report by the Academy of Science Malaysia. They have the reports published. And according to Zainur, again, they mentions about the roles that played by the PAGEMA in these unfortunate incidents. In conclusion, what I can say that, yes, we have to work together, enhancing the networking. By doing that, we can practice our one language principles by having a regular training, CIMAX, and last but not least, enhancing the partnership. It's not just between the public and private partnerships. We need to include the academia and community so that we have a better collaborations in the future. In brief, it is about strengthening the cooperation in terms of teamwork, improving the communication in terms of continuous discussion, and aligning the coordination in terms of effective partnership. With that, thank you for your kind attention.
Thank you, Dr. Rashdan. And in the interest of time, we have room for just one question. Are there any questions from the audience? If none, we would like to ask Dr. Rashdan just one question. Are there program? Yes, yes, sir. Yes. Please introduce yourself.
Good morning.
Yeah.
Thank you very much for the sharing. And certainly I am very much inspired by the way that you have brought everything together in terms of systems with the private vendors and so on, all partnership to get one. Just want to highlight that also the Pasir Gudang is really just next to Singapore.
Yes,
So in
we are
terms of the
neighbors.
One ASEAN, One Response partnership, in fact, we have been receiving timely notifications when such incidents may have occurred so that we can also take steps to prepare our environment as well. So indeed, I think just want to highlight that unfortunately such incidents are not designated by our boundary of our nations, but actually we are all in it together. And we certainly appreciate the timely notifications that we have been receiving and that we can work together to get a better outcome out of such incidents. Thank you very much.
Thank you.
Thank you, Singapore. And at this juncture, we'd like to say terima kasih, Dr. Rasdan, for that wonderful, informative presentation. Our next presenter will discuss the portable medical isolation unit for the transportation of high-level isolation pathogens. He is an associate consultant at the National Center for Infectious Disease and the chair of the High-Level Isolation Unit Training Committee and member of the Portable Medical Isolation Unit Work Group in Singapore. Please welcome Dr. Darius Be.
Good morning to one and all. I'd like to thank the organizers for inviting us to talk about this topic on portable medical isolation units for the transportation of high-level isolation pathogens. I have no conflicts of interest to disclose. We should go through some definitions and abbreviations. PMIU stands for Portable Medical Isolation Unit. It's also referred to as a Patient Isolator Unit, or PIU. HLIP are high-level isolation pathogens. They're also known as high-consequence pathogens or infectious diseases, and some people refer to them as special pathogens. Now, when it comes to pandemic preparation and disaster health medicine, there are some differences in compared to special pathogens. And this is mainly in the planning norms, where in disaster health medicine, you plan for a large number of casualties, but in special pathogens, we tend to plan for a smaller number of casualties, primarily because of the high resource intensity that they involve. But the elements are the same: staff, supplies, training, comms, and funding. Now, the prototypical special pathogen that we talk about is Ebola, but there are others such as Marburg, Lassa, smallpox, and disease X. So high-level isolation unit is HLIU, and is also referred to as BCU, or biocontainment unit. So with that, we want to talk about why you should consider a PMIU for HLIP, what some of the pros and cons are, what does PMIU comprise of, when to consider deployment, how to evaluate potential PMIUs on the market, steps to take to operationalize them, and where does this fit into the overall response plan. So going through Ebola virus transmission and the risk of the healthcare worker, the highest risk of transmission is really with reference to bodily fluids such as vomitus, diarrhea, blood, and direct contact, followed by droplets, fomite transmission, and aerosol transmission has been described in animal models. With regards to the impact of Ebola on the healthcare system, we will realize that healthcare providers are at the highest risk, and there's something to do with the hospital environment that amplifies transmission. So how can we do better to prevent transmissions and prevent the mortalities that have been seen in previous outbreaks? So this is an example of a pre-hospital retrieval of HLIP. It could be a patient that is an imported case from overseas, and activation of the EMS would bring the patient to our high-level isolation unit in NCID. Many patients will present to primary health, where there is only some PPE, untrained staff, and maybe questionable or protocols of waste management that may not be too firmed up. They will need to travel through built-up infrastructure, resulting in contamination in the environment before they reach our HLIU, which has the engineering controls, specialized PPE, trained staff, and waste management. So how then can we bring forth some of these elements of our HLIU and our BCU, or biocontainment unit, further upstream? So some people have explored things such as draping, and this is something that can be done on the internal environment of your ambulance system. But as you can see, not all areas of the ambulance can actually be covered. There are many different nooks and crannies, and your healthcare workers need to be in such high level of PPE where it is hot, it is difficult to work, and performing tasks can be quite challenging. So this is in comparison to a PMIU, where the PPE is wrapped around the patient. And in essence, if you do so, we ask the question, can you then decrease the amount of PPE around your healthcare worker, allowing them greater thermal comfort and ability to perform their activities? These are just some examples of PMIUs used in various different countries, Swiss, US, and then on the far right is an article where PMIUs were bought in, I think, the hundreds in order to prepare for potential disaster planning for the Olympics. So these are just some of the scenarios requiring PMIU transfer that we've talked about. And I would just like to highlight, it's not just for patients who have confirmed HLIP, but those who have high suspicion of having it as well, as long as they are symptomatic, assessed to have potential exposure or symptom onset within the incubation period, which is for Ebola 2 to 21 days. Other special patient groups that we've considered include pediatrics, pregnant women, and also family clusters. So there are many different types of PMIU. This is an open system, which is more like a field deployable biocontainment unit. where the healthcare worker can enter and provide care within it, and then on exiting will doff the necessary PPE. This is in contrast to a closed system where the patient does not exit, the healthcare worker does not enter the PMIU and provides care through these access ports and gloves on the sides. There are hard shell options and soft shell options. In general, hard shell options tend to be heavier compared to the soft shell options. And then on the left is one example of something that's reusable, whereas on the right is a disposable form. So a PMIU is basically just a patient in a box where the healthcare worker stays on the outside and the biohazard is on the inside. And in this way, you have some degree of safeguard. It's usually HEPA filtered in terms of the air that is exhausted, and this is battery operated, so that's portable. These are powered through blowers, which are either positive pressure or negative pressure, and then you access the patient or provide care through these gloves, and medical supplies can be kept internally. Other access ports can provide routes to administer intravenous fluids, medications, vitals monitoring, or even connect a ventilator. So these are some of the pros and cons of a PMIU. The pros are that it can overcome issues with regards to the construction of the ambulance, because as you can imagine, different ambulances of different structures will require different draping requirements. But however, the sizing must be compatible with the ambulance stretcher. Overall, there'll be less preparation time required to draping the ambulance, but there's less access to patient affecting the level of care. But this can be overcome with wireless devices such as stethoscopes or SpO2 monitoring devices. Generally, it does provide superior containment of infectious particles, but you'll need to run lines monitoring equipment through the ports. There are less safety issues compared to draping where slipping can occur, but it's mainly for ambulant, non-critically ill patients, and definitely not for patients with claustrophobia. It's good for long durations, so it minimizes the need for enhanced PPE, but these long durations also increase the risk of deterioration and the potential of battery failure. For those that are disposable, there's less need for disinfection. However, there are some ethical considerations, such as the question of whether or not you open up a PMIU in the event of patient collapse. It can be decontaminated, and therefore, if the patient tests negative. And there are other considerations such as cost, procurement time, training requirements, storage requirements, and also potential maintenance. So these all factor then into the considerations for evaluation, and I won't belabor the point any further. This is what we had in terms of the proposed considerations for a disposable PMIU. So we wanted one that had a short lead time for delivery, less than 4 months. We wanted one that was light, one that we had a local distributor, and one that was disposable. And then this is just an example of an evaluation criteria comparing to, and I think the weight of a PMIU is very important, primarily because that's just the starting weight. You still have to put a patient who may weigh 70, 80 kilos, and then if your starting weight is 40, you're looking at something more than 100. And that can be quite challenging for your team of EMTs and paramedics. A PMIU is not going to be deployed in all scenarios, and a risk assessment is usually made in order to decide on the deployment of one, and that's based on the index of suspicion, so basically the likelihood of infection with a viral hemorrhagic fever or an HLIP, whether or not the patient is medically stable, so stable yes, unstable no, whether or not they have a ventilator, the exposure risk, so longer durations increase that risk of exposure, definitely wet Ebola patients, those that have a lot of secretions, diarrhea, vomiting, or bleeding, those are things that we would like to prevent in terms of transmissions, and then the patient's tolerance, so whether or not they're claustrophobic or violent. Now, although I did mention that it generally is not used for patients who are ventilated, this is a retrospective review performed on long-distance aeromedical transport of patients with COVID-19, and 3 out of 13 of the patients were actually ventilated, 2 of which had excellent outcomes, but 1 had tube dislodgement. It also goes to show that this is also something that's quite feasible. The flight times were also between 2 to 11 hours, but there are some risks involved. So whilst I put forth the case for a PMIU, I do want to emphasize that it's a small component of an overall larger response that does need to include things such as border checkpoint surveillance, suspect case definitions, early notification, activation of your EMS system, and triaging whether or not you want to use a PMIU. Communications, command and control are very important, fast-tracking security clearances, PPE, the proper donning and doffing, early treatment protocols for patients with HLIP, and including, in addition to waste management. And then your PMIU fits somewhere there. And so if you are thinking about having a PMIU, I think there needs to be adequate discussion, policy in place, definitely a significant amount of training of your EMS staff and your hospital staff that are receiving the patient, in addition to exercises and audits to ensure that it is being implemented effectively. And this is one of the audit tools that we have come up with and we'll be using in one of our future exercises later this month. I wanted to end off with the incident life cycle, primarily because I think it's a good platform to do so as I was thinking about this talk. I think we've been through a lot through this 3 years of a COVID-19 pandemic, through preparations, response, and we're at a stage of recovery. And I think that's why this is a very good platform to discuss further readiness for the future. And I end off with this African proverb, a belt fastened while running will come undone while running. So essentially, if you want to be agile and fast in response to various scenarios, we do need to fasten our belts and prepare for it in advance. Otherwise, when the time comes that we need to run, we might be caught with our pants down. Thank you.
And again, thank you very much, Dr. Be, for that very informative and enlightening lecture presentation on the portable isolation unit. Are there any questions at this point regarding the PMIU? Anybody? In your experience, Dr. Be, the isolation unit has been very much used during the COVID-19. What do you think are the major challenges in its daily operations and maintenance?
Yeah, so I think the first PMIU that we actually first procured was a reusable one, and it was a hard shell, a beautiful system, I must say, but does have significant issues with regards to the protocols in place for disinfection. And you can imagine it's like taking apart a device, pieces of Lego strewn everywhere, and different components have different instructions for use with regards to the contact time and disinfection that's required. So it's very challenging and it's very tedious, and it's a lot of laborious training and man hours for the nursing staff who have to do the disinfection. So I think that's, for us, was one of the major challenges and one of the pushes to switch to a disposable system.
Yes, thank you, Dr. Wei. Any more questions from the audience regarding the PMIU? I think this is very much good in our hospitals. We have used this before in COVID-19. It is really quite challenging to maintain it. Okay. If none, we'd like to thank again Dr. Be for that wonderful presentation. Our third and topic will be about the deployment of the emergency medical team of Thailand during the COVID-19 outbreak in their country, their domestic response. There will be two presenters for this. Our first is the emergency physician from the emergency department of the Center of Excellence, Trauma and Emergency Department, Rajaviti Hospital, Department of Medical Services, Ministry of Public Health, Bangkok, Thailand. And that's Dr. Nopmani Tandives Ruwangdet. And the second presenter is the Chief Nurse of the Center of Excellence, Trauma and Emergency, Rajaviti Hospital, Department of Medical Services, in the Ministry of Public Health of Bangkok, Thailand. Mr. That's Panjasilpa Sombun, the Chief Nurse of the Thailand. So please take the floor. Thank you.
Okay. I apologize to have two speakers, and I have the setting to the two parts. Part one is me to present for you, and the next part to Mr. Ranjasin. And first of all, I say that good morning, ladies and gentlemen. I'm Assistant Professor Nopmani Tandives my team, Mr. Panchasin Somboon and Dr. Poch Intarapapon, on behalf of Center of Excellent Trauma and Emergency Rajaviti Hospital, Department of Medical Service, NIEMS, Bangkok, Thailand. Many thanks to AAN Committee, Arts Projects Team, and Department of Research, Rajaviti Hospital. I would like to tell you about that. When I come to Indonesia, I met the old friend, and she lost of 13 years old, and we learned about the disaster together in Thailand. Her name, I said that Ina, and I appreciate to come back again to Indonesia. And for this presentation, I think that education is not the end. We can learn together and sharing for the experience. For Thailand, why we use the EMT COVID-19 outbreak experience in 2020 domestic response, we have in the first wave, we found that we have the first case from Wuhan, main China, and on December 2019, and we found that we met the first domestic case on March. It's a taxi driver. Then we found that more than 55% of the case is a traveler. And what we learned and what the Thailand can do well in the first wave of the COVID-19, we have about 188 cases. We found that we have the death case about 0.5%. And all the world, we found that the death case is about around 2% or 2 to 3%. And what happened for the Thailand do when we have the first wave? And for the first wave, we have the government and the public health can work together and setting for the policy, right? To use the community, have a strategy of the DMHTT. What is the DMHTT? DMHTT is keep distance. M is mask wearing. H is hand washing. T is testing, and T is body temperature. And we follow by the WHO recommend like this. And we early alert to setting the EOC, and we have the law and regulation to set the lockdown, have releasing. And after that, we have the three things for this. For the three things, we setting the early diagnosis by the physician. What we do, we have early for the diagnosis. We use the criteria, right? Fever more than 38 degrees, and we have and pass to the respiratory symptom. And when we met case, we isolate this case and manage the patients. Then after that, when we use the EMT to respond in the domestic, we found that the flow of the hospital, and we need more extension healthcare service. We need few hospital, and we need the new team, and the EMT have a limited to transfer to the other country, and we can add the value for the EMT to use them in the domestic Like in the area of the second wave of Thailand is a fresh market, is an immigrant area, and we can use them and can have the good quality and service well for the Thailand. Thank you, and let you know about and sharing about the response of the Thailand EMT in the Samut Sakhon province, just near the Bangkok. Okay, thank you.
Okay. May I apologize for some mistake? Back to normal. Very, very good morning, ladies and gentlemen. I'm Panchasin Sambun, Chief of Nurse at the Narendra Center, Ratchaviti Hospital. The center of Bangkok, under the Department of Medical Services, Ministry of Public Health, and I also the member of EMT Thailand also. I'm very glad opportunity to share about experience about EMT Thailand's response during the COVID-19 2020 to 2021. No conflict of interest for this presentation. As mentioned about Dr. Narumon mentioned yesterday, Thailand has a robust training for the medical emergency team, MERT team in Thailand. We had training since 2008 and in 2015. Thailand MERT deployed to Nepal to respond to an earthquake in Nepal. Thailand expresses its interest to become certified, the WHO certification to EMT Thailand Taiwan FIT. Throughout the 2018, we worked so hard, training, practice, drill, exercise, again and again. Finally, our team was verified the first team in Seattle as well as the Asian regions. But less than a year after, the COVID-19 has occurred. Thailand is doing well in the first wave at a peak of 188 cases per day. We controlled the situation after that, but toward to the end of the year, the second wave occurred. This time the peak reached nearly 1,000 cases, and we were overwhelming. The focus on infection this time was Samut Sakhon province, just outside of Bangkok, nearby Bangkok, particularly a seafood market with many foreign workers. This is the map of Samut Sakhon province. The traveling times about an hour from Bangkok to Samut Sakhon. Our EMT Thailand has assigned from Ministry of Public Health to set up a field hospital in Samut Sakhon province. This is a category of the mild COVID-19 cases who were foreigner worker. This time, some places in Samut Sakhon province which were used to the field hospital setting. The top left, this is the sports stadium. Top right is our field hospital in the temple area. Bottom right is a nearly open factory area, which was also used as a field hospital. And bottom left is a temporary field hospital set up in the seafood market, with the focus on the spread of COVID-19. This is the area of Buddhist temple. We use a field hospital. It is normally used meditation site. We also have a survey of area, including the sleeping, eating, washing, toilet, and sanitation area. Our team not do alone, so we had help from the local authority, the Department of Disease Control, the Department of Mental Health, Department of Health Service Support. This is the layout of field hospital area. The green rectangle is the medical team area, and the yellow is the patient area. This tent We were used for the medical personnel operation and sleep also. Behind the fence and around is the patient area. This is a warning sign on the fence saying entering inside is forbidden. On the right side is a contamination bin for the personnel to put away the PPE after doffing off. Inside the patient area, inside the facility, the Army provide bed with the mattresses, pillow, blanket, and on the right is the bucket of personnel item, of the toiletry, washing powder, and 30 December 2020. Our team was deployed. We are only authorized half of our full team of 32 staff. This team consists of the 3 doctors, 2 pharmacists, 3 nurses, and 8 emergency technicians. The latter also helped with logistics also. We do not use the full team to reduce the risk of infection. And we do not require other utility support such as electricity and water. Final preparations were made on 21st December. A computer inside of the compound of communication purposes and part of the team donning PPE uses. The first group of patients, 29 patients arrived and entered the compound. Those with PPE were there in the rest of the team monitored from the operation tent. We use CCTV to monitor the situation all the time. The patient first register, which we used on an online platform to communicate from the outside. We gave each patient number codes, which correspond to the base number. This is to avoid misidentification as we are not familiar with the name in their language because almost a patient is the foreign worker. This is the mapping of bed in facility. We color code the day patient entering the facility so we know which bed will be available once they are discharged. Our daily work routine starts with a ward round. We will use the telecommunication system inside the patient compound. There are automatically blood pressure measuring machine as well as pulse oximetry also. Patient will report their symptoms and we will give the medication accordingly. Besides our medical team, we had other teams work together. The civilian and rapid response team from Department of Disease Control and the Mental Crisis Assessment and Treatment team from Department of Mental Health. We have our daily meeting, usually at night, but sometimes we join meeting with the other team during the day. This is the machine and innovation used which was lent us by the Chulalongkorn University, the engineer faculty. This is the robot used delivering the medication. It is a remote control and this is a tablet attached to which we can communicate with the patient. Throughout the 7 days of our operation, 143 patients were admitted. Most were males, most were young patients, and all were mild cases. All admitted were foreign nationals. There were 3 patients who need to transfer to the hospital. They had clinical changes and need further investigation, monitoring, and treatment. There are the admission statistics throughout the week. These fluctuate depending on the number of the health districts sent to us before. 3 patients were referred, 2 patients were suspect have a COVID-19 pneumonia, and 1 pregnant patient had a hyperemesis gravidarum. The patient was mostly healthy, and so they were able to the activity. They took turn a clean. Okay. They took turn cleaning the area as well as playing a sport in the afternoon. Okay. Besides the physical well-being, we have support from spiritual well-being. As we are in the temple area, the abbot of the temple would do daily round in the morning to visit us and the patient to give blessing. We had a great collaboration with the other sector. The army, police provide security, and NGO donate food and beverage. And sometimes, throughout the period, we had some time to relaxing moment. Enjoy a coconut juice from the local. The Deputy Ministry of Health also visits us and saw how things are. After 7 days, we conclude our mission. Our service was taken over by another provincial team, which arrived a day before to transfer the information from us. It was a mission accomplished for us. What we learned from this experience, the first, nothing is set in stone. We must adapt to ever-changing world. We never thought that our Thailand EMT would respond to an event other than natural disaster. But here we are, responding to the pandemic. Second, collaboration is the key. We could not have pulled it off without working together with another sector. I believe absolutely not. Whatever it is after health sector or non-health sector. At last, it is important to always build experience whenever the opportunity comes. With this, I would like to say thank you for your attention, and I would be very glad to answer any question. If I cannot answer, I have the good helper, Dr. Kesehatan over there, who is also a part of our team. He was with us. I think he can answer for me. Thank you very much. ขอบคุณครับ
Thank you very much, Dr. Nopnani and Mr. Sombun. Are there any questions from the audience from Thailand's experience in their COVID-19 response? Any questions? Yes, Dr. Chin.
Thank you for your presentation. So right now, since the COVID-19, right, the big concern you are talking about, during your presentation, you mentioned about, online consultation, right? Online consultation, like telehealth or something like that.
Yes,
we use that. So who did that? Doctor, medical officer, or nurse, something like that? You can do that, which, give some condition for the patient.
Okay, normally we set a schedule for a staff, one doctor to commander, one doctor to assessment, clinical, and one doctor to ward round, daily ward rounds. And nurse, 3 nurses, 1 nurse for primary screening, and 1 nurse for the PPE uses and cleaning. About the sanitation, when we finish, how to take care, how to take off the PPE, and how to manage about the sanitation, and 1 nurse registration.
Actually, in our country, you had a system like a telehealth, right, or telemedicine. You can imagine like this. So I think it's a very good experience that we learn from your side. But maybe in the future, the pandemic like this happens. So that's a very good such system because you can don't touch patients. That can prevent some kind of transmission that for the disease like COVID-19 as well. Thank you.
Thank you. Thank you very much for your
Okay,
questions.
any more questions for Mr. Songboon? Yes, sir.
Shinichi Egawa from Tohoku University, Japan. And my question is, why was it December 30? The reason I am asking this is the deployment of the Thai EMAT was like an end of year. But it could be faster than that, or you could prepare the field hospital for the dealing with a number of patients. But why was it the end of the year?
Normally, we use a full team for preparation of the fields, and when we deploy to the field for operation, we split a team because when we deploy the full team, we need another logistic, without a full logistic, such as electricity setting, water setting, sanitation setting. But this area, this field hospital, we have all complete of the electricity, or water, sanitation. We use half of a team.
And just let me confirm that who decided to deploy the Thai EMT?
Ministry of Public Health.
Ministry of Public Health
Yes.
decided. Was there any indication from the Prime Minister? Or? Thank you.
Okay, so thank you very much, Dr. Nopmani and Mr. Songboon, for that wonderful presentation. And we would like to thank all our presenters for the first part, from learning the various activities of DMTs of Malaysia in this response to chemical incident, the role of the portable medical isolation unit presented by Singapore, and the role of the COVID-19 response of the Thailand DMT. So thank you very much. At this juncture, we move to three teams who will discuss their experience as an international EMT who responded to the magnitude 7.8 earthquake in the Republic of Turkey. For this part of the session, we will allow all presenters to deliver their presentation first, and we request that they limit their presentation to 12 minutes or less. Then we will ask all of them to come to the stage for the question and answer later on. Our first presenter has the monitoring of data and information of health crisis at the Center for Health Crisis Unit of the Ministry of Health of Indonesia. She will discuss their deployment in Hatay province, which is one of the hardest hit area in Turkey. Please welcome Dr. Hadija Pandita.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning, salam sejahtera buat kita semua. Distinguished expert and all the participants. So I'm here to share with you an overview of the experience of Indonesia Emergency Medical Team in Hasa, Hatay Province. I will describe the experience of Indonesia EMT assisting the Turkey earthquake. Okay. Now, conflict of interest for this presentation. So, you can see the series of a massive earthquake struck southeast Eastern Turkey in the dawn of 6th of February 2023. And you can see more than 100,000 people injured, more than 45,000 death, and more than 430,000 people displaced and more than 9 million people affected our population. And interministerial coordination is held. Indonesian government decide to deploy emergency medical team to assist the Turkey government. The team is sent a week after the earthquake happened, and then 107 people, members, is assembled, comprised from medical and non-medical personnel coming from the health reserve workforce, what we call TCK, tenaga cadangan kesehatan, in order to prepare human resource for Indonesia Emergency Medical Team. Center for Health Crisis, Ministry of Health, as the coordinator of the National Health Cluster, coordinate with the other agency, with the National Disaster Management Agency, Indonesian Army, Indonesian Police, Medical Profession Association, Health Professional Association, and non-government association. This is, we can see the composition of the Indonesian Emergency Medical Team, consists of general practitioner, surgeon, orthopedic surgeon, anesthesiologist, pediatric, ophthalmology, emergency physician, obstetric, and etc. You can see here. And then we have a liaison officer, safety and security officer, and environmental health, data and information, and the logistician. This is our structure of operationalization of our field hospital. Head, we have first head and a liaison officer, at logistic, data information, safety and security, medical services, pharmacy, surveillance, nutrition, sanitary, and forensic. And we have, for the logistic, we have medical logistic and non-medical logistic, and numerous of health services. This is our capacity in the field hospital, outpatient 100 till 150 patients per day, and inpatient 10 patients per day, minor surgery 10 patients per day, major surgery 5 patients per day, and mobile services 50 patients per day. And we can see the side plan of EMT hospital, side plan of the field hospital in the Turkey. And next. Before we are, before the Indonesia Emergency Medical Team departed to Turkey, a briefing was conducted for all EMT member or personnel, which to provide an overview and explanation regarding the assignment of the IMT in Turkey, such as the weather and the local temperature, up to the condition, job description of personnel, and then very important about the safety and the security. And pre-departure, we conduct meningitis vaccination, which carried out for 107 personnel, and effort to prevent meningitis infection, considering that Turkey is meningitis endemic area. Health logistics consists of medical and non-medical logistics, For the example, the tent for health services consists for tent for triage, inpatient, and for the outpatient, pharmacy, and etc. In a room, include tent for the operation, and dormitory tent, logistic, public kitchen tent, common center, portable toilets, portable bathroom, water purifier, electricity generator, and other non-medical logistic. This when was the INAMT depart to Turkey on Monday, 13 February. The ceremony to deploy the INAMT. And then in Turkey, INAMT continue to coordinate with the Ministry of Health of the Republic of Turkey, the province, and then the provincial government of Hatay and Hassa City regarding operational license for field hospital and the types of health services provided by INAMT. The operation of INAMT field hospital received approval from the Ministry of Health of the Republic of Turkey until February 28. And then INAMT also coordinate with EMTCC, Turkey, and also in Antakya, Hatay, to inform and register our team, and then to regularly send a report to EMTCC Turkey. We can see here about the service we do. Number of services are provided such as triage, outpatient and inpatient, medical emergency and surgical services in 11-day operationals of service. Total 2,000, more than 2,000, almost 3,000 patients was treated in outpatient, and number increased a day before. We can see here the number increased the day before the end of operational in Hassa City, operational of field hospital, maybe because the story about the EMT will end of services by end of the field hospital will end the services, spread the community around the hospital location due to the increase was the infected infected by more than 4,400 visited to field hospital. And we can see this, the majority of cases are non-trauma cases, most with the complaint of respiratory problems, maybe due to the weather or others due to a process of dismantling of debris, which is still ongoing. The total number of emergency patient is was, you can see this 70 people, examination of pregnant women and productive health for women. Total number of pregnant women who receive antenatal care was 99. This is our services, mental health, examination and management, as well as psychological support to the community and the children in location around the field hospital, conducting psychological assistance services for the children affected by the earthquake in the form of games and storytelling, recreation activity, and 560 children was received psychological assistance. The number of patients with mental health problem served was 32 people. Patient, the number of patients with mental health problem. Okay, and we patients have received a radical. The 30 patients have received the radical examination, and then operation room was prepared. However, this the patient got surgical services. That is the minor operation, because most of the patient that needed surgical intervention had been carried out the nearby referral hospital by local government. This may show the ability of the Turkey to establish health the facility. And then in 1 week we can see it. This is the termination of INA EMT, that the end of operational field hospital Indonesia grant a field hospital to Turkish government. The ending was marked by the signing a report on the Indonesian field hospital grant from the Indonesian ambassador to Turkey to representative to the Turkey Ministry of Health. The challenges, the weather, Turkey has a different climate compared with Indonesia, especially in February. Turkey is a winter season. And then our challenge, the next our challenge is availability of supporting infrastructure. In the first week, the logistics such as clean water, electricity, and hot toilet is still lacking. The conclusion, overall, the mission was a success with the minor setback. In our evaluation, a better self-sufficient team, a better self-sufficient team capacity, including as well as increasing cooperation with local authority, are needed to improve disaster response. Thank you.
Thank you very much, Dr. Pandita, and we'll serve the questions later. Our next presenter is a nutritionist dietitian from the Health Emergency Management Bureau of the Department of Health of the Philippines. She will present the experience of the Philippine Emergency Medical Assistance Team, or the PMAT, in Adiyaman, Turkey. Please welcome Ms. Janice Feliciano Calixtro.
Good morning to everyone. On behalf of the members of the Philippine Emergency Medical Assistance Team with Dr. Danak and Sir Eric around, I'm pleased to present to you the experience of PMAT answering the call for humanitarian assistance. So in the next 15 minutes, I'll be sharing with you why did Philippines organize its own emergency medical assistance team, what is PMAT and the package of services that we provide, and our deployment experiences, particularly in response to the devastating Turkey earthquake. We also will be sharing with you some slide on our contribution to global disaster health management and our way forward. But before I do so, there's no conflict of interest that I need to disclose for this presentation. If you would know, Philippines started organizing PMAT based on our learnings during Typhoon Haiyan in 2013, wherein we accepted several international teams from 57 countries, and in total we received 150 emergency medical assistance team. Of these 150 emergency medical assistance team, only 83 were registered and 67 did not register. And because they did not register, they did not submit reports to the Department of Health or to the World Health Organization. We don't know their capacity. We don't know the services they provided. Some are not self-sufficient. And so because of that, as a country, we learned three things. One is we need to institutionalize an international EMT registration and coordination system. There's also a need to have a common standard procedures across stakeholders and information dissemination to all actors and players. And lastly, we need to capacitate our own national team in order to respond to local emergencies and disasters. And so, based on the Typhoon Haiyan experience, we were introduced of the EMT initiative by the World Health Organization. And thus, as envisioned by the EMT initiative, countries such as the Philippines, because we ranked 1 in the latest World Risk Report, we developed our capacity for national response. So what we have in the Philippines is a 31-man team composed of doctors, nurses, emergency medical technicians, midwives, social worker, nursing attendant, pharmacist, drivers, cook, electrician, logistician, data manager, admin personnel, and finance. We currently have 2 to 3 pools of EMTs from the 3 DOH hospitals, and each of them has an estimated 6 to 9 team members. So PMAT is a type 1 fix, which has a staff for the provision of basic and advanced healthcare for a limited period of time in existing temporary structures like field hospital. In particular, PMAT provides daylight hours of care for acute trauma and non-trauma presentations, referrals, and for ongoing investigation or care and community-based primary care in an outpatient fixed facility. It is designed to cater to 100 outpatients a day, as mentioned in the EMT Blue Book. Among the services that we provide includes initial wound care, basic fracture management, basic outpatient chronic care, minor surgical procedures with local anesthesia, basic outpatient testing, rapid diagnostic, and others. Note that because we're EMT type 1 fixed, we don't have the capacity for intensive care, for blood transfusion services, for medical imaging, and for reporting. In addition, the PMAT operates on a daytime, but it is capable of providing life-saving care overnight for emergency cases. As mentioned and as discussed by Dr. Danak yesterday, PMAT is not designed just for international deployment, but more so importantly for local deployment, as mentioned by Dr. Danak. Planned events such as SEA Games, various earthquakes, and various typhoons that happened in our country since 2019. Very recently, though we're not yet verified by the WHO, it is a privilege for us to provide assistance during the Republic of Turkey earthquake, particularly to the people of Adıyaman. It is a combined personnel team from 2 DOH hospitals and from the Health Emergency Management Bureau. In your screen is the summary of our Turkey deployment. So on the same day that the earthquake struck the southern part of Turkey, around 7 o'clock in the evening, the Philippines, led by our National Disaster Risk Reduction Management Council, or NDMO, met to plan to offer assistance to the Republic of Turkey. And the deployment would include a combination of a search and rescue team and emergency medical team. The following day, upon approval of the President of the Philippines, we submitted the offer of assistance, and on the evening of the same day, we received the acceptance from the Republic of Turkey. And then the following day, the 81-man team composed of 51 personnel for the search and rescue team and the 30-man team from the emergency medical team headed to the Republic of Turkey. It took us 2 days to arrive to our assigned area, to the province of Adıyaman. And so, on February 11 to February 25, we had our 14-day operation. And then, but the mission lasted for 21 days because it includes travel time. On our way back to the Philippines, or upon arrival to the Philippines, we also had several activities, and that is along after-action reviews, mental health services, health assessment, resupply, and repacking works. And until now, we're still revising our standard operating procedures based on our learnings during the Republic of Turkey response operations. Apologies if it's too small. So during the 14 days, we were able to cater to 1,022 patients. Note that no patients were recorded under admission, dead on arrival, dead within the facility, and those that requires long rehabilitation. Similar to what Indonesia shared, majority of the outpatient that we've seen includes acute upper respiratory infections, various injuries and disorders of muscles and others. And we are happy to share with everyone that we have been consistently reporting to the EMTCC on a daily basis using the MDS. Part of our standard operating procedures is the conduct of patient satisfaction survey. So what you'll see in the screen is a simple survey tool that we converted to Turkish language and with photo illustration for the patients to easily understand and for us to rate. And we're happy to share that a majority of the patients rated the PMAT service as excellent with 97.4%, while only 2.3% of the patients rated as good and 0.3 rated as average. It was also notable that none of the patients rated the service as poor and very poor. Now, each day, in order to boost the morale of the team, we discuss this in our daily meetings at night, and the results of the patient satisfaction survey, including the comments as you've seen in the screen, and we also post this in our operations center. Also, during deployment, we have several mental health activities being done, celebrating Valentine's Day, birthday of Dr. Danak during the response operations, and several others. We've also experienced various quality assurance visits from the Ministry of Health, from the Ministry of Foreign Affairs, including those that is led by the EMTCC, led by Dr. Kubo. And it's also an opportunity for us to share during the quality assurance visit, the PMAT information system that we've been developing, and we have piloted in several local deployments. During the 14th day of our operation, we were able to endorse all the documents needed by the Ministry of Health, and that would include all the patient records, all the EMT daily reports, all the customer satisfaction surveys, copy of the exit report, which we've also shared to the EMTCC, the list of patients and the list of donations. And upon close coordination with the Ministry of Health, the remaining drugs, medicines, and medical supplies and tents were donated, amounting to $28,178 US. Also, please note that as early as day 4 of our operation, we did prepare a deployment plan in coordination with the Ministry of Health. Some of the challenges, as also mentioned by our colleague from Indonesia, is extreme cold weather to as high as -8 degrees Celsius. Despite the team having layers of winter clothes, sleeping with our winter shoes on, it's really cold. And this is the photo of our first night in the camp. So majority of the team just went out, have spent time in the bonfire as early as 2 a.m. Other challenges we experiences would include language barrier, but Google Translate application helped us together with the volunteer students that we have in the camp. Also, we experienced challenges in source of water and wood, and of course there are closed stores in the area. But we're lucky that the location of the team is just across the location or the same location as the Turkish army, so where we coordinated for water and for wood. We also took the time or the opportunity in the field during the last 3 days of our parade, which are attended by the members of the PMAT and led by Mr. Eric Jan Capito. So during this activity, we evaluated our processes in terms of pre-deployment and pre-deployment and deployment area, or the pre-mobilization and mobilization phase. Wherein, at this point, we discussed what went well, points for improvement, even if we're still in the field. And so the next video will share with you our experiences in the Turkey deployment.
As Filipinos, it makes us proud that our country, the Philippines, readily responded to the call. In solidarity with the international community, we were able to quickly form our humanitarian contingent, as we are never short of men and women who have no reservation about facing danger and overcoming odds just to extend the helping hand and bring comfort to those in need.
Isang karangalan po ang tumayo dito ngayon sa harap ninyong lahat para po magbigay ng papuri sa ating malulugod na bayani. Hindi lamang po oras ang sinakripisyo, kundi ang kanilang mga sariling buhay sa pagtungo sa Turkey upang tumulong dito sa emergency response. Hindi nyo lamang po na ipamalas ang tunay na kabayanihan sa ating mga kapatid sa Turkey kung hindi pinakita nyo rin po ang taglay nating kakayanan bilang mga Pilipino dito sa urban search and rescue at essential medicine, medical and public health services. Ngayon pa lang po, nakikita natin lahat, sumasagot po kami sa inyong lahat.
Give me the chance to be here today. We want to thank you from our heart so beautifully that you guys came here without any obligation. Nobody pushed you guys. Your country sent you here. You served, and you are our heroes in our hearts.
Thank you. So, in the team is Dr. Danak being the team lead, and Sir Eric is the assistant team lead. So, this is my last slide. So, globally, PMAT has a fair share of contribution. So, we have partnered with Ethiopia twinning program, where we provided assistance to Ethiopia to start organizing their team. We have shared these experiences during the recent EMT Global meeting in Armenia. And it is also in the said international meeting that PMAT participated in poster presentation of our local response operations. In addition, in 2021, We are happy to share with everyone that though we're not yet verified, PMAT from Dr. Jose N. Rodriguez Memorial Hospital and Sanitarium received the Honorable Mention Award from the International Hospital Federation Awards in recognition of the excellence in healthcare as a result of the response to the Taal volcano eruption. PMAT also participated in several international drills and exercises, and we have hosted the regional collaboration drill in the Philippines in 2018, and we have participated, provided technical assistance in several policies and guidebooks that's developed globally and in the ASEAN level. And lastly, as I mentioned in my first few slides, we started PMAT because of what we learned during Typhoon Haiyan in 2013. And this year, 10 years later, we are happy that from a country who is a recipient of assistance, we can now return the favor to the world through PMAT deployment. So with that, on behalf of the PMAT members, thank you for this opportunity to share with everyone the story of the 30 strong men and women of the Philippine Emergency Medical Assistance Team during the earthquake in the Republic of Turkey. Thank you, everyone.
Thank you, Ms. Janice, and for that wonderful presentation. And at this juncture, our last presenter is a member of the Japan Disaster Relief Medical Team, an associate professor of Department of Emergency and Disaster Medicine, Huntendo University School of Medicine, Graduate School of Medicine, and a consultant of Emergency Critical Care Medicine, Huntendo University, Narima Hospital. Please welcome Dr. Jiro Oba. He will not dance at this time. He will dance later.
Thank you very much, Dr. Danak. Thank you very much, kind introduction. Selamat pagi, apa kabarmu? I would like to thank you for giving me the opportunity to present at this wonderful conference. I am Jiro Oba. I'm an emergency physician, also an orthopedic surgeon. And also, I am a member of JDR, Japan Disaster Relief Team's members. On behalf of the JDR, I will present our Turkey mission. I took part in our team's Turkey mission as a medical leader of our first dispatch. Let's get started. Oh my gosh. Okay. No sure to disclose. Okay. On February 10th, advanced team including Tatsu and Yoshi and Tomo and Yutaka and 3 members is support EMTCC. They provided support in various aspects, including information management, and particularly in the organization and analysis. You can see this MDS part here. Our first teams was dispatched about 1 week too late after disasters occurred. This is an EMT support map, February 23rd. Many teams, including those from Indonesia and PMAT, and PMAT teams are operating in Adiyaman. Japan has a rescue team working in Adana, and JDR EMT, our teams, are conducting operation in Gaziantep. Our total teams were active until March 24th. The location where support were provided in Ozeri district in the Gaziantep province. The only one healthcare facility in this area was the Ozeri State Hospital, a very, very small hospital with only 20 beds and no surgical and no obstetric gynecology department. Following the earthquake on February 6, the structural damage occurred in Ozeri State Hospital, resulting in non-functional. Additionally, nearby clinics were also unable to provide medical service. The nearest major hospital in Gaziantep required 1 hour by car, too far from this region. Next slide, please. Okay. On the day of the earthquake, you can see the man is Dr. Sedat, director of Ozeri Hospital, swiftly issued a statement of the hospital Twitter account. He announced the establishment of the temporary clinic. You can see this, the Ozeri Vocational Technical Technical Anatolian High School. They are only provided emergency medical cares. Desperate to protect this area, he worked with the hospital staff provide medical care 24 hours per day. They primarily focus on just only to internal medicine and pediatrics, while severe cases and trauma cases transferred to the Gaziantep by car, very long trip. When we arrived in February 13th, 1 week since our earthquake, they had been attending to 200 or 300 patients daily. The hospital staff, all hospital staff was exhausted. So Dr. Sedat were resolute in this desire to provide care to patients in this region. The space was sufficient for EMT type 2 operation. And after discussion and obtaining permission to use the space in front of a temporary, we determined it as an operation site here. We set up a campsite 5 minutes walk from operation site. This is a movie from a camp to our site. Okay. This mission is the first time mission, our JDR Type 2 as EMT Type 2. We are able to collaborate with several self-defense force to carry out the transportation of goods materials exceeded 13,000 kilograms. And with cooperating with the local staff and people, we carried out unloading operations. Even during the night, we borrowed an excavator car and worked together as one team. We are able to started medical care within 48 hours of unloading, and the operation room and ward functionally started 72 hours later. Next slide, please. Okay. This is a footprint of our operation site. The total area is 14,500 square meters. You can view our site in detail by this QR code on YouTube, if possible. Yeah. We can make a medical site virtual tour. You can view our site manually in detail by this QR code. Right side, left side and in Japanese, right side in English, okay? Within the JDR operation site, we actively collaborate with the local staff. We simultaneously operated both the JDR MOS, is a computed operating system, MOS system, and the Turkish patient information aggregation system with our site. Since the disaster struck, there was a significant demand for examination and X-ray examination, but because they could not conduct within a temporary clinic, we made every effort to provide 24-hour service whenever possible. During the peacetime, the patient, trauma patient, pregnant patient, and dialysis patient were typically transferred to Gaziantep from this area. So it was essential to establish a strong trust and rapport to enable to direct Sedat to make decision, like in our medical site in this region, we can handle such patient. In temporary clinic, they are primarily focused on internal medicine, just only pediatrics. So our team mainly support emergency care and orthopedics and general surgery, pediatrics, obstetrics, gynecologists, including our teams have special staffs for each disease, for each programs. So this chart illustrated each deployment timeline, the number of the persons sent, including drivers, interpreters, or local staff that actively working on site reached over 100 members per day. The total number of official number member is 181. Next slide, please. The next part, the clinical part. Next slide, please. Okay. This light upper chart presents the medical performance on the first dispatch team. You can see this, I'm so sorry, it's too small chart. The blue line is a number of a patient, and the orange line, the examination, the number of examination, and the gray line is the X-ray examinations. So the second day of our medical operation, next please. A trauma patient was processed by ambulance. You can see this, the center is a local staff, local physicians. I think it's a very important to collaborate with the local staff. And also patient did not survive, since the gratitude was expressed, especially from the director said that. During the funeral procession, all team's members observed the moment of silence. We maintained the respectful and honest attitude throughout. Initially, Dr. Kesehatan said to introduction for immediate patient, the very severe patient is from this area to the Gaziantep by car. So we maintained the competency, upheld senior medical care, held a daily meeting like this, and engaged in discussion about case to gradually build mutual trust. Mutual trust is very important, I think, between our teams, between each teams. The trust continued to deepen. I will show the first surgical case on our site. An 11-year-old boy, a fracture of a proximal phalanx on the left finger, and presenting the need of a surgical intervention due to very short rings. The hospital capable of performing surgery was located in Gaziantep. So the patient is needed to the Gaziantep for a long time, and after post-operating follow-up was also needed. So we consider the conducting the surgery as a JDR medical site could resolve these geographical problems. So before the operation, we talked to the doctor said that in addition to the performing the surgery, we need to alongside a local orthopedic surgeon because we could provide follow-up care. That patient is needed follow-up cares. So even after our teams have withdrawn. So father, his father, the son's father here also expressed his desire for the surgery to be conducted at our site. So with the director decision, it was decided to proceed with the surgery there. The father provided written commitment and consent was obtained from JDR teams and consent also the Turkish side. The director said that expressed his trust in Japanese cares, which resonated deeply and strongly our heart. So before the surgery, we always review the response plan. It's very important on the affected area because of any potential earthquake or emergencies. The surgery was performing under general anesthesia. The procedure proceeded smoothly without any complications. Both the patient and their family were extremely pleased with our outcomes. So third teams removed the fixation pins performed. This is a 24 days activity. The JDR medical teams provided medical care about 2,000 patients, conducting surgery, including X-ray examination, rehabilitation also. Next slide, please. Okay. I think it's very important, the interpreters. A total interpreters, 43 interpreters. They work with us interpreters are also there as drivers, work as drivers, despite being victims themselves. We are sincerely grateful for their cooperation. For interpreters are essential for EMT type 2 mission because of involving invasive procedures. So we need to provide us as psychological support to them. Post-mission is also crucial. Next slide, please. Next slide, the logistic part. So total 100 tents were set up by ourselves. The area, you can see this, the surrounding the fence, so safety management is adequate. So you can also see that all weather soccer field on campus, cold weather precautions are also essential. And we effectively manage approximately 35 generators. We achieve the operation of water prepares, water, WOTA, so we can get a high price from WHO, the quality assurance visit. We are able to establish a system that matches the local environment. We absolutely need to discuss waste management with local staff in advance. Sorry, next slide, please. Okay, this slide for WHO leaf certification. Negotiations were conducted locally to secure the opportunity for on-site quality assurance visit. The last part is a mission summary. At this part, the disaster, the social media account, the Ozeri State Hospital, were filled with a word of gratitude to our teams. I will show one comment on February 26th. This is about the first operation. So operation well done, and thanks to my friend in Japan. This comment is very impressive to our teams. Furthermore, one social media of Ozeri State Hospital, it was announced medical service. At first, the Ozeri Field Hospital just only to focus on the internal medicine and pediatrics. After our collaboration, you can see this is the Turkish language here. So the announcement indicated in addition general internal medicine, they are capable of providing service in obstetrics, gynecology, orthopedics, general surgeon, pediatrics, and more. We think it was a moment when we felt we could continue providing medical care with a sincere attitude for earthquake victims, some evacuees, and the healthcare workers, those who are supporting them since the disaster, gradually building trust and working together, so we will be at one team. So last, I will show the 4 topics or characteristic achievement of Turkish mission. First one, EMT Type 2 initial deployment, we efficiently use civil defense, Japan civil defense for the aircraft for transportation over so heavy equipment. We operated night shift to ensure the continuous support. The second one, active participation in internal coordination. Our team members, including Tatsu and Yoshi, contributed to international effort to deploying our teams to the EMTCC. And fostering global collaboration in disaster response. The third one, very strong local connection. I think is very important. We prioritize close cooperation with the local medical facility and deeply respect for a local healthcare system. This including establish a physical presence in the area, holding daily meeting, offering consultation in basic medical procedure, and facilitating referral when we need it. So we also embrace the use of a Turkish ID. It's also important, I think. The final one is a commitment of quality assurance. Our team has successfully underwent the quality assurance visit process on site. So finally, every time we provided assistance in the affected area, we are kindness of our people in the countries. So gratitude from a local resident and smile of our children always served as a source of encouragement and support in our work. We sincerely wish Turkey a speedy recovery. Thank you very much for your attention.
And that ends our presentation. Thank you, Dr. Oba. And we'd like to request our presenters, Dr. Pandita, Ms. Janice, and Dr. Oba to please come up the stage as we prepare the chairs for you. And we'll have the question and answer. So we have consolidated the time, so we have about 10 minutes for this portion. Okay, so we'd like to request Dr. Pandita, Ms. Janice, and Dr. Oba to please come up the stage. And the floor is now open for questions. I'm sure you have a lot of questions, and we have lots of hands raising. So we'll go first with, yes, please introduce yourself from Vietnam.
Good morning, everyone. I'm Dr. Dũng, I come from Vietnam. I'm a member of the EMTs Vietnam, come Turkey after the 1 week, disaster happens. After the earthquake disasters happens in Turkey, Vietnam government, Minister of Defense and the MOBs of Vietnam forms a working team with 67 people, includes the militaries in energy and professional dog team and the EMT Tip 1 came to the Turkey for the rescue and find the victims who were still in the Zapla. I understand clear and sympathies with everything you done in the Turkey. I have questions for the Dr. Pandita, come from Indonesia. The first, you can talk more about the logistics. That when you come, medical response in disasters in Turkey. That's the first question. The second question, I would like to know according to the WHO EMT's classification, which the EMT is which types of EMTs according to the EMT's WHO EMT's classification. Thank you.
Dr. Pandita?
Okay, thank you. For the first question, you asked about the logistic. Can you repeat what is your question? I'm not clear.
Because for the medical response, a long time in the Turkey, with my teams, we should carry many goods for the logistics, medicines and medical equipment. You talk more about all things you carry to the Turkey. Please.
So you're asking about how they handle the logistics.
They handle the logistics
during the long deployment.
About the transportation. The logistic brought to the Turkey by the airplane, because we are charter the plane for the Indonesia, special for bring the logistics. So it means we can respond quickly if the logistics we bring by the plane. And then some on logistics we work in Turkey, and some we work from the Indonesia. We take the take it from Indonesia.
And the second question is your WHO classification.
Yeah. The second question, our EMT we deployed to the Turkey. The classification is EMT type 2, but now we are going process to register and certified. So our EMT is not yet international certified by WHO.
So it's not yet verified, but operating as type 2.
Yeah, that's our priority.
Thank you. So thank you, Vietnam. And any more questions from the floor? Yes, please introduce yourself.
Thank you. My name is Melisa Ramadhani from Universitas Indonesia Hospital. Thank you for your presentation. Due to my background is occupational health practitioners, I will ask to three of you about how do you manage the occupational health for your team members, medical or supporting staff during your operational in Turkey. What if there is a needle stick injury or any kind of incident, or maybe your member getting sick or exposed to the virus during their services in there? And then if there's any member that in charge in occupational health and safety during the operation, considering the limited number of your staff there. Thank you.
Thank you. So we'll start with Ms. Janice. Issues on what is your team's outlook on occupational health?
All right. Thank you for the question. For the Philippines, part of our standard operating procedures is that we have a designated safety and security officer, which looks into the welfare of the entire team. Also, in the PMAT, we have a buddy-buddy system wherein each one would look into the welfare of his or her body. We actually had an experience of a cook having a fever during the first few days of the operation. So we had to make sure that the cook, with Dr. Danak as our team lead at that time, we had to make sure that the cook would rest, that the clinical lead would take care in terms of checking the cook in terms of the fever. And then the staff, the member of the logistics officer took the role as a cook. So that the PMAT members, particularly in terms of the logistics staff, is not just is capable to make sure that he can do other tasks aside from the tasks given to him. Also, we make sure that we have team welfare. That's why even if it's as early as 6 o'clock in the morning, we do find time to have an exercise, making sure that in each of the daily meetings, our team leader would check on the team members in terms of their welfare. So that's what we do, and as part of our standard operating procedures.
Thank you. How about Dr. Ova? What's your JDR's experience?
Thank you very much, Dr. Danak. Yeah, the security point. So in disaster time, in the security is very important, I think. So firstly, you can already know the CSCA TTT command and control is very first priorities, and second, the security is, I think. The security is, fortunately, our site is surrounding around the high fence, so the security is adequate, I think. But our teams have always to decided to the security officers. Security officer is always to support the management of security and safety. So security officer we have a check chat. We have a document, JDR book. This is the principle about our department. So we have all leaders, all department leaders have original check chart. So all original, department leader has a check chart, and so they can, the management, sometimes they forget some information, some management, for they check the all times. So the next is how to manage so many people, personnel. So our site is confusing, sometimes chaos, is so many members, except for the members for the foreign international EM teams comes, and some politicians comes, some media is come. So the patient is a 20 bed here. So many the patient family is come our teams. So in your side is sometimes chaos. But I think is a gate management very important. So and the flow, patient flow, and the visitors flow is important. And I will check the visitor to use like this card, visitor's card. So we'll check the card. And we also the management important interpreters, including local staff, drivers, and also. So command post is very important, I think, in the disaster response. So in peacetime, we have a plan to how to manage so many persons, so many local staff, so many the other facilities. So command post training, we are always training every time.
Thank you.
That's it.
Dr. Pandita?
Yeah. That is very important to implement an SOP and job description, clear of job description each personal, and then same with the Philippines and Japan. Very important about the we are in briefing before we are going to we went to the Turkey about safety and security. Each member now and can implement to protect themselves. And then it's very important about the structure, command and control, and meeting regularly is very important to update and the manage of the team.
Thank you. So being a WHO EMT verified EMT team that follows WHO standards means not just about treating patients, but also making sure that we look after our healthcare workers. Any more questions? Yes, Dr. Donahue.
And I have not so much a question, but a comment. I thank you for your contribution. This was insightful and instructive. But Janice, you mentioned one thing that stood out to me was on return home, the health assessment. And I would suggest that a follow-up, a subsequent assessment occur 90 to 120 days later, because many issues do not show, either physical or psychological issues don't manifest when they're first coming home. And my experience is when you're at the airhead and people are getting off, they will lie to you because they want to go home. They will say, I'm absolutely wonderful. So my recommendation is 3-4 months later, come back to the team, ensure their wellness, and make sure they're ready for the next mission.
Thank you, Dr. Dan.
It's not part of the presentation, but we actually had that. A few months after the deployment, we had our mental health and psychosocial support service activity for the entire team. But we'll include that in the presentation. Yes. Thank you.
Yes, Dr. Ikeda. Mr. Ikeda.
Thank you very much. My name is Ikeda, and thank you very much for your very impressive presentation. Yeah, in presentation, encourage many of our participants here. Next is ours, us maybe. And my question regarding to the the challenge for the collaboration with the local community for your operation. Actually, the involvement of the local community, including about the local professional, medical professional as well as interpreter, is very essential for the effective operation of your EMD. Doctor, I'd like to ask all of you that the doctor oversaid that you hired 42 or 3 interpreters. How did you recruit those kind of many number of the interpreters for your team? And also you could have the very good connection with local hospital director. How you could get such kind of the very good resource for your you get advice from him. And maybe both of you, other presenter, I would like to ask how did you get the interpreter, or did you get the advice from the local professional? The Janice says that maybe one of the possible areas is a medical student. Maybe I'd like to hear about your experience. Thank you.
So we'll start with Dr. Oba.
Thank you very much, Dr. Ikeda-san. Thank you very much. I think it's very important to look on how to collaborate with the local staff. Very important because our team just only to focus on the emergency case, emergency phase, just only to one month, and or our teams to the 1 or 2 months, just only to support this region, just only the small, because very short times. Now is a Turkish. Now in our countries, 2011 the big earthquake occurs. Now is some people, affected people is some have problems. So after we are done, we are ended to support this area. We need to hand over. We need to the patient hand over the information for patient information. Very important, I think, and I think. Most important, EMT type 2, we need invasive procedure. Sometimes we need the amputation. It's very stressful for affected area peoples. Not only affected area people, but also in peace times, we are very stressful. So we need to very kindly, very respectful for medical health care, local medical health care personnel, and talk with the patient, very important. So at first time, fortunately, our teams, advanced teams, Dr. Tatsu and Tomo is connected is local hospital, Dr. Sedat. But Dr. Sedat is a very important person, a very key person in this area. He has a very responsibility for keeping this healthcare system in this area. So we are always to express for sincere attitude and respect for their cares. So I think just only I think is very important. I think so. EMT type 2 that we can do the surgery and we can do the high dialysis, but I arrived 1 week later in this area. No surgery, no treatment here, but we want to, sometimes we want to do a surgery, but it's not important. We discuss about a key person is a Dr. Sedat. Dr. Sedat want to do this area. So his request is priority is very high. So how to support this area, how to engage in this area, our teams always discuss. It's very important, I think.
Thank you, Mr. How about Ms. Janice?
A straight answer is that we did not hire volunteers. We're very lucky that there are a lot of volunteers in the province of Adiyaman. So it's the Ministry of Health that assigned us to a one main volunteer. And then the volunteers grew as we did the operation. We had volunteers from students, we had volunteers from landowners that are coming to our camp and say they wanted to volunteer as interpreters. So most of our volunteers are just for interpretation of the, talking to the patient and the doctors. So that's about it.
Yes, Dr. Pandita?
And we involved the Indonesian students provided by the embassy and to communicate with to handle the lack of language. So the students from the Indonesian and the people from the Indonesian as ALU.
Thank you. Well, I wish we could entertain more, but in the interest of time, we have to end the question and answer. And we would like to thank our speakers, Dr. Pandita, Dr. Oba, and Ms. Janice, for their wonderful experiences in their deployment in Turkey. And I'm sure it has inspired a lot of our healthcare workers who are advocates of disaster health management to be part of the disaster management in our in future deployments. At this juncture, we would like also to call in front to the stage our other speakers earlier. We have Dr. Resdan, who presented from Malaysia, their chemical spirits. And we'd like to request the three of you to please remain as we give you the award. The second is Dr. Darius Webb from the National Center of Infectious Diseases of Singapore, and Dr. Nopmani and Mr. Sombun from Thailand. And to present the plaque is thank you.
Thank you very much, Mr. Moderator from the Philippines, Alfonso C. Danak. May we give a round of applause for our moderator, ladies and gentlemen. Thank you very much indeed. And again, we would like to use this opportunity to present our tokens of appreciations to our wonderful array of speakers for session 4 today. May we again invite onto the stage, please join us from Malaysia, Singapore, Thailand, the Philippines, Indonesia, and also Japan. Kindly join us on stage front and center, please, speakers. And to present the appreciations, may we kindly invite onto the stage the Chair of Regional Coordination Committee of DHM Singapore, Mr. Edwin Goh, to present the tokens. And first of all, we'd like to present our token of appreciations to a representative from Indonesia. May we have Miss Hadija Pandita, please. Thank you very much. May we now move a little to the first line there, from Malaysia to Mr. Rashdan bin Rahmat, please. Terima kasih. Thank you very much, sir. Our appreciation to you. And next to Mr. Darius Bey from Singapore. What an insightful presentation. And we appreciate experience sharing from our friends from the Philippines, Ms. Janice F. Calixtro. And from Thailand, may we present to Ms. Panjal Supasombun. Thank you very much, sir. And also another colleague from Thailand, Dr. Nopmani Tantivasa Ruangdet. And last but definitely not least, may we present our appreciation to our colleague next from Japan, Mr. Jiro Oba. As for Mr. Alfonso C. Danak, we believe we have presented you with our appreciation yesterday when when you were a speaker for the first sessions, but would like to hand another one on the stage anyway. Thank you very much. Salamat po. Thank you very much, our colleagues from Philippines. Front and center, Mr. Edwin at the center for a group photo. And come closer, please, speakers and moderators. On the count of 3 to the master of photographers at the center. 1, 2, 3. One more time, 1, 2, 3. Let's hear it for session 4 of our conference, ladies and gentlemen. Thank you very much. And with that, ladies and gentlemen, we now invite you to enjoy your lunch. As always, it's already been served at the El Patio restaurant of the hotel. We have a little bit of over an hour break, so we'll reconvene for session 5 at 12:30 local time. We wish you a wonderful lunchtime. Thank you very much. Delegates, ladies and gentlemen, we are delighted to announce that we will begin the next sessions in just a few minutes. May we invite the rest of our delegates who are still outside. Please take your seats in the ballroom. Session 5 is about to begin very shortly. Thank you. Distinguished delegates, ladies and gentlemen, welcome back to our conference here in Yogyakarta Special Region. After the much-needed lunch break, we hope that the lunch has whet your appetite and replenish our energy to continue on with the rest of our sessions for today. And without further ado, ladies and gentlemen, it is my pleasure to welcome you to session 5 of the conference, which will shine a light on regional collaboration mechanism on DHM. It's about sharing the situation of other regions. And may I present our moderator for this sessions from ASEAN Secretariat in Jakarta, which is now known as the headquarters of ASEAN. Ladies and gentlemen, please give a warm welcome to Mr. Jim Katampongan.
Thank you, MC. Good afternoon. Good afternoon. Thank you very much, MC. Good afternoon again, distinguished delegates, speakers for this second ASEAN Academic Conference on Disaster Health Management. Welcome to the 5th session, which will be around the Regional Collaboration Mechanism on Disaster Health Management. It is my pleasure on behalf of the ASEAN Headquarters to moderate the session. I had the opportunity to accompany the ASEAN health sector in its journey in strengthening disaster health management, which was one of the strategic health priorities of the ASEAN health sector under its ASEAN Public Post-2015 Health Development Agenda for 2016 to 2025. So, in fact, I can recall that my first meeting, the first meeting that I attended, as soon as I joined the ASEAN Secretariat during that time, was the first meeting of the Regional Coordination Committee for this, or for the ARCH project, not yet the RCC for Disaster Health Management. That was end of September 2016. So 7 years after, one can confidently say that significant progress have been made. And it's something that we have to celebrate, exchange those developments during this meeting. So with regards to disaster health management, our collective aim is to protect and save lives and livelihoods, alleviate suffering, as well as build and strengthen resilience to various risks. We know that the disasters happen in communities, they affect communities, and the local and national governments have the main responsibility in addressing the needs of the affected population. However, disasters are also getting frequent, devastating, and more complex, and may overwhelm countries, even the more developed countries. Hence, as part of the collective aim, the international community has envisioned of setting up seamless mechanisms that will enable local, national, regional, and global actions to work together to prepare for, respond to, and recover from disasters, including strengthening their resilience. This is critical for ASEAN, which is one of the most disaster-prone regions, as has been mentioned many times during this conference. So as part of the ASEAN-wide effort, this session will hear updates on ASEAN health sector efforts to strengthen disaster health management at national and regional levels, which are aligned with global frameworks and instruments. We will also hear collaborative efforts from the health sector from other regions, particularly Americas, and through colleagues from Costa Rica, and then other regions through colleagues from the WHO. So this session has two parts. The first part will be presentations from 5 esteemed presenters. They will have 15 minutes each, and then that will be followed by a 5-minute quick question and answer. The second part will be a panel discussion wherein the speakers on stage will exchange ideas and insights on the challenges that they have experienced in pursuing regional level collaboration efforts. So without so much ado, let's start with the presentations first. As mentioned earlier, during this conference, the ASEAN health sector is implementing an ASEAN Leaders Declaration on Disaster Health Management. The ASEAN health sector now is operationalizing this Leaders Declaration through the matrix of detailed activities that has really outlined what are the priority activities to operationalize the declaration. So this will be a joint presentation from the Philippines as well as Thailand, which are the core group members under the Regional Coordination Committee for Disaster Health Management assigned to develop the draft this matrix of detailed activities. So allow me to introduce the two speakers for this presentation. We have the point person for emergency medical team mobilization of the Department of Health of the Philippines and the senior lecturer at the Centro Escolar University, Ms. Janice Calexto. And then the presentation will also be delivered by a representative from Thailand, Thailand's being the Regional Coordination Committee Secretariat, and he's also the emergency physician from Chiang Rai Pachanokrop Hospital, and that's Dr. Krengsak Pentatham. So kindly join me in giving them a big round of applause. Thank you.
Thank you, Mr. Jim. So good afternoon to everyone. As mentioned, this session will be presented by Dr. Krengsak and I. We're happy to share with you the matrix on the detailed action for the plan of action to implement the ASEAN Leaders Declaration on Disaster Health Management. In particular, I'll be sharing with you the background while Dr. Krengsak from Thailand will be discussing the status of the 5 priority areas. Both Dr. Krengsak and I doesn't have a conflict of interest to disclose with regards to this presentation. So at the ASEAN level, disaster management started years ago. So we learned from the various devastating disasters that happened in 2004 in the Indian Ocean earthquake, 2008 Cyclone Nargis, and 2013 Typhoon Haiyan. So thus, in 2019, we are united by a common desire and collective will to jointly respond to disasters in the ASEAN region as articulated in the ASEAN Agreement on Disaster Management and Emergency Response. And in 2011, to realize the unity of effort with the spirit of one vision, one identity, and one community, the AHA Center was established. And in 2014, in order to achieve a faster response, mobilize resources, and to establish stronger coordination among the ASEAN member states, we do support and agree on the declaration of one ASEAN, one response, ASEAN responding to disasters as one region, as one in the region and outside the region. And to support this one ASEAN, one response, what we have is the ASEAN Leaders Declaration on Disaster Health Management, which was adopted during the 31st ASEAN Leaders Summit in November in Manila. And this declaration calls for urgent action to strengthen disaster health management system, both at the national, meaning at each ASEAN member states, and at the regional level, which are very critical for us to improve health outcomes from emergencies, to minimize health hazards and vulnerabilities, and to ensure access to healthcare and health services remain functional when they are most needed, thereby strengthening health resilience. And this ALD on DHM was operationalized through the adoption of the Plan of Action on DHM 2019 to 2025 during the 4th ASEAN Health Ministers meeting on August of 2019. Now, this Plan of Action on ALD DHM is a framework for us to ensure practical coordination and collaboration among the ASEAN member states in implementing the ASEAN Leaders Declaration. So in order to achieve the goal of the disaster resilient health system in the ASEAN community, the Plan of Action for ASEAN Leaders Declaration has 5 priority areas, and these are regional collaborative frameworks, multi-sectoral participation, integration of DHM, and the national and subnational legal and regulatory frameworks, improvement of critical health care facilities infrastructure, and knowledge management. In particular, the plan has a total of 21 targets. 14 are regional targets, meaning targets that at the ASEAN level, while 7 are national targets. The 14 targets, as shown in the screen, is along strengthening regional coordination committee, development of various standard operating procedures, information knowledge management, research, issuance of journals, and others. On the other hand, we have 7 national targets in which all ASEAN member states should accomplish until 2025, and this includes organization of our international emergency medical team, establishment of emergency medical team coordinating cell, development of national SOPs for acceptance or registration of international emergency medical teams, deployment of standard reporting system for emergency medical teams, DHM tracking system, knowledge management, collaboration training, DHM in the health education and safe hospital program. And this is the reason why this ASEAN academic network is patterned along these 7 national targets. Now, moving forward, during the second regional collaboration committee, this DHM meeting, which happened in 2020, Thailand, as the lead country of the ALD, proposed for the formulation of a roadmap that would articulate the ASEAN health cooperation contribution to the realization of the One ASEAN, One Response through the 5 priority areas and through the 7 national targets that are stated in the Plan of Action on ASEAN Leaders Declaration. Now, during the said meeting, the creation of a core group was agreed in order to further develop the said roadmap. And at that time, only the Philippines, being the then chair of the RCC-DHM, and Thailand as the lead country, volunteered to join the group. And this is the reason why Thailand and the Philippines is the one presenting the detailed matrix on ASEAN Leaders Declaration. So as a result, what we have is the detailed matrix, which is divided into 5 priority areas. And this detailed matrix is annexed to the work program 2021 to 2025 of the ASEAN Health Cluster on responding to all hazards and emerging threats, wherein the operationalization of the Plan of Action on DHM is one of the project activities under the Health Priority 13 on disaster health management. So at this point, may I turn over the floor to Dr. Krensak to present to you the RCC-DHM and the status of the activities under this detailed matrix. Thank you.
Good afternoon, ladies and gentlemen. Thank you, Mr. Jim and Janice, for kindly introductions. First of all, I would like to explain about the structures of the regional coordination committees on disaster health management, or we call RCC-DHM. The structure of Regional Coordination Committee on Disaster Health Management, or RCCDHM, work under the ASEAN Health Cluster 2. The chair of RCCDHM is representative of the Health Cluster 2 that currently serving by Singapore at this time. The secretariat responsible by the MOPH Thailand. In Thailand, we have many organizations who take in charge of the RCCDHM secretariat that will provide some works or some activity under the RCCDHM committees. There are 26 activities developed under the 5 priority areas that Janice have mentioned earlier. As shown in the table, some are complete activities, some are upcoming, and some are ongoing activities. That we focus on 5 priority areas. I will give you some more detail for each area. In the tables, as you can see, in the green one is the completed activities that we have done. And for the yellow one on the tables, that is ongoing activities. And the blue one is upcoming activity that we have to finish by the year of 2025. For the priority area 1 is strengthening and enhancing regional collaborative frameworks on disaster health management. The first that we finished is to develop the standard operating procedures for the EMT. As you can see on your right hand side is the SASOP chapter 7 that we developed the SOP for the EMT that's already endorsed into the SASOP chapter 7 already. And in the SASOP chapter 7, we have the form, the common form that need to report during the disaster response that include in the SASOP chapter 7. And we have ongoing activities such as we have to share lessons learned and good practice from the actual disaster health response that run by RCCDHM. And the other activity that we should review, we have the SASOP, we have the SOP for the EMT operations, but we have to test and review them and need to amendment in some cases. Okay, this is priority 1. The major activity of the priority area 1 is about the regional collaboration deal that we have performed for 5 times. For the first one is the startup deal in Bangkok, and the first deal in Phuket, second in Da Nang, Vietnam, and the third in Manila, Philippines. The fourth one is in Bali, Indonesia, and last month we performed the 5th RCD in Malaysia, in Kuala Lumpur. For the priority area 2 is enhancing multi-sectoral participation in disaster health management. For this priority, we focus on the coordination between other agencies, other partners in our country or in our regions and in our regions. The picture, as I show you, that is the ADEX that we test about the EMT operations with the AHA centers. For the priority 3 is about promoting the integration of disaster health management framework concepts into national and subnational legal and regulatory frameworks. This priority area, we will conduct the peer review and collective measures. For more detail and information about this activity, Mr. Taro Kita will explain in the next sections. This is the peer review that we performed the first time in Bangkok in this year. For the priority 4 is about promoting investments to develop and improve critical health facilities and infrastructure at national levels. That may be the activity about the safe hospital. We will we will conduct the regional consultations and meeting about the safe hospital and conduct the joint research about the safe hospital. That is ongoing process. For the last priority area is about priority area 5 is enhancing knowledge management on disaster health management. This activity are conduct a regional academic conference, establish AIDHM, and develop standard training curriculums. Now we have 2 curriculums that we call C course and B course that one have mentioned earlier. Next step is the publications of ASEAN Journal or e-bulletin on disaster health management that led by AANDHM and AIDHM. This is the future plan. This is the last slide. It shows you that we established AIDHM and steering committee, the member from 10 AMS institutes, and we have partners from non-ASEAN members. Both of AIDHM and AANDHM work under the RCCDHM and under Health Cluster 2. This is the diagram that shows you the relation between the ASEAN sector and AANDHM and AIDHM. Thank you very much.
Thank you, Ms. Calexto and Dr. Pentatham for the presentation, wherein you inform us about the 5 priority areas and then the 26 project activities under the matrix of detailed activities to implement the plan of action for the ASEAN Leaders Declaration on Disaster Management. So before moving on to the next presentation, we will open the floor if there will be questions or points for clarification. If none, if you can allow me to raise a question. So with regards to the implementation of the plan of the matrix of detailed activities, particularly taking into account that the plan of action is from 2019 to 2025, at the moment there are still a number of project activities that need to be initiated. What's the considerations? What are the considerations or the plans now of the ASEAN health sector with regards to the project activities that may need more time to be implemented?
Yeah, the progressions of all of the activity that we evaluate by the they have sending the concept papers to the health cluster to endorse the concept papers. For the next step is how to organize about the activity or to conduct the activity. We concern in some activity that may need a long time, such as for the civil and military coordination activities that we need to establish some sub-working group, or it may take a long time but it should finish on time on the 2025, I think so.
Yeah, thank you. Are there questions from the floor? If none, just allow me to also mention that the Regional Coordination Committee for Disaster Health Management is supporting the implementation, and there's already an established mechanism for coordination that support the implementation of the priority areas. The activity that we're holding now and the institute that we visited the other day are tangible evidences that there had been progress in the implementation of the matrix of detailed activities, and particularly the ASEAN Leaders Declaration on Disaster Health Management. So with that, please join me in giving a big round of applause to Ms. Calexto and Dr. Pentatham. Moving on, there was a mention of the project for strengthening regional capacity on disaster health management, and then that's through the ARCH project. So one of the initiatives of the ARCH project is the harnessing the cooperation of the ASEAN member states in disaster health management through the ASEAN collective measures. So this afternoon, Mr. Taro Kita, one of the experts from JICA, supporting the ARCH project implementation will walk us through these ASEAN collective measures. Mr. Kita, please.
Thank you very much, Mr. Moderator, and good afternoon again, delegates and ladies and gentlemen. My name is Taro Kita, the JICA expert for the ARCH project. Today, I'm really happy to have this opportunity to share our one of the ARCH project activities, the ASEAN collective measures. I have no COI to disclose. So as mentioned in the previous presentation, the Southeast Asia, the ASEAN is a disaster-prone, one of the disaster-prone regions in the world, and the occurrence of the major disasters here that has boosted the development of the regional disaster management framework, as represented by this ASEAN declaration on one ASEAN and one response. The ARCH project, the project for strengthening the ASEAN regional capacity on disaster health management, was started in 2016. And the supporting the ASEAN member states are strengthening their disaster health management capacity. And the second phase of this ARCH project just started in 2022 and planned to be completed in March 2026. And one of the outcomes of the ARCH project activities so far is the development of the development of the ASEAN Leaders Declaration on Disaster Health Management, and also the development of its plan of action to implement the Leaders Declaration. Then the ARCH project phase 2, we are focusing on supporting these 3 priority areas among 5 areas of this plan of action. And we have a number of activities like supporting the Regional Coordination Committee on DHM, development of the SOP that I mentioned in the previous presentation, the regional collaboration drill, and also the development of ASEAN academic network on DHM, development of training curriculum, and also the peer review and self-assessment. So this is the background of this ASEAN collective measures. As we know that the WHO set this classification and the minimum standards for the EMT and started the international registration system. We consider this initiative as a global standard. And when we look at this ASEAN situation, all 10 ASEAN member states already maintains some type of emergency medical teams, and many of them are already having international deployment. But when it comes to this international registration, we only have 2 EMTs, the government team from Thailand and NGO from Malaysia. And several other ASEAN member states are still in the process of this accreditation. Then with this EMT initiative, WHO set this minimum standard with its guiding principles, core standards, and the technical standards, and requiring all IEMTs to meet that level. But according to the survey conducted during the ARCH project activities in the early stage, many ASEAN member states expressed difficulty meeting this level, especially for those 5 areas: customs compliance, waste management, indemnity malpractice, logistics support, and accreditation of foreign medical license. Then the ASEAN collective measures was initiated to support the ASEAN member states in meeting those challenges, especially for these 5 areas. This is a brief history of this ASEAN collective measures. It was started in 2019 with the endorsement by the project working group of the ARCH project with a representation from this 10 ASEAN member states, and the discussion and also developed the sub-working group with the 5 ASEAN member states focusing on ASEAN collective measures, and discussion is still ongoing even now. The analysis was conducted, and as mentioned earlier, the ASEAN collective measures was initially started to support ASEAN member states in terms of the EMT development. But we decided also support the capacity building in receiving IEMTs, because ASEAN is a disaster-prone region, and any ASEAN member states can become the disaster-affected country, so that we really need to increase the capacity of this the receiving capacity of the IEMTs. And the point two is that there are a number of strengths of ASEAN in terms of EMT deployment, like geographical proximity, or cultural and linguistic similarities among neighboring countries, and also the existing disaster management frameworks and agreements, like ADOMA as a foundation of the regional disaster management framework, and AHA Center as a coordination body, and SASOP, as I mentioned, and also DELSA, the Disaster Emergency Logistics System for ASEAN. And another analysis was conducted for the the issues raised by the ASEAN member states, and it was identified that the lack of information about the disaster-affected country in terms of receiving IEMTs for the national procedures or guidelines. So there are 5 recommendations, ASEAN Collective Measures recommendations in preparation and also in progress. The development of the database of DHMO information in ASEAN member states, the confirmation of national SOP or guidelines, or the assignment of medical coordinator, the development of stockpile of EMT items in the disaster-prone country, and also the conduct of joint EMT operations. As a lack of information on the affected countries was identified as one of the common challenges, we are now developing the database of DHM information about ASEAN member states. And with this process, each ASEAN member state can confirm the necessary procedures or guidelines for receiving international EMTs, and that information can be provided to the incoming EMTs in a timely manner. The SOP for the EMT coordination that was explained in the previous presentation, and the EMT SOP stipulates the essential information for mobilization and for on-site operation for IEMT to obtain. And they also put the annex document with a list of essential information. So this is an overview of the database that we are now developing, covering emergency medical system, disaster management system, and disaster health management system as well. And as for the DHM, it was guided by the contents of the topics of the national targets of the plan of action of the ASEAN Leaders Declaration. For the information collection, we utilize various ARCH project activities, self-assessment on DHM, which is in progress, and peer review on DHM. We conducted this one in Thailand earlier this year, and also the regional collaboration drill. The regional collaboration drill, this was also explained in a previous presentation. This has been conducted since the beginning of this ARCH project. One of the objectives of this RCD is to confirm the host country's strategy, guideline, or procedures for its disaster response, including the acceptance of IEMTs. And during the, excuse me. The 5th RCD was conducted in Malaysia last month. And excuse me, what's happening? Oh, thank you. Yes, through this 5th RCD in Malaysia, Ministry of Health Malaysia confirmed the national SOPs and guidelines for the receiving IEMTs, the various procedures, guidelines, and also the reporting formats were also identified. Yes, and the next one is a medical coordinator Again, the EMT SOP stipulates the assignment of medical coordinator as one of the supporting function of the EMTCC. However, there is no definition is stated in any document so far. So that, again, the fifth RCD in Malaysia, MOH Malaysia discussed and then conducted the group work and identified the role and qualification of the medical coordinator, and that was tested through the field exercise of this RCD. Then the stockpile of EMT items. Okay, the development of stockpile of EMT items was proposed to address the challenges on the transport of dangerous goods and also the controlled medicines. Then the basic concept is that there are two options. The number one is the utilization of DELSA warehouse in ASEAN. There are 3 warehouses in ASEAN region managed by the AHA Center. And the second option is supporting the capacity of the domestic EMT of the disaster-prone countries and giving them a capacity to maintain the extra stock which can be provided for the incoming IEMTs. The ARCH project set the standardization of EMT medicine and equipment in the ASEAN region as a designated theme for the joint research project in 2024 with funding support. And the National Ban Hospital from Vietnam submitted a research proposal with the title of the Evaluating Current Medical Toolkit and the Practical Scale of EMTs in ASEAN Countries. The proposal is already endorsed by the steering committee of this ASEAN academic network. So we expect this research will be implemented from sometime in the first quarter next year. And we are really hoping that the outcome of this research can contribute to the realization of this stockpile of the EMT items. Then the last recommendation is a joint EMT operation. The recommendation of the joint operation between national EMT and incoming IEMT was proposed through the scenario-based brainstorming at the project working group meetings last year. And the fifth RCD in Malaysia last month, we conducted a simulation with the joint operation between national EMT from Malaysia and the IEMT from Japan, the JDR, Japan Disaster Relief Team. The participant review is still being collected, but expected benefit of joint EMT operation is that the national EMT can provide the local coordination or administrative or logistical support or taking charge of the security management. While the AMS IMT can provide, can leverage the existing strengths of ASEAN region that I explained earlier. However, at the same time, this joint EMT operation would require the same principles, same standard operating procedures, or same training curricula, or standardized medicine and equipment, as well as the prior bilateral agreement. A conclusion, the ASEAN corrective measures aims to support the efforts of the ASEAN member states to strengthen their capacity to meet the global standards for the emergency medical team and the capacity on the receiving and the coordination of the EMT operations by leveraging the strengths of the ASEAN region, such as geographical proximity, cultural linguistic similarities among neighboring countries, existing frameworks and agreements on disaster management, thereby achieving a rapid, effective, and high-quality EMT operations with the view to realizing the one ASEAN, one response. And this is my last slide. So the ARCH project published the 5 articles in the Pre-Hospital and Disaster Medicine Journal. And if you are interested in learning about the ARCH project, please just check this article. You can access this article through this QR code. Yes, with that, this is my end of my presentation. Thank you very much.
Thank you, Mr. Kita, for the presentation. A big round of applause, please. Yeah, in the interest of time, we will only entertain one question if there is. Yeah, please.
Thank you very much. My name is Ryoma Kayano from the WHO, in charge of policy research on disaster medicine. Thank you very much, Mr. Taro Kita, for your great presentation. Especially, I'd like to emphasize want to say congratulations about the progress on the research project also, about the publication of the pre-hospital and disaster medicine. It's a great progress in terms of from activity to evidence, science, evidence. So the collaboration between the researchers and the practitioners and the government officials, those harmonious collaboration and engagement is a key for the success. So I want to say thank you for your great efforts. Thank you so much.
Thank you very much for the comment. So again, a big round of applause to Mr. Kita. Thank you very much. So after sharing two initiatives within ASEAN, let's expand the horizon. Let's move to experiences and initiatives from outside of the region. We'll start with a presentation from the technical officer for Surge and Rapid Response of the EMT Initiative Secretariat of the World Health Organization. So please join me in welcoming Dr. Sohail Resh. The floor is yours, please.
Should I mention I'm not a doctor? Sorry, maybe I should go because we are full of doctors here.
Yeah, the floor is yours, please.
Thank you very much. Good afternoon, colleagues. I should not say colleagues, but good afternoon, colleagues. Just first of all, I would like to thank you for inviting me because it's a great opportunity to discuss about EMTs. And I've been working for WHO for now almost a year, and I've never heard so much about EMTs. So I'm super happy. Thank you very much. So please invite me more for discussing about EMT. So, yeah. Yeah, I do not have any conflict of interests. Sorry. Yeah, first of all, where we are regarding the EMT initiative, because we've been talking a lot about EMT, part of the EMT Secretariat, so where we are. So today, basically, working on more core and technical standards, and we have seen during the last days that the necessity to have more guidance, more standards, so we're also contributing on that. Global classification system, quality assurance, that is being developed, so we'll see how many teams are now being classified. More than 100 EMTs now are part of the network, okay, classified and under classification process. Obviously, there are more, but within the network today. The national EMT development is part of the priority, and there are a lot of initiative, a lot of development, as we have seen in the presentation here, in the last day presentations. Coordination mechanism, obviously EMTCC is one, but we have also different EMT coordination mechanisms that exist. Our colleague, Dr. Kita, just presented one, but there are also many others. Operational responses, here I think we have seen this map. This is the Turkish response, 38 EMTs deployed, major operation, but since I started in February 23, so this was my first, so that was my welcoming disaster. So very, induction was very, very fast. So I was deployed not in Turkey, but in Syria for the earthquake as well. So since then, we have managed Malawi, we have had Morocco, remember recently, Libya, Sudan crisis, conflict. Now we have the conflict, we have the Israel-Hamas conflict, and there are others. So we're getting more and more operations going on, and it's, as we also mentioned, it's a worldwide network. So how do we use this network, this committee of practice, to exchange information, to exchange practices and knowledge? Sorry, I have to learn about this thing. So EMT global footprint, as I was mentioning, there are more than 100 EMTs classify or under classification. So you can see, maybe some of you will note that there is a problem in this map. Okay, so all the effort was done in Asia, Americas, but Africa and Middle East is still low. So this is where the effort of the EMT Secretariat is going to be for 2024. Okay, and definitely we will need your support as mentors, as donors as well. So a message to Jika again. But you can see it's quite impressive, and places where we have most of the disasters and the conflict are not really covered. So that's the priority. Again, this is don't use it for any publication, because this is pulled out from a list of EMTs that we have that are under classification and classified. So, give you, I don't know if it was introduced, but we have developed a new EMT strategy, 2030 strategy, which was launched in Armenia. Yeah, by the way, I forgot also Armenia recently. So the strategy calls on countries and organizations to take proactive action and to build and strengthen their EMT and rapid response capacities by implementing 4 critical steps. Again, we have seen during the presentation for the last days, so nothing new. So adapt EMT guiding principles, standards, EMT methodology, and adapt to local context. So it's always about adapting it. That's the next step. Establish a search system at country level to facilitate rapid mobilization and requests for assistance if and when it's needed. Again, we have seen all the effort done during the last presentations. Strengthen technical and operational skills of health workforces, which is also essential at the local level. And document to inform evidence-based strategies and share best practices, so through research, through better data analysis, etc., etc. So, in quick overview as well of the strategy. So I'm not going to go in detail, but I mean the vision is every country has the capacity to respond to the national emergencies, obviously with rapidly, effectively, flexibly. The goal is the population, affected population, should receive essential assistance with quality. Okay, and here the value for us, the new, I would say the critical shift from the previous strategy is the interoperability with mobile labs, for example, with rapid response teams that are existing. So how do you connect them with the EMTs as well? And I would say for me the most important, and for us the most important value is the regionalization, okay, which we've been discussing here. So how does it work? So we put the region in the middle, and the region is a connector between the international search, which is a strong international search, quality assurance with standardization and classification system, and the investments to be made to build a strong local capacity, response capacity, by adapting the standard to the, adapting standard to at local level, by developing local quality assurance, etc., etc. But the most important and something which is also key for our strategy, at least the WHO EMT, is the third one, is including the training hubs. So basically, developing training hubs in the different regions, the mentorship, facilitating the research and knowledge sharing, which we have been seeing during the previous presentations. Today, for WHO EMT, we have 3 hubs, okay, as of May 2023. So the first one was established in Ethiopia, in 2021. And it's operational. The second one is in Indonesia, established after the signature as presented by Professor Yadjan yesterday at G20 in Bali. So, and it's now operational because we have had 5 different courses, AMT courses, since the beginning of the year. And the Turkey hub will be, is now being established and will be fully running by the end of the year, end of 2023. So, just to give you an example of the Ethiopia, some data is about Ethiopia, the Ethiopia hub. So 453 participant trained, 7 courses conducted. So the way it works, so you have countries coming, I mean, country teams coming in Ethiopia to be trained, or you have specialists going from the hub to the countries. And again, it's not only, it's the idea of the initiative, it's not only WHO specialists, but it's part of the network, okay, mentors. So we have had inductions, I mean, EMT induction, trainer TOTs, national EMT implementation workshop, burns mass casualties, and actually for that, the Togolese team was sent to Sudan to support the, no, so not to Sudan, sorry, to Chad to support some burn cases. So that was also quite interesting. Cholera management and SOP workshops. Again, another, this is the vision, WHO Afro strategic vision. Again, I'm not going to go in details, but just to show you, they also developed their governance structure. So it starts with identifying 10 priorities countries that within the Afro countries. Then it goes to the establishment of a regional governance structure with different partners from the region, which WAO, CDC, and others. So I think we have similar mechanism within this region. Building a training center, so that we've seen that the Ethiopia one, and reinforcing partnership with international EMTs. That's I would say the connector with international EMTs and donors. Again, without donors, nothing can happen in the regions, and also international partners. Okay, just in terms of planning, so yeah, we still have until, I mean, basically until the end of the year, there are still all this list of trainings to happen from now to the end of December. So as you see, we have logistics. We've seen in the previous presentation, the supply is also a big subject, a big thing. So far, we have not reached the point of pre-positioning supplies, but it will hopefully come soon. Wash is also a big thing as well, because without proper wash system, it's going to be quite difficult to set up any EMT response and structures. And there are new countries to be engaged, Mozambique, Guinea-Bissau, Cabo Verde, and Zambia to come. Sorry. So here is the EMT course model. I've put the Indonesia one because it's also very specific. So you'll find this model, this course package developed in all the different hubs. Here it's very specific. Yesterday, you remember, Professor Yadiana mentioned the specificity of the Indonesia hub is the biodefense perspective, and I think you will start soon or next year to include this course. Okay, so very specific. So it's adapted to the local context and also the request from the partner, which will develop the curriculum for this specific course. And if you're also interested, please reach out to Professor Yadiana. She can give you more details about that. The example of the Pacific Islands. So as we have yesterday had a presentation from Dr. Luke from the FIMAT, we've seen that there is also a lot of EMT teams, national EMT teams, that have been developed and classified. And the way they're working, because it's also very far from all the, most of the regions, they have now working in a system where the classified team will send mentors to support the new teams. Another model, and this is where we are going, so how national teams can help each other in building the capacity. We were talking about exchange, knowledge knowledge management here, okay? One of the role of WHO is to provide guidance. So we are working on different guidance, so HID, pre-hospital medical evacuation, burns in mass casualty incidents, mass gathering, medical planning, joint EMT, RRT response, civil-military interaction. Also, this one developed in part. I mean, we're developing it in partnership with the Rideau University. Semi-non-permissive environment. So, how do we work in conflict? Okay. Many of the EMTs in this room have no experience or no capacity to work in such conflicts. So, how can we guide them? Help them to develop such a capacity. Specialized care team, CMEX medical simulation, sorry, CBRN, so it's linked as well with the work done through Rideau. Mental health and psychological support. This is a big need now. I mean, obviously after disasters, but now in Sudan, the Gaza situation, we're seeing a lot of requests for mental health guidance from our MT partners. Healthcare operations support and migrant health and refugee crisis. Sorry. Yeah, quick high infectious disease outbreak teams, another model that has been developed. So here the idea is that some recommendation established for 3 different scenarios, so acute watery diarrhea, respiratory infection with epidemic potential, viral hemorrhagic fever with human-to-human transmission. So here it's a different type of teams needs according to the phase of the disaster or the crisis or the outbreak, sorry. Okay, first at the beginning, so I'm happy to share as well the link so you can have it. Quality insurance, as we were discussing all over the different presentation, the quality assurance is also one of the pillar of the EMT initiative. So the classification is so we have, is essential, at least 39 EMTs classify as of today. So mainly type 1 fixed and mobile, obviously require less resources than a type 3, but we still have some partners, and then we have 2 classifying as going for type 3, sorry, and 2 specialized care team. How does it work, this classification process or reclassification? So we have decided basically that it will, at the regional level, will go for the type 1 mobile and will keep at the HQ, so at the Secretariat in Geneva, the lead for the other type of classification. So I have to speed up because So, thank you very much. Don't ask too much questions, please.
Thank you, Mr. Resh, for informing us about the developments on the EMT initiative at global level, as well as the experiences in Africa, as well as the Pacific islands, and also the regionalization effort, particularly the development of multi-country training hubs and putting the region at the center. So with that, we will open the floor for 1 or 2 questions. Mr. Resh, can you, because you have outlined a number of regional initiatives, and then also with the ASEAN, there are also initiatives to really bring together the countries in order to also work together. What's the potential for interregional collaboration and collaboration through WHO? Thank you.
You want an honest answer or?
If you can make a comment on that.
Okay, no, definitely. When I see the conference here and then the ARCH project, is definitely there's some, I would say, more space for collaboration. It's true that we collaborate a lot with our closest partners, being in Europe, and I think there is definitely a need to have more collaboration in the different regions. So far, I would say it's not weak, it's happening, but we could develop much more. From what I've seen during the presentation these 2 days I've been here, definitely, the EMT strategy is somehow, reflect all the discussion we have been discussing here. So for sure there are more, and I've been discussing with Dr. Taro that we need to discuss more about that. Now, regarding pure disaster management, we have a partnership and we have an MOU now signed with UNDAC, which is not an EMT, but it's very, there's a lot of complementary and synergies between UNDAC, search and rescue teams and EMTs, because we are almost coming at the same time, and this is also important. So this is what we're trying to build. And we're looking for more collaboration and partnership, not only in Asia, because it's already there, but as well in PAO and Africa. Thank you very much.
Thank you for that. So again, a big round of applause to Mr. Resh for the presentation. So after being updated on the Global EMT Initiative and then also the experiences in Africa, as well as the Pacific, let's go to Americas. Let's call Dr. Mario Velches Madrigal, the Director of the Center for Emergency and Disaster Management of the Caja Costarricenses de Seguro Social of Costa Rica. Yesterday, he presented their experience at the national level. So today, he will be sharing the experience in terms of how Costa Rica engage at the regional level, and then also provide insights on the experiences in PAHO. Thank you.
Thank you very much. I wish to express again my gratitude for the organizers of this great event to allow all of us the opportunity to come sit here together and learn from each other. I have no conflict of interest to disclose. I go back to this slide that I presented yesterday to remind the audience our size, our inhabitants, our lack of armed forces, and diminished capabilities of airlift, and the separation between the Minister of Health functions as policy and regulation, and our institution as the provider of healthcare services, the high coverage of the population, and that we have been actively trying to engage in this world since 2005, when we started trying to develop the DMAT for Costa Rica. We are going to dive deeper in this from our perspective. How have we engaged with PAHO, and how this two-way relationship and regional relationship benefits not only the region, but also your own country in a very big and important way. So, we discussed yesterday some of the very important contributions or critical contributions of the Blue Book, both editions, in how we set up our project. But I want to call the attention to the plan of action since 2014 for the PAHO. This allowed us, behind the Sendai framework, to develop a national policy for risk management, and the Ministry of Health to develop this strategy for healthcare sector for integral disaster risk reduction and healthcare emergencies. And so we use all this to regulate inside our institution also, and so we make this the pillars of and the justification of everything we do now at the Center for Emergency and Disaster Management inside the CCSS. So we started with this book. Hopefully is familiar to everybody. The first version of the EMT, which was then called Foreign Medical Teams, which started to give us some problems with the terminology, because to invest in foreign medical assistance was a complex concept to sell inside my organization. So we identified our current preparedness and capabilities for effective disaster response under the standards set by WHO. Then we had to define what we wanted to do with this and try to close the gaps. We had some gaps between Ministry of Health and our institution, which I must say have closed a lot since we started working with this methodology. We had a lot of gaps inside our own institution, so we supported ourselves with these regulations, and Civil Protection Agency in Costa Rica and our institution had some gaps. The PAHO engagement has allowed us to have a neutral ground for discussion and for closure of these gaps. And PAHO has helped us actively support our gap closure. We will, sorry. So, in 2014, the International Search and Rescue Advisory Group performed the first CIMEX with an EMT component. And timing, as Dr. Kai says, timing is everything. The first EMT component was held in Costa Rica in 2014. You can see here the president of Costa Rica with the head of the Civil Protection Agency. So that was the starting point for us. Before 2017, we participated in these activities, and we hosted some of these activities in exchange for some more places for our staff to be a part of them. So PAHO would do these activities, and we would get this benefit, added benefit, by collaborating. Sorry. So, timing is everything. Before the verification in February 2017, we received direct impact of a hurricane in Costa Rica. Last one, 1851. But we didn't come empty-handed, because we had all the procedures and all the paperwork, the layouts, and the doctrine of the EMT standards. And we also, at the time, were participating in this seminar, so we were sharing our material with JDR, and we were receiving feedback and advice from JDR. So when the hurricane struck, we already had a lot of material that we used to mount the first response. Remember that I told you yesterday we had absolutely no experience beside the door of the emergency department, and that we were not even engaged in pre-hospital medical care. So to deploy a medical facility in time of a disaster with water, self-sufficiency, electricity, and all the standards could have been very difficult, but it was made much, much easier because of this engagement with PAHO. So our second phase, this was our first phase. The second phase comes after the verification until before the pandemic started. Just an example, in the picture to the left, you can see the Minister of Health. You can see my former boss. You can see Mr. Flavio. But on the right, you can see the regional representative of the Pan American Health Organization. So this team together made the verification and possible. And so we have been engaging in a lot of activities, either organizing them in Costa Rica, heavily supported financially by PAHO, but we were using our equipment, our staff, our instructors, our faculty, and the other activities we organized as faculty outside Costa Rica together with PAHO. So this has allowed us to see the very different perspectives of different parts of the region, but some of these activities have also been done with WHO. So we have also been able to participate at the global level of the initiative, thus expanding our vision. We had even participation in the Idai cyclone at the MTCC coordination cell, and this partner or member of our group in Mozambique is now being accepted to form the part of the information management work group for EMT. So this is how we have taken advantage in the good meaning, in the good concept of this relationship with PAHO and other relevant actors. We have also done some, for example, when we classified our team in 2017, there was this EMT virtual tour. We received some donations from PAHO for water treatment kits. They were complementary to the US Southcom donation of equipment during the pandemic. And so this was very important because PAHO had complemented Southcoms to fulfill the standards. Not only the medical tents, but also the ability of the regions, of the countries in the PAHO region to fulfill the standards. So we made the training in Costa Rica, and this can be accessed it's in the PAHO webpage. We have done several technical visits. These two teams, Panama and Dominican Republic, are under verification process right now. And El Salvador, I received an email a couple of days ago before coming here, probably will also join soon the initiative, the verification process. We organized the regional mentor workshop last year in Costa Rica. And this mentor workshop has now a mentor core group that is meeting regularly and is growing in capacity to support the development of the teams in a more standardized approach. During the pandemic, at some point, we had no more ability to expand, so we partnered with Panama to provide us some of the equipment, and with the SAMU Sevilla Verified team to provide us with the healthcare workforce. So we could do this joint deployment in a hospital where we had already full deployment, but this was complementary at a critical time. I keep getting back. So these are the teams. We have participated in the mentorship of these teams. This is excellent opportunity for our people, not only to share what they understand, but to learn and see how other teams do the process, and this is invaluable for us. And there are 4 mentorships underway, with our staff being as lead mentor or as support mentor. This was very important. We participated in the development of regional technical redaction of guidance. And these 3 regional guidelines, and we also participated in the update of the Blue Book. But now, pandemic comes, we invest our time and effort in this documentation, but then we use it. All the knowledge that we acquired through here, we put it to make a national guideline to service expansion inside the infrastructure of the hospitals. And you can see 2 examples here of one of the national reference center, one of the 4 national reference centers, and one on the right of the regional reference COVID centers. So as a direct result, we have tools and technical ability to complement our own local response. We were asked to provide an alternative care site at some point, and even pressured by authorities. But since we had developed these guidelines together with PAHO, we understood very well the challenges of doing this. And at the moment that it was requested for us, we simply did not have the human and logistical resources to invest in this conference center. So we took the decision to pull all resources inside the hospital, but inside the surge capacity and capability that the EMT deployments allowed us to do. So we did not have to go to a conference center. We could deploy the EMTs with standards and make the search with EMT in very close proximity to the hospitals. So what are our next steps? Mr. Soleri already explained the 2030 EMT WHO Emergency Medical Team Strategy. We plan to be heavily involved in the next years in this strategy. For next year, we are holding the presidency of the EMT Regional Group of the Americas. So we have to organize some of the activities in the region. We are in the process of reclassifying our team, and as I said yesterday, we are finally starting to develop the surgical capability of EMT, which does not mean that we are going to classify yet a type 2 EMT. But the future is very busy, and I think it's busier now after having attended this conference and having the opportunity to take a lot of work back to Costa Rica. So thank you very much for your attention.
Thank you very much, Dr. Madrigal, for the presentation. Thank you for the information regarding Costa Rica's engagement in EMT development at the PAHO level, the Americas level, as well as the initiatives on strengthening EMT as coordinated by PAHO, as well as the engagement on technical visits, as well as the development of your mentors in the region. So at this stage, we will open the floor. If there are questions, points for clarification. Yes, Mr. Ikeda.
Yes, my name is Ikeda. I'm the Arch Project Chief Advisor. Thank you very much. Again, very good presentation.
Thank you.
Dr. Mario. My question is very simple, actually. According to my understanding, in the region of the Central America, you have the similar kind of the regional integration mechanism like ASEAN, like so-called the SICA. I don't know the actual name, like some kind of the Central America integration system, etc.
Yes,
right?
exactly. That's the Sistema de Integración Centroamericano.
Yeah,
exactly.
yeah. Why I ask you that, because of yesterday, in your presentation, you said that the importance for the implementing and proceeding about the EMT initiative in your country, actually the political and the leaders' commitment, leadership is the most important in order to proceed your effort. However, that political leadership is sometimes a risk for the sustainability. Sometimes the president changed the new person, and maybe according to the system, that many of the top of the ministry and the organization was changed by the political appointee, and that is a risk. And therefore, I'm asking you that SICA law. According to the experience of the ASEAN has a mechanism of the all top leader for the future toward the integration of the ASEAN region. And ASEAN people are very good, taking the very good way. They're utilizing this mechanism, the ASEAN leader declaration for the disaster health management, endorsed and approved, adopted by top leader of each country. And even the leader of each country changed. The new leader or the new president or prime minister binded by such kind of the regional framework, which was already committed by the all previous leader. That is an international agreement. Even the new leader has to respect such kind of the system. How do you think about this kind of idea from the experience of the ASEAN to your region?
Thank you very much. It's an interesting question because SICA in 2019 updated its policy statement and include the sub-regional collaboration mechanism to deploy specialized, national specialized teams, they are called. So USAR team is a national specialized team, EMT is a national specialized team. I mentioned the important role of the Civil Protection Agency in my country. They lead this interaction between this mechanism and during emergency. National Protection Civil Agency is the lead agency organizing the response. So we already have a commitment to make this reciprocal assistance during emergencies through the SICA mechanism by deploying national specialized groups. However, the type of activity that and work group that you have developed here is very different from that's what's been developed in the country. Although in the sub-region, the mechanism exists, it has been used already, but not so much together working so far. But very, very, very interesting question.
Thank you very much. So in the interest of time, let's move to the next part of this session, which will be a panel discussion. It's only 25 or 30 minutes, so what may happen is that we will just be scratching the surface. But definitely after the sessions, you can approach the panelists for further discussions. So may we call on our 5 speakers to the stage. So the panel discussion will focus on the objective of the overall objective of this session, which is to discuss the challenges for regional collaboration on disaster health management and perspectives to be considered for further development of the regional mechanism. So may we now call on Ms. Janice Calexto, Dr. Krengsak Pintatham, Mr. Taro Kita, Mr. Sohel Uresh, and Dr. Mario Madrigal. So while our panelists are settling in, just allow me to say a few words that as far as the literature on disaster management or emergency management is concerned, and also based on the presentations that we had in the last 2 days, some common themes and threads can be recorded. We have communication, coordination, collaboration, cooperation. These are critical in emergency or disaster management. But these are also the key challenges that we face in doing our work. So we propose that this will be the focus of the discussion, not to dampen our spirit, but to learn from this based on the experiences from our panelists. So to kick off this panel discussion, apologies if I'm here, I'm not with you. Allow me to throw one question, which could be answered by all of the panelists to kick off the discussion. So based on the initiatives, the regional initiatives that you are pursuing, your experiences in working at the regional level, can you share what are the major challenges or issues that you have experienced or you foresee you may experience in the continued implementation of the regional initiatives that you're pursuing at the moment? So, for example, the ASEAN collective measures, the implementation of the matrix of detailed activities, further implementing or rolling out of the EMT strategy, and then further expanding the regional cooperation in the Americas. So please, anybody can start.
Allow me to start. So when we were developing the detailed matrix on the ASEAN Leaders Declaration on Disaster Health Management, one of the challenges is that is as mentioned by Dr. Kensak, there are several activities under the plan of action, and we were having the challenge on looking into countries that would lead in several activities. If you've seen the presentation of Dr. Kensak, not all the ASEAN member states are leading the activities. It's mostly Thailand, Singapore, Indonesia, and the Philippines lead one activity. So that's one challenge that that we've encountered, and maybe because it's rooting on the fact that there's lack of funding support in terms of these activities, and that some of the activities are mostly based or reliant to JICA funding requirement, and not and that the funding is not innate to each countries to support several regional collaborative activities. And Dr. Kensak may want to add more.
Yeah, please go ahead, Dr. Kensak.
In my opinion, this is the first that I concern that it's maybe the challenge for us is to do all the activity in the short time or periods, because of the reason that why we have to do many activities in the short period of time, because of the challenge in the disaster response in our region is about there are many party or many agency organizations that be involved with our response during the disaster. That if we don't have SOP or we don't have any something to do or to coordinate with them, we will encounter with the problems, a lot of problems about the coordination problems. That's why that we develop a lot of activity that to try to solve this problem. This is my opinion. Okay.
Thank you. Apologies. Before we move on to another point, can we go back to Janice and Dr. Krengsak? Based on those challenges, what are your plans in terms of addressing those challenges? So if I can also request the other speakers to consider those two as connected questions. Yeah, please go ahead. Yeah, if we can go back to Janice or Dr. Krengsak.
All right. Maybe my suggestion is that we continually but in terms of funding, we would have advocacy for inclusion of the funding of the advocacy for inclusion of regional collaborative activities in the existing work and financial plan of each ASEAN member states, or that each ASEAN member states would allocate fund to make sure to contribute or to fund several regional collaboration activities as mentioned in the ASEAN Leaders Declaration. Another is that maybe we can use technology. We can always use the online platform to meet and to discuss things. It's not always face-to-face activity which requires a lot of funds. We can do research online, we can do meetings online, and which is cheaper as compared to, we can do conference online as compared to us meeting here every time. So it's, that's one thing. And then we can also, because as mentioned earlier, the RCCDHM is our main coordinating mechanism to implement the ASEAN Leaders Declaration on Disaster Health Management. And I'm sure with Singapore's leadership now, we would be meeting more and discuss the status of the activities on the ASEAN Leaders Declaration. One also is that because Philippines is the leading the monitoring and evaluation plan, and that the Philippines would want to push more in terms of making sure that the plan would be developed and would be finalized and would be used as a good tool to monitor the activity, whether we have accomplished the activities or in the ASEAN Leaders Declaration, and that we've evaluated these activities in terms of reaching our goal or our objective.
For me, I do agree with Janice. That Janice has mentioned that it's very concise about the question how to implement all of the activities to our region.
Thank you, Dr. Krengsek. Can we invite Mr. Kita to give some comments?
Okay, so about the regional challenges in coordinating this, conducting this regional program. Actually, I'd like to raise the 2 points. The first one is about the diversity in the ASEAN member states. Each ASEAN member state, the situation is totally different in terms of the disaster management because of the frequency of the disaster, what type of the disasters, or also the, how can I say, the capacity, vulnerability, and also the preparedness, and also the interest in which part they want to focus. And even though we have ASEAN Leaders Declaration on Disaster Health Management, and also the plan of action, and also the, with the national target, I think depending on the country, the level of the achievement is different. But as a resolution, we have a training program in Japan called Knowledge Cooperation Program. And in that, we have activities called country analysis on disaster health management. And we invite our ASEAN member states as the participants of that training. And we ask them to analyze based on their needs and the situations. And then they decide the focused national target. And we encourage them to develop an action plan based on their assessment. So that's the one thing. And the second point is about the difference of the legal and the regulatory framework when it comes to the EMT deployment in the regions. When we developed the ASEAN corrective measures recommendations, we realized that in terms of the, let's say, the accreditation of the foreign medical license or import or use of the controlled medicine or dangerous goods, so there are many different laws and regulations in each countries. But for that purpose, as I mentioned in my presentation, we are now developing a database of the DHM information in ASEAN member states. And with that, through the activities like regional collaboration, DOIL, or in-country CCOS that mentioned many times in this session from yesterday, through those activities, we encourage the host countries to confirm their procedures or guidelines. And if it's not existing, advise them to create it. And with that, we will make a more sustainable way of the mechanism of the disaster health management.
Thank you.
Yeah, if I can add a few points, I mean, it's going to be similar points on the resource disparities within the region. So it's not only about financial resource, because that can be covered by donors, but it's also human resources, skills, and you have some countries where you have some brain drain, people living outside, going to other countries for better situation. So that's something it's important to do. So through these different training hubs that are now being developed, I think this can help, and obviously not at the regional level, but as well at the national level. I will also mention the policy and the regulatory. So it's not only about, I mean, where the health EOC where is the disaster response mechanism sits. Now, I've seen for the last 3 disaster, or at least emergencies, that Ministry of Health does not anymore lead the emergency response. So how do you manage when you have a Ministry of Health being cited by the Ministry of Defense, Ministry of Interior, or sometimes another ministry? So that's important for each country to define, and that's part of the preparedness, to define who's going to lead the response at the national level. Because for us, at least for WHO, our counterpart is Ministry of Health. And when you end up, like in Morocco, having to deal with Ministry of Foreign Affairs or Ministry of Interior that has no clue about EMTs, then it's going to be complex. Then you have all the issues about visa, medical licensing, and importation, which is also another complexity. Thank you.
I think Dr. Ikeda just landed. The political and security situation in Central America is very complex now, and it looks like it's going to get more complicated in the near future. That poses important challenges for a long-term strategy to be able to be implemented in the sub-region, at least. In Costa Rica, we have so far enjoyed the political stability. Even the authorities that have changed, even though they have changed some of the ministers or some of the policy, we have made it very difficult for our program to be replaced easily, because we have, as a defense strategy, tried to make it part of the successful day-to-day operation, build a group that can lead this initiative in the technical and strategic domain. And we have also avoided the possible politicization of these deployments, which is also another problem in some of the countries. As I say, in Costa Rica, we have had this opportunity. So you see the same people that have been working in the last years in the same working groups, and maybe adding more staff to the core group. But you don't, in other countries, every meeting I go is somebody else from the country that represents, because he's being changed. So it's very difficult for that country to really sustain this. And my recommendation, as I said, to a country is try to technically justify your place in the work in the technical group, and prove that you are not essential, but the cost of replacing you is high in terms of developing the capacity of this group.
Thank you.
Yeah,
Mr. Sohail
sorry,
was indicating...
being a field responder, I wanted to come with some very practical recommendation. I've seen as well, once you have the, from certain member states or from certain organization point of view, they think that the coordination of EMT deployment is an easy job. So you have to sit around the table and people discuss, and then we do the minutes of the report, and we go ahead. And I think this is also something which is sometimes underestimated, is the role of, the place of the EMTCC, so the EMT coordination cell, and the methodology behind it. And that's why we are struggling, and that's why we are all, at least from the EMT, also from the ARCH project, that's why we train EMT coordinators in order to run these EMT cells, in order to accompany the EMT deployment with the Ministry of Health, obviously, task them, prepare their deployment, prepare their how do you assess the situation, how many EMTs do you need, etc. And this is often underestimated by the partners and the member states. Thank you.
Thank you. So based on the conversation, the presentation, and then the initial exchange of ideas, from the ASEAN colleagues, what aspects of the presentation or information shared by non-ASEAN representatives that you feel will be relevant and would be useful for consideration by the ASEAN moving forward? So vice versa, to Dr. Madrigal and Resha later, what are your perspectives in this matter? So can we start with the ASEAN colleagues, Janice or Dr. Kringsat?
You go ahead.
From the other presenter from the other parts of the world, I do appreciate with the Costa Rica that they can develop all the EMT initiative very quickly in their regions. If ASEAN country, we have developed all the EMTs initiative quickly and widely spread in our region is very, very strong for response to the disaster that maybe occur in the future. I very appreciate with the EMT initiative platform in South America.
For me, two things. One is mentorship that happens in the other part of the other non-ASEAN areas. For me, it's important because we already have at the ASEAN level. We already have verified EMT teams, and that mentoring other countries in the ASEAN that doesn't have that. Has not started organizing their EMTs is very important because we know how we work at the ASEAN level. We know the situation at the ASEAN level. So it's important that for countries who already have their verified EMTs to mentor other countries at the ASEAN level to make sure that, or to be with them in their journey for the verification of EMTs. That's one thing I pick up from the presentation. Second is that maybe we need to streamline all our efforts at the ASEAN level. For example, there is already an Indonesia training hub. And at the ARCH or at our level, at the Plan of Action for ASEAN Leaders Declaration, it wasn't considered. We are developing B course, C course, and several other training courses. But maybe we can also lodge it in, or what is the relationship of the ASEAN Institute on Disaster Health Management vis-a-vis the training hub that is developed, or the ASEAN Academic Network vis-a-vis the training hub that is developed. So that's one thing maybe that we can discuss more at the ASEAN level and how to streamline all these efforts at the ASEAN level. Thank you.
Yeah, Mr. Kita.
Okay, thank you very much. Actually, after hearing the presentation from Mr. Sohail and Dr. Mario, I actually realized that, realized that importance of the collaboration with the WHO. Of course, in our ARCH project, we set as a WHO EMT initiative as a global standard. But personally, I can't say that we have a very close collaboration with the WHO, unfortunately. So let's say that under the ASEAN collective measures, we developed some guidance documents for the waste management, so technical documents. But perhaps we could have more inputs from WHO if we have more close collaboration with them. But today, now we have Mr. Sohail here, so our collaboration with the WHO would be more stronger and closer. Yeah, thank you very much.
Thank you.
Yeah, please go ahead.
No, definitely we need to do more. Yeah, I was trying to think about cross-fertilization and how, I mean, for me, definitely the fact that, I mean, we've seen in Turkey the deployment of 38 EMTs, civilian and militaries, actually. It's not only civilians. From different parts of the world, it's already interesting to see the variety of EMTs that are deploying, the way they work, and that's also the importance of having. We were discussing with our colleague on after action review, and having this type of after action review in order to not only look at the global deployment, but as well quality of care and for your, I mean, for internally for the teams, but as well as a network. What went well and what needs to be improved? And I think this could be interesting as well for us to adapt our strategies, because we assume that everything is perfect. People have been trained, they can be sent, and then, so that's the first point. There's, I mean, in terms of resource sharing, human resource sharing, so having more mentors that can be deployed from Asia to Euro to Africa, using as we mentioned, the training hubs wherever it's convenient. So simply having a mapping of all the services which are existing. I'm sure if we had a mapping of all the services only in ASEAN we'll be shocked to see what exists and what we don't use and what we could use, simply because there is no discussion at a higher level. Thank you.
From the exposition of the ARCH project, Mr. Taro, I saw very clearly the information sharing, and from the experience of the last 2 days, the research in this field is very important because it gives us all hard data to make the proper justifications in our programs, our countries, our regions. PAHO has a platform where we share information, and much to my embarrassment, I was looking at it yesterday and I saw that our information is not updated. So this is a very, I mean, to take in the good side, positive side, opportunity to put the effort in this area of information sharing and research in this EMT world, which, by the way, is also the 4th priority of the EM 2030 strategy.
Thank you very much. So I hope that the exchanges has triggered something, also facilitated a little opening, which will allow us to further expand and not only focus on the work within the region, but also across regions, as the overall objective is really to save lives through seamless mechanisms. My apologies that we are running out of time. However, before we really wrap up, can we hear one voice from the audience if there's a comment? Mr. Kida.
Thank you very much. And I have just one proposal, to especially Mr. Sohail, for the WHO. Actually, my colleague Mr. Taro said that collaboration, especially the relation between the WHO and this region is very important for us, but not with ARCH project, because the ARCH project is just the single project. We have the fixed time and up to the 2026. Therefore, we suggest and propose the WHO as well as ASEC or some of our members. We have the mechanism for the coordination in this ASEAN for the disaster health management. That is RCCTHM, Regional Collaboration Committee for the Disaster Health Management. That is a sustainable platform for the coordinating and discussing about everything about the disaster management, especially disaster health management, including the EMT initiative. Therefore, when the ASEAN will organize a meeting of the RCCTHM, we expect and the host country of the RCCTHM as well as the ASEC invite WHO to join the meeting and share your information, and you also learn from the progress of this region. And one more thing, and one more proposal to you, actually relating to this thing. The coverage of your regional office of WHO is different from the coverage of the ASEAN. The 3 countries of the ASEAN is the member of the CRO, but the other is UPRO. But sometimes it's rather difficult for the ASEAN how we can communicate the contact about inviting someone from the right person. Therefore, if you go back to your head office, please ask and discuss about this thing. Please assign someone who is in charge of the ASEAN, especially the ASEAN disaster health management. Thank you very much.
Thank you, Mr. Ikeda.
Thank you very much for your 2 questions. So for the first one, definitely we said that we are going to keep in touch, maybe have a formal meeting in order for me already to understand and to know when are the dates, the key dates, so I can be invited. I also mentioned that I'll be very happy to be invited to Japan, but that's more personally. But definitely with Dr. Tao, we'll discuss about that. For the second point, yeah, I agree with you, and sometimes it's also difficult for us within the MT secretary to understand the repartition of of the regions, which is basically done by the member states, so it's not WHO who decide. But once I mean, if I become a general director of WHO, I'm keen to change that. But no, but I agree with you. It's also a big challenge, and we have seen that because of this, the fact that we're sitting in 2 regions and the information is not passing. So that's why now I suggested that from the ARCH project, we can relay. I mean, the focal point will be at the secretary level, and then we will relay to whoever needs to be inside the loop. Thank you.
Thank you very much. So with that, we have follow-up matters already arising from this session. So definitely that will be documented, and then the related parties will be following through. So we're wrapping up this session 5. Just allow me to summarize or make final statements. That working together is vital in our efforts in protecting and saving communities affected by disasters, including public health emergencies and other crises. To achieve our collective efforts, countries work together and support each other to ensure that the potential or actual unmet needs are covered by neighboring countries or other regions, or within the region or other regions. However, there are challenges that hamper our efforts. This may be given as part and parcel of our work, because if there are disasters, there will really be chaos. However, disaster risks are also not static. They evolve as the community, the environment, as well as hazards and other factors also evolve. The disaster health management system also evolves. As I also mentioned earlier, people move on. Leadership and management systems also change. On the other side of the coin, there are valuable experiences, practices, and lessons that address them. So exchanges of experiences, including what we are concluding now, and other knowledge management activities are vital in addressing, if not preventing, these challenges from happening. So on this note, we express our appreciation and gratitude to our esteemed speakers, Ms. Janice Calexto, Dr. Krengsak Penthetam, Mr. Taro Kita, Mr. Sohel Resh, and Mr. Dr. Mario Madrigal. So with that, let me give back the floor to the MC. Thank you.
Thank you very much. Let's give a round of applause, ladies and gentlemen, to our moderator from ASEAN headquarters, Mr. Jim Katampongan, and our 5 panelists for these sessions. May we request all of you to please rise, as we'd like to present you all with our tokens of appreciations. And Mr. Jim, kindly join our group front and center as well. And to present our appreciations, may we kindly request the president of the Japanese Association Disaster Medicines, JADM, Mr. Masato Honma, onto the stage. Please, sir. May we first present our token of appreciations to the moderator from ASEAN Secretariat, now known as ASEAN Headquarters, Mr. Jim Katampongan, as an expression of our gratitude for helping us navigate the discussion for the 5th session of the conference. And as for Ms. Janice of the Philippines, we believe we have presented you with our tokens the other day. We'll present you the next one, sir, to Mr. Kriangsak Pintatam of Thailand. Thank you very much. Because we don't want to add more weight to the bags on her flight home, Ms. Janice. Thank you very much. Sir, may we please now present to Mr. Suel Rash, jump over one person, for his, Mr. Suel Rash, do we have that? I think we have that on the name. Apologies for that. On my list here from WHO, thank you very much indeed. Merci beaucoup again. And to Mr. Taro Kita, on behalf of ARCH Project, thank you very much. Arigato gozaimasu. And last but not least, already presented yesterday, Mr. Mario. So we thank you again for these sessions. There's no need to bring 2 tokens. I think one would be enough for each of our delegates. Thank you very much, ladies and gentlemen. May we have this moment, Mr. Masato Honma at the center for a group photo, please. And now to our master photographer on the count of 3. Everyone, 1. Yeah, 1. That's good. On the count of 3, once again, 1, 2, 3. One more time, 1, 2, 3. A big round of applause, ladies and gentlemen, for session 5 of the conference. Thank you very much, Arch Project, the Philippines, Thailand, WHO, and Costa Rica for such an invaluable experience sharing for the sessions. Thank you indeed. May we request that you return to your seats. And thank you, Mr. Masato Honma, for presenting. Ladies and gentlemen, we'll now take a 15-minute break. I've been informed that some of the most distinctive delicacies in the form of the so-called Semar Mendem and also Surabi of Solo, Surakarta have been served to your delight. So please enjoy alongside your coffee and tea. Ladies and gentlemen, we'll see you in 15 minutes. Thank you very much. Hi, hello. Yes. Yeah. Okay. Oh, that's you? Mr. Rio Macayano. How can I help you, sir? Unfortunately, the one who will introduce you is the moderator. Okay. For the presenting of that flag, yeah. Yes, I will be announcing. So is that W Center for Health Development? Okay. Yes, it helps from WHO. Thank you very much, Mr. I'll take note of that. Thank you, Mr. Yeah, that's you. Distinguished delegates, ladies and gentlemen, we're here announcing the start of the next session in just a few minutes, requesting participants to enter the ballroom. Please bring your coffee and tea with you. Our next session will begin very shortly. Thank you. Delegates, ladies and gentlemen, your attention please. Another call to our participants outside. The final session of the conference will begin in just a few minutes. We are all set and ready to begin. May we have all of our participants join us here in the ballroom and kindly take your seats. Thank you.
bicara belum lengkap ya. Ini kita udah lewat 10 menit dari waktu seharusnya mulai. Pripun niki. Tidak ada anggota.
May we call upon our speakers of session 6 to kindly take your seats and be prepared on the right side of the stage. Our session will soon begin. Once again, requesting speakers of session 6, kindly join us to prepare and get set up on the right side of the stage, please. Thank you. Distinguished delegates, ladies and gentlemen, welcome back to our conference here in Yogyakarta Special Region. We have now arrived to the sixth and the final sessions of our conference here, which will further talk about further promotions for the AAN activities, including publication of the ASEAN Journal and joint research on DHM. And may I introduce our moderator to help us navigate through the discussion today. He is a representative of Japan Advisory Committee, or JAC. His professional experience includes leader of the Public Health Module, or EMT, Initiative Corresponding Unit of the Japan Disaster Relief, chair of the WHO Emergency Medical Team Minimum Data Set Working Group. It is my immense pleasure to introduce our moderator, Mr. Tatsuhiko Kubo. A round of applause, please.
Thank you very much for a very kind introduction. Thank you. Thank you very much for coming back. So this is second ASEAN Academic Conference on Disaster Health Management, session 6. This is going to be a last session, and I'd like to appeal my sincere gratitude to all of you that you keep up on this final session. I know you're very busy, but I really appreciate your great commitment till this end of this great 3 days. Session 6, this is about future promotion for the ASEAN academic network activities, including publication of the ASEAN Journal and joint research on disaster health management. And allow me to say, this is our session. This is our future steps. And yes, I will ask you, ask to the panelists or the presenter to introduce your great knowledge and so on. But please be very sure this is about future steps. This is about our future. So all of you in this room can more than welcome to speak up, including the students on the back side. Please be very sure that this is our session, very important session toward the future. So there's a framework here. And as a first speaker, let's first check what is the exact framework for this ANN, ASEAN Academic Network. So allow me to introduce Mr. Ikeda Shunichi. And he is, of course, we all know he's the chief advisor of this ARCH project. And he will be presented ASEAN Arctic Network Framework, Operation Policy and Strategy, and Plan for the ASEAN Journal Publication and Joint Research. Let's check and learn what is confirm again, what is a framework and our policy. Mr. Ikeda, please. Round of applause, please.
Thank you. Thank you very much, Mr. Moderator, Kubo-sensei, for your introduction. And also, good afternoon, ladies and gentlemen. Yeah, this is second of my presentation since yesterday also I conducted. This time I would like to share our new challenge for ARCH project. Actually, maybe new challenge and the biggest challenge for all of us to start up and activate about the academic activities under the ASEAN Academic Network. Before I move on to my presentation, I just touch upon about the strategy of the ARCH project. Actually, the key, most important strategy for ARCH project is knowledge co-creation as well as the mutual learning. Yes, you know this new word, knowledge co-creation. We use the word for this academic conference. Yes, this too is a very important keyword. But in order to realize actual knowledge co-creation and mutual learning, we believe that activity under the ASEAN Academic Network is most key challenge. I don't have any COI for my presentation. Yes, I just remind again about the background, but actually our colleague from the previous session, Janice from Philippines and Thailand, Dr. Danak, and Kita-san mentioned a little bit about the POA. We have the POA in this region to how can I say, push for the activity for the disaster health management in this region. Under this POA, there are many targets set for the relating to the academic activity, including the establishment of the ASEAN Academic Network. And finally, the November 10, 2021, and when the ASEAN senior official meeting organized and endorsed terms of reference of the ASEAN Academic Network as a main mechanism to support achievement of above regional and national target under the POA. And 14 May 2022, terms of reference of ASEAN network was adopted at the ASEAN Health Ministers meeting. And finally, the DHM was officially established in this region with objective of promoting and supporting the academic research and learning initiative of AMS as a mechanism to assist in the realization of the objectives, including the national and regional target on knowledge management of POA. Yes, this frame, actually, Dr. Kriansak also mentioned that is a two engine for the proceeding about effort for the improvement of the regional capacity in this region on the DHM. ASEAN Academic Network is one, especially responsible for these kind of activity for the promotion of joint research, etc., etc. And all countries, AMS 10 countries already assigned the National Focal Point Institute as a core member for this institute. Now each country trying to increase the more member institute from each country. Steering committee is a decision-making organization and a platform for the activity of AAN. And right-hand side, yes, they have the ASEAN policy framework for the health development. The RCCDHM and the steering committee as well as ASEAN network can be double engine for the moving on the more improvement of this region. Yes, this is the role and the responsibility of the AAN. Actually, there are 12 the main role and responsibility. Like number 3, yesterday in my presentation, I mentioned a little bit, the AN should promote and support educational training activity of AMS by mobilizing resource person, developing training curriculum and learning material in this network. They share the resource in this region for the training program, and also the 7, the organized regional conference once 2 years by yearly. That this is this meeting, this conference. And the new one, that is very, also very challenging for us, the established and publication of the ASEAN Journal. And also we have to activate joint research under the activity of ASEAN Academic Network, number 9. And also 10, complementary learning activity with such kind of another policy document as well as another policy framework of ASEAN in the field of health development. It means that this Hawkins role saying that AN is required to conduct some kind of the policy recommendation to policy level based on their experience and knowledge. This table listing the member institute in this ASEAN Academic Network. As I say that all of the countries already assigned their national focal point institute as a core member. However, now still the core member is not enough as a strong network. We have to encourage all national focal point institutes to recommend many more the educational and some kind of practical institute to be member of this. And Singapore already nominated 4 institutes as a new member. That was already endorsed by steering committee. And also Thailand also submitted 2 new members to be member of this AN. And as an external member, according to the TOR of this network, AN can invite external partners to be the member of AN. And JADEM, Japan Advisory for the, Japan Association for the Disaster Medicine, also submitted the membership, and this was also endorsed and approved by the steering committee. Thank you, JADEM, Professor Homa, you are chair of this JADEM. Next, yes, as I said, that is very challenging for us, for everybody. We would like to publish the ASEAN Journal. Title of the journal is ASEAN Journal of the Disaster Health Management. The status for this journal should be regarded as official journal of ANDHM, and we expect this shall be published, responsible for the publication by AIDHM. And the objective of this this journal is to provide the opportunity for young medical practitioners and all healthcare providers in the relevant field of DHM, the researcher who may be inexperienced in the writing English paper. That is an entry paper for the younger researchers. And the recommended area for the article, of course, we have to respect the ASEAN interest, and also WHO has some kind of the research framework network, so-called Health EDRM. They have the 5 research priority areas. Later on, the Dr. Kayano from WHO, Kobe, explained a little bit more about this. And also, we have to consider some topic and article relation between the public health and disaster. We have to respect and also align always to the WHO EMT global initiative. And collaboration between the health sector and non-health sector in DHM is also important as one of the important article, possible article. Target authors, as I already mentioned, yes, young and experienced researcher, medical practitioner, and healthcare provider. And we also invite article from the other region consistent with ASEAN priority areas. And also, we expect a review article for not only disaster medicine and public health science, but also in various fields of disaster science are very welcome to promote interdisciplinary collaboration. The target leaders, yes, medical practitioners, healthcare workers in relevant fields, researchers, disaster humanitarian aid workers, decision makers, disaster scientists who are involved in, have the interest in the ASEAN DHM. And the condition, other condition for the publication, we have to consider, we have to have very strong editorial board. We have to consider to invite some of the international influential academicians to maintain the quality. And also, regarding about the frequency of the publication, according to the POA, they are required to publish twice a year, but it might be difficult immediately. Therefore, we start gradually, and gradually increase the number of the frequency. And the submission fee, this should be affordable because our target author is a young researcher. And access policy, yes, for time being, AIDHM shall bear this cost for the access, free access. And journal indexing, maybe this is very important for the receiving some kind of the international reputation. But we have to start from the Google Scholar, but we also consider to search some another possible indexing. And maybe we have to take more time for this kind of thing. The aim of the initial publication support by Arch project. Arch project will be continued up to March 2026. During this remaining period of the Arch 2, we would like to support the new challenge to develop and establish a sustainable publication mechanism for the journal. Yeah, actually, Arch project would like to support to publish first one and the second issue until March 2026, along with the aims of the identifying and analyzing the relevant issue for the development of the publication mechanism. As I already mentioned, yes, editorial board is a very important, a reviewer also very important. We have to start up to recruit and also consider how we can have the very good one. And the publisher also very important. And journal indexing, as I already mentioned, yeah, collaboration with other academic partners is very important. The financial sustainability. During the Arch project, maybe JICA can fund, but without some kind of the financial sustainability, after the Arch finish, gone. I don't want to do such kind of thing. We have to discuss and consider what kind of sustainability can be possible to draft a sustainable and appropriate budget plan for the future publication based on the analysis and the review for the actual publication cost, first issue and second issue. And through such kind of the trial publication, maybe we would like to analyze the financial possibility for the future sustainability. And of course, we have now AIDHM. The day before yesterday, 17th of September, AIDHM officially opened. Now we have to, how can I say, clarify the management system. This is a very important role of the AIDHM. And plan for the first publication of the ASEAN Journal. Yes, during this presentation in the ASEAN Academic Conference, we would like to encourage the selected presenter to prepare to write the full paper for this journal. And maybe we expect some time of early period of next year, we would like to publish this article. Another the new activity the POA saying that the joint program. Also, we would like to facilitate this one. And the ARCH project will support the Joint Research Project 2022 as a startup program under the ASEAN Academic Network to test the necessary procedure and mechanism, so and so, so and so. And we, ARCH project, provide very tiny seed money, 2 million Japanese yen. Now, because of the Japanese yen is getting weaker, therefore, maybe it's more smaller by US dollar. But anyway, we would like to start up. And we have a designated theme. And Kita-san already explained, but yes, some of the organizations already proposed for the theme 1 for stabilization of the EMT medicine and equipment. And National Bang Hospital veteran, and for theme 3, level of the health facility preparedness for the disaster. Actually, 3 member institutes already submitted, and they negotiate each other, and they finally negotiate a compromise. These 3 proposals can be integrated into the one single project. And after this meeting, maybe soon, and maybe some kind of, maybe we have to announce another member institute for asking your interest for the participation as a co-researcher for this joint research. The future strategy, yes, still it is necessary for us to seek possible collaboration with WADEM, PDM, APCDM, JRM, and WHO, etc. And we have to also encourage national focal point to nominate more members, and we have to activate the function of the AIDHM and to create a mechanism in order to secure the academic quality to pursue the financial sustainability for the academic activity. Yes, again, advertisement. Yeah, actually details, we are using this supplementary issue of the PDM for brochure to explain about the PDM. Please access this paper. Thank you very much.
Thank you very much, Mr. Ikeda. Is there any burning question we would like to take it? But it is good. Okay, taking the time schedule, let's move to the next one. So what Mr. Ikeda suggests is that there will be the two pillars we need to consider. One thing is the journal, and next pillar will be the joint research. And the next session, next presenter will be from the just joint research part. Allow me to introduce, Thank you. Allow me to introduce Dr. Nhan Tien Don, specialist in surgery and wound care, Vietnam National Burn Hospital, Vietnam Military Medical University. He would kindly present his proposed research, about his proposed research. Dr. Tan, would you please?
Thank you, Dr. Ko. Good afternoon, everyone. I'm on the behalf of the Vietnam teams, and now I would like to present the topics evaluate the current medical toolkits and practical skill of EMTs in ASEAN country. These studies belong to the theme 1, standardization of EMT medicine and equipment in the ASEAN regions. Introductions. So you know that EMT is play one important role at the SAN in the reducing the mortality and the mobility due to public emergency and disaster. To ensure the success of EMT response properly, medicine and medical equipment should be qualified and meet with the need as required. As above mentioned, the question is whether the existing EMT toolkits, needs and drugs and equipment with and among the ASEAN countries are similar, and are there any standards for since the ARC project have been implemented with the slogan "One ASEAN, One Response." Therefore, it is necessary to investigate and evaluate the current status of the medicine and equipment of the EMT amongst ASEAN countries in order to serve as a basis for the policy formulation and the develop minimum standards for EMTs in response DHM within country in the regions. Objectives, this study, there are two objectives. The first one is we would like to assess the situation of the EMT medical toolkits, the similarity in the medicine and medical equipment of EMTs in the ASEAN regions. The second one is we would like to assess some knowledge and practical skill and using medical equipment of EMT members in the ASEAN regions. The methods, studying the design, a prospective descriptive cross-sectional study conducted on 5 targets of ASEAN countries. The studying partners utilize invite JICA, NIEM, and 5 targets of ASEAN countries join this study. The research location, MOBS and others, Center Hospital EMTs, Dispatch Center, and the EMT member. The methods and the research context. A two-step surveys will be conducted on the following aspects. The first step, we will systematically investigate most normative document decision documents of health department and the director of hospital EMT's departure center on the establishment and development of EMT. In this step, we would like to identify the EMT classification, regulation, and the establishment of domestic and international EMT team, lead up medication and medical equipment for each type of EMT. Next one, we would like to identify the deployments of EMT, for example, type human resource facility, list of medicine and equipment. Next, would like to identify the existing medication, medical supplies and equipment, packaging, preservation, periodic maintenance, schedule, periods operation, replacement, rotation of the medication and medicine supply and equipment. The second step, we will create a checklist for evaluating the knowledge of practical skill of EMT members. For the knowledge of EMT members, we will classify the type of disaster, national disaster, man-made disaster, and EMT according to whose standards, types of EMT function of EMTs. In that, we focus on EMT type 1 mobile and type 1 physics, logistics of EMT type 1 mobile and EMT type 1 physics, and organization and function of EMT CC. In that, we would like to know the office setup of EMT CC and the function of every member joins in EMTCC. For the practical skill of EMT member, on this, we would like evaluate practical skill of EMT member for common accident and injuries in disaster as A, B, C, D, E procedure, for example, drowning in first aid, CPR, external bleeding management and bone fracture. Wound care, for example, bandage, burn management. On site, we would like to evaluate practical skill of EMT member in using medical equipment, supply, and toolkits. In that, we will create a questionnaire and checklist and the theory situations. In theory situation, we give out the list of victims, of disaster victims with the injury, the chronic disease and acute disease, and all the members of the EMT will triage as by the start process and transporting this victim. The next one is the operation of medical device medicines. We check practical skill for the using the laryngeal mask, AEDs, and electrodegram, hematology analysis, and urinalysis machine and ventilators. The results of statistic analysis. The result of survey will be recorded, code, and analyzed by using Microsoft Excel and Stata Trials software. Expected outcome. We would like to know to give a report on the characteristics of existing EMTs in ASEAN region and report the similarity of the regulation on and reality of the medicine and medical equipment of EMT in ASEAN region. The next one is reports on practical skill in using medical equipment of EMT ASEAN member. Recommendation of standards medicine and medical equipment of the EMT in the ASEAN region. And the last one is the publication on the ASEAN Journal of Disaster Management. Ethical consideration. The collected information will be kept confidentiality on the use under permission and for research on recommendation proposed only. This is Bucharest plan summary. Total is $14,000. Thank you for your attention. Thank you so much.
Thank you very much, Dr. Don. Now the question is open for the call. Anybody one? So, Dr. Don, may I allow me to make one question. In your method section, you suggest that JICA will be the partner of your research. And do you suggest that you wish to get a list from the Japan team, or is just just a technical part? And no, do you need a list from Japan team or not? May I question these things?
Yes. Thank you for the question. I think that's for the EMTs. For the various of studies, I will create the checklist and questionnaire based on the WHO's EMT standards and others related, for example, the Japanese EMTs and other countries for create the questionnaire and listen for a checklist to conduct this survey. Yeah.
Thank you very much. I do believe the Japan team is also very happy to contribute to your information gathering. Thank you very much.
Yeah.
Dr. Don, thank you very much. Round of applause, please. So allow me to invite the next speaker, Ms. Mariami Yuliana Kosmi Ami-san, from the Assistant Professor of the Department of Emergency and Critical Nursing at the University of Gajmara. Ami-san, please.
Thank you very much, Kubo-sensei. So, thank you very much, gentlemen. And I would like to express my heartfelt gratitude for the opportunity to be able to stand here on behalf for member states, Indonesia, Thailand, Vietnam, and Singapore, to introduce the plan of Joint Research Project in Asian Academic Network 2024. So our proposed title is the implementation of Hospital Safety Index in Asian region. Let me introduce myself. My name is Mariam Yuliana Kosim from Department of Basic and Emergency Nursing, Faculty of Medicine, Public Health and Nursing, University of Gajah Mada. And I have a distinct honor here to be the main researcher. So actually, currently I was quite anxious to have that such great responsibility since this joint research project for the designated Team 3 level of health facility preparedness for disasters, such like what Ikeda-san previously described, that it's already through so many processes. So there are 3 proponents from Indonesia, as me as the main researcher, and then from Thailand with Dr. Rapipong, and then from Vietnam with Dr. Nguyen Nulam. Then we agreed that the proposal from Indonesia with the title Profile of Hospital Preparedness Level and the Challenge in Developing Assessment Tools in Asian Region become our topic for the joint research project in designated Team 3. Then after long coordination through online meeting, so finally yesterday we have the opportunity to meeting directly, of course facilitated by Art Project, Kita-san, thank you very much. And I finally also able to meet the co-researcher from Vietnam, and then also from Thailand, and also we're welcoming the member of the research team from Singapore. And here, actually we have quite tough yet insightful discussion. So the one that we agree from beginning is that we thought we agree that HSI, Hospital Safety Index, is an international standardized tool. Therefore, it is better to use or refer HSI to evaluate the level of hospital disaster preparedness. Therefore, there are so many research considerations that comes from our discussion. From the previous report, that the assessment tools for evaluating hospital disaster preparedness level actually exhibit significant diversity. So there are many tools if you want to find in the internet about how a country evaluate its hospital disaster preparedness level. And then the other consideration is the impact of health policy, that the implementation of HSI can be influenced by the healthcare policy in the respective country. And then also the need to familiarize with HSI. That is, it is imperative that each participating country becomes well-versed in HSI to ensure the effectiveness of the implementation. And then there are, of course, since this is a research, and then we want also the good quality of research, and then we have so many heads joining in this discussion. Then there are some technical considerations, such as the inclusion of multiple countries in this joint research, and then how to manage the constraint related to time and budget, and then to define a research methodology which align with the research objective. So here we discuss what are the research objective, methods, and outcomes best served to the current need of Asian countries. And then here, finally, we come to one Asian, one response. We agree that the research objective will be checking on how familiar the hospital on using HSI here by asking the main or backbone hospital from each country to evaluate hospital preparedness level using HSI. So this can be the quantitative method. And then after that, we asking the gap or their challenge on implementing the HSI. So this could be a qualitative method using phenomenology or phenomenography, just like asking the probing question like, what do you think of HSI tools? Which part do you think is important or it is useful? And then what your challenge on implementing the HSI? And then, so way forward, there are still so many discussions that needed to finalize this research plan. Therefore, according also the information from Art Project, that we will invite more of the member of the state, ASEAN member of the state to join this research team. So I encourage the other country, Peru, Malaysia, Brunei, and then Philippines here, Laos, and then the other one, also Myanmar, or even Timor-Leste to join this research. Then probably we will get the invitation from Art Project on November. I don't know the exactly process that will be going on, but the research plan finalization will be in December. And then, of course, the schedule of starting the research will be starting around January or February next year. Thank you very much. That's all.
Thank you very much, Anton. Any question or comment from the research group? No? Oh, Ega-sensei, please.
Thank you very much. My name is Shinichi Egawa from Tohoku University, Japan. And my question is about the conversion of the current tools to evaluate the hospital preparedness for disasters in each member states to convert it into the HSI. Of course, you can also survey the current situation of how they evaluate the hospital safety, not using HSI, but using this tool and this tool, this tool. And if it is easier to convert these indexes into the HSI, or converting HSI to interpret the current using tool, maybe another option of this research. How do you think about that?
Thank you very much, Sensei. So actually that kind of question also already emerged in our discussion yesterday. And then again, we thinking about the constraint budget and timeline for doing this research. And then to converge either from the existing tools that country use to the HSI, or vice versa, I think it's need quite a lot of time. Therefore, our agreement yesterday focusing on, well, at least we get the country or the subject of this research to be familiar first with the HSI. And then after we got some information, some confirmation through that process, probably, of course, the next stage, we go through that, the one like your idea, to how to adapt the HSI tools to the country evaluating tools for hospital disaster preparedness level.
Thank you, Am-san. Any other comment or questions?
Yes.
Please, madam. Please identify yourself. Thank you very much.
Thank you, Kubo-sensei. My name is Rosa. I'm a researcher at the Tsunami and Disaster Mitigation Research Center, Shah Kuala University Aceh, Indonesia. And I'm very interested to add some comments, yeah,
Okay.
and your idea about implementation and adaptation of the HSI is very fascinating for me, because this I'm concerned about using uniforming tools, yeah, because there are local wisdoms, yeah, from each of the hospital to overcome their challenges. Probably you can add, yeah, some more question about how they overcome their challenges if they are not into that specific, yeah, certain specific items of the HSI. Yeah, and I'm more than happy to join your team if
Thank you very
may,
much.
you may want me to. Okay,
Thank you
very much.
Yes, thank you very much, Ms. Rosa. May I directly? Yes, Ms. Rosa, actually, your question also has been discussed yesterday. So we found that, as I mentioned before, that the incorporate policy or considering policy of each country also affected the implementation of HSI. So probably there are some country that has focused on one topic or one theme for their hospital, so, or one specialization for their hospital. So of course, and that point, we cannot really force them to use HSI. So also the question about how actually the policy, the internal policy affecting the implementation of HSI also will be one of the question that we think about. Thank you.
Thank you, Am-san. Any other question or comment? May I ask, so in this case, may I ask one thing?
Yes.
As far as, for my understanding, you have, it was great to see that yesterday you did a face-to-face meeting
Yes.
with Indonesians and also the Thailand and Vietnam plus
Yes.
Singapore.
Yes.
This is a great thing. And but I remember that you did that kind of the meeting by remotely 2 months ago or something like that.
Pardon,
Sorry.
the last part.
I also remember that you did the research meeting by the web system
Yes.
remotely 2 months ago in August
Yes.
or something. And how do you think how do you see the difference? Do you think you can continue your research only by the web meeting, or do you think you need to gather up some time and do the face-to-face meeting? What is your feeling or understanding now?
Thank you very much, Sensei, for the question. So, yes, the greatest challenge is that even though we have the technology, the online technology, still it not really par to the situation if we meet directly. So then, yesterday, even though previously we already agree, and then we have also coordinated about the research plan through email and so on. Yesterday we finally can address the true concerns of each member. So therefore, probably the answer of this concern is that we need either, so this is, I'm asking directly to us project, either greater, bigger budget, or the other facility that can let us to meet directly for at least 2 or 3 times, at least for discussing the main concern of the research. Thank you very much.
Thank you very much, Amsan. I think that we will note it in the record of this official meeting record, and maybe Ikeda-san will be very nice notice now. Okay. So, any other comments? No? Good. Thank you, Amsan. Round of applause, please.
Thank you.
Okay, thanks to these three distinguished speakers, now we clearly understand this is under the ASEAN Leaders Declaration Plan of Action number 5, and there's 2 pillars, journal and joint research is now a very standing item for this session. And from here, now we are moving into the panel discussion session. There will be 6 distinguished panelists we will onboard soon. But before that panel discussion, allow me to invite 3 speakers, one by one. And so the first speaker, Dr. Acharya Paranaga, Director of the National Institute of Emergency Medicine, Thailand. Dr. Acharya, would you please?
Good afternoon. Thank you, Professor Kobo. Ladies and gentlemen, for my session, I would like to make a promotion about our ASEAN Academic Network. And from the earlier presentation from Mr. Ikeda, talk about the IDHM, ASEAN Academic Network already, and also our previous moderator or panelists talk much about the journal and also the research. But for me, I think I don't want to leave out one thing that is important too. That's why I want to propose the idea for the additional for ASEAN Academic Network. For the ASEAN Academic Network outline, has been listened earlier about the research, joint research program, or ASEAN Journal on Disaster Health Management, and ASEAN Academic Conference that we have it today. One thing I would like to propose is a training. The training is I think is one of the key of the knowledge sharing to our ASEAN member state and also to the member of ASEAN Academic Network also. For my idea that for the training, normally in Thailand is also, we are facing for this problem. Normally we give the training for the medical personnel. We do a lot. But one thing we are left is executive. It means that they are leaders. It means that even they know. It means even the medical personnel know. But when they get back into their office or maybe their country, it's important that their leaders doesn't know why and how. This is I think I would like to propose in multi-level of training curriculum that it could be developed for our ASEAN member state or maybe ASEAN Academic Network. For the executive level, the high executive, what about the SG, DG, or DDG? I think no one of them here except me. It means that they need to know something, especially disaster is a big one, but we're talking about disaster health management is one of the sector of disaster management, that's right. That's why how we could make them understand what it should be managed, or how are they supporting you. Because you are a worker, that's right, you have to make many things, but how they could support. Even if we have the IEMT, if we are wanting to go to somewhere for this disaster area in any part of the world, but they may not understand. They say, no, wait, no money, no support. It means you cannot go, that's right. This is the thing that I'm proposed, that it should have some kind of this. For the operational level, yes, sure, we have to do many things for the training course, disaster training as exercise, disaster for specialty training, or EMS and disaster operation support. It means many kind of knowledge that it could be shared. One thing is important also is the citizen level. It means how the citizen could be learn how to protect themselves or maybe how to save themselves before we get in. That's right, we are the medical team, that's right. How long or how fast that we could get in there. Maybe a day, or maybe 2 days, or maybe a few days. It means how the people could be live during waiting for our team get in. Sorry. Just an example, this is the training course that our colleague mentioned earlier about the B course. BDHM, Basic Disaster Health Management, is an instructor, is a group of Thailand experts that work with the JICA team, work with the Japan team to set up the training course. For this course, I think many one from this room may join for the mock-up training in Bangkok already. That means in any country that we want to set up, I heard that Singapore interest to use this material of this training course. It could be, or maybe it could make the training for our member state also. For the C course, disaster health management coordination course is one of the important things that we conducted this training course in Malaysia already, and how it could be happen in another country. Did some country want to have this course? Please raise your hand. Oh, many. Okay, interesting. Ikeda, please, please support us. Okay. Not only this is for the whole picture of the health. This is a health management. That's right. But something is maybe need to be added to this because this is a wide picture. With some specific incident, it could be something like a CBIN. We may have a training course like a hazard area response team to facing with the hazard, chemical, bio, radiation, nuclear, or something. Or the mass casualty simulation. We may call major incident. The medical response to major incident, disaster is a big one, but if someone is a smaller, something like a bus accident or maybe like an airplane crash, it may not like the big disaster like a natural, like an earthquake, but how do they practice? This is the thing that if we practice day by day for the disaster management should be good also. In some area, they may need to have some special vehicle like a helicopter. How did our medical team could fly? Normally we use the land transport ambulance, but somewhere that earthquake can break the road. The road cannot go there. How to go there? Maybe by helicopter. I don't want to let anyone learn how to jump for the parachute jumping. Did someone want to fly with a parachute, jumping, get into the scene by medical equipment with parachute jumping? I think it's too dangerous for us. But for the helicopter, it could be. We can have something like this. Or in some situation, not only for disaster, natural disaster, or maybe come from the man-made, the tactical EMS may need to have that knowledge also. Oh, sorry. It's gone. Okay. Or some others. This is just only example. Radio communication, transportation, whatever. This is the thing that we could have it for our training course for the ASEAN. And also for the public, CBRAD should be the fundamental. How could they know how to save themselves with a very basic thing that they should have this knowledge before our team to get into that one. Okay, this is my idea. Just give the idea, don't follow all. But and also maybe some country that have the capacity. Indonesia have a lot of training course. I heard that our friend from the WHO said that we have the training course, EMT coordination course in Indonesia. Maybe it could be make some kind of this for the ASEAN. Thailand can have some, Singapore can have some, Malaysia can have some, or our friend Myanmar, Vietnam, Laos, Cambodia, Brunei, Philippines. I think we have many courses and many capacity, we can share. Unfortunately, tomorrow I cannot join for the steering committee because I will hand over to the new chairperson. But I will propose to the steering committee that this is the idea I want to propose to the team to make it happen in the future to strengthen our ASEAN with the ASEAN academic network on disaster health management. Thank you.
Thank you very much, Dr. Acharya. So maybe we will take the question later for you. Thank you very much, sir. So, now the peer is expanding thanks to the great insight by or guidance or led by the Dr. Acharya. Now we can include the training part. This is a very critical part of the academic framework, I think. So let's have this next peer within this next coming session. Allow me to introduce Dr. Dr. Masato Honma, President of Japanese Association for Disaster Medicine and Professor of Emergency and Disaster Medicine. This is my great privilege because I feel very honored because Japan is a part of the Arch family for the long years, as Dr. Pumin kindly mentioned. But now, thanks to the Dr. Acharya and also the Thai friend with the recommendation, as noted by Mr. Ikeda, Japan Association of Disaster Medicine officially becoming a member institute of this great AAN. So please welcome our president, Mr. Professor Honma. Professor Honma, please.
I'm very happy to have a privilege to talk here. I'm Masato Honma, and the touch allowed me to talk only 8 minutes. So I set the timer here, and if the sound ring, I stop the lecture. So anyway, today I'd like to talk about the overview of the JADEM and the possibility of cooperate with the ANA. Let me introduce myself. At the great tsunami disaster in 2004, I deployed to the Thailand, Bangor province, my pronunciation is correct, Bangor, as a member of the JDR medical team. And this experience influenced me to the establishing Japan DMAT and aeromedical evacuation system. This is a picture of the children who might lost the relatives, father or mother or brothers or sisters. And I didn't realize at that time that 7 years later, we saw the same thing in Japan. This is a successive president of the JADEM. This is Muneo Ota. With this leadership, our study group born in 1996 and became a society 2000. And this is Yasuhiro Yamamoto and Yuichi Koido, who presented yesterday about the synergy of the JDR and DMAT. And this is Professor Yasuhiro Otomo, who is president of the WADEM 2025. It's me. This is one of the goal of the JADEM. And
contribute to the development and technical improvement of a wide variety of people involved in the disaster. This is an important word, variety of people, and contribute to the preservation of the lives and health of the nation. This is the general information about our society. A member is about 5,000, and including the student members. The task is hold the academic annual meeting a year, publication activities, academic journal twice a year, committee activities, educational activities, and we hold the training course and textbook. This is the member of occupation. We, not only the doctor and the nurses, we have a lot of people who have a background like this. And we have academic journals published since 1996, twice a year. Japanese papers with English abstract, peer-reviewed and online journaling. And we have a training course and textbook publication. We can buy these texts by Amazon.com, but only written in Japanese. DMAT, CBAN, mass casualty, terrorism, mass destruction, and disaster pharmaceutical affairs. Japan is not an ASEAN member state, though. We are sharing disaster-prone background. We have overcome many disasters through the ARCH project since 2016. We have challenged together to develop capacities. We are proud to be ARCH families. And academic activity is border-free, so it's a time for Japan officially to join the network. So this is the official agreement to become an additional member. And we have an international committee. Katsu is in charge of this committee. So our society can cooperate with ANAR. These things, I think. So far, we have internationally cooperated with WADEM, APCDM, and JADEM. We have a three-layer, and this is important that the three society have a seamless scientific point. For example, this is the first annual meeting and the publication of JADEM in 1996. This is a picture of the Steve Lottman, who was the president of WADEM at the time. The president at that time was Ota Muneo, and he invited Lottman to have a lecture. And Lottman gave us a paper for first publication of the JADEM. And the fruit of this exchange will help us to impact positively those mass population health emergencies, which are our inevitable future. This is exactly the same. So I think it is very important to coordinate with WADEM, APCDM, and our society. This is a poster of the WADEM Congress, which was held in 2025. So I told that Professor Yasuhiro Otomo is the president of this conference. So I think everyone here will go to Tokyo to attend the meeting. I think that JICA supports some. Anyway, time is running, so this is the conclusion. Thank you very much.
Thank you very much, Professor Honma. We all hope to see you all in WADEM 2025 in Tokyo. Thank you very much, sir. So the next speaker, allow me to invite Dr. Ryoma Kayano, Technical Officer of WHO Kobe Center, Center for Health Development. Dr. Kayano, please.
Assalamualaikum warahmatullahi wabarakatuh. Distinguished guests and delegates and colleagues and also experts from all over the world, selamat sore, good afternoon. My name is Ryoma Kayano, Technical Officer of WHO Center for Health Development, which is a part of headquarters but located in Japan, Kobe. Because of the history of the establishment of Kobe Center, we were established as a symbol of recovery from a huge earthquake 30 years ago, Great Hanshin earthquake. That's why we are part of headquarters but located in Japan. So that is why we are called as Kobe Center. So first of all, I'd like to say big thank you to the conference organizer and also JICA for inviting me to this very important opportunity to see the great momentum of ASEAN region. And also it's very closely linked to the WHO Global Initiative to better protect people from emergencies and disasters. In this two-day conference plus the pre-conference seminar, I found a huge progress on disaster preparedness and response capacity in ASEAN countries, which is also highlighted by your efforts for the EMT-related activities and related capacity building, and also your focus on the hospital safety index, which also promoted by WHO. And I want to say that this great progress in operation, but for further successful development, scientific evidence will be the key. So that is why this session is very important. So in my speech, I'm going to briefly introduce WHO's recent efforts to address the improvement of scientific evidence on health emergency disaster risk management. Let me check. Okay. This is the history of our effort since 2016 to 2023. I don't go into detail because I don't have so much time, but let me share with you. Please remember 3 names of the document and the 3 key players. So 2 things. The first one is this. Next one is this. 2 documents. First one is 2015 document, Sendai Framework. It's a global framework to see the direction of the strategy of global society, how to do disaster risk reduction, which was developed by UNDRL. In 2019, to respond to this momentum, WHO developed this framework, Health Emergency Disaster Risk Management Framework. This is developed by WHO DRR unit. So those 2 documents and 2 key players, please remember. Then in Sendai Framework, for the first time in the history of the DRR, health was very much highlighted. That is why WHO is working very hard to implement Sendai Framework from health aspect. That is why we developed this WHO Health EDM Framework too. But to do some good research, good policy and program, we need scientific evidence. And to produce good scientific evidence, we need research. So that is why WHO established in 2018 Global Research Network. This is, full name is the WHO Health EDM Research Network. It's a global mechanism to promote research. And this is a picture of the first our core group meeting held in Kobe, Japan. And we, WHO Health System Research Network, currently have over 300 experts from 47 countries. And our co-chairs to support the facilitation is from UK and Australia, Professor Virginia Murray and Mr. Jonathan Abraham. Our center is located in Kobe, Japan, as working as the secretariat of this research network. And every year in November, usually, we convene the WHO headquarter focal point and all 6 regional office focal points to discuss the strategic direction of the disaster health management research. This year, it will be held on 14th November. If you have chance, interest, and budget to come to Japan, please visit us. You are always welcome to a meeting. Kobe Center is working in the secretariat, and we facilitate the global and regional collaborative research and activities. And the third document and third player I'd like to introduce, this is a WHO research methods for WHO guidance for research methods for health emergency and disaster risk management. It is a comprehensive guide how to plan, do, and report research before, during, after emergency and disaster. As all you may know, maybe doing research during disaster or just after disaster, it's very difficult. How to do it? It's very difficult. It's not standardized. That was one of the biggest challenge we identified in the expert meeting in 2018. That is why we collaborate with more than 150 experts from all over the world, from 30 countries, to write together this guidance using as a textbook how to do research. And this is I think it's very useful guidance, but it should be updated. So that's why we do the regular updates. It's to make it as a living reference. This is a second version published in 2022. And also, we are very open to everybody to learn this guidance. And so we developed the online learning materials, such as the chapter webinars and the video presentation and slideshows, podcasts. All are available on WKC websites, all free. Please use it. And also, we know that not only just having these materials, we need to do some more effort to disseminate, to let you use this guidance, to improve the quality and quantity of research for emergency. So that is why we are leading now the initiative to use this guidance, dissemination, and promote research in regional countries. And also, I to show this picture. This is a friend, Goody, and it's Madalena, who came from Gajah Mada University to the Wadham Conference in 2023 in Ireland in May. I met those people, and we gave the guidance to them. And yesterday, on Wednesday, we went to, on Tuesday, we went to Gajah Mada University, and the secretariat of the AAN I went to, and she said she has this guidance on their secretariat. That is very glad. It's good news for us. And I think we can collaborate each other to how to promote research in your country, all the ASEAN countries, and how to work together to improve quality, quantity of research. So, for example, currently we are doing some collaboration with the regional office. In July, we did a joint webinar. It's a EMLO and the EURO regional office together to provide some lectures on the research capacity building, health emergency, EDRM, and also we are thinking about a possible future collaboration with you, ASEAN countries, to do some such kind of the webinar or workshop for research to improve the evidence for better policy and program. And thank you, and please contact me if you're interested in, and let's work together for the better future. Thank you very much.
Thank you very much, Ryoma-san. So, taking this opportunity, may I allow all the distinguished panelists to come on the stage, please. So, so the chairs are please. Would you please reallocate the things? And taking this moment, so now let's check out the structure. So here's now we started from the 2 standing item, journal, 2 times a year publication, and the joint research. Currently, 2 joint research already start running beautifully. And the third one, as Dr. Acharya suggested, this is one of the conference now we are having. This will happen every 2 years. So next one will be in 2025, in the WADEM same year. And also this is a fourth pillar, as Dr. Acharya suggested, training. And we already have B course and C course, basic course and coordination course, but how we can expand these things. So the board members, chairs, panelists, would you please go up? Thank you very much. So here's a fourth standing item. And thanks to the Ryoma's input, we have already confirmed that there is a WHO HEDRM network. 300 members joined, and 47 countries are currently already joined and do some, there's a guideline for the research and so on. And what Professor Honma, President of JADEM, suggests is it is very important to think about the WADEM, APCDM, JADEM, that's kind of a structure, international structure. And I believe this is what is emphasized by the President Don of the WADEM. He also suggested in his keynote, everything should be coordinated and calibrated. We need to in line with the ASEAN academic network need to be in line with the many international, regional, or other partners' efforts. So those are the key structure, I believe. So from now, our theme or our challenge, our aim is now we have the beautiful ASEAN academic network. And 2 days ago, there's a site visit to the ASEAN Institute of Disaster Medicine. Dr. Acharya once said, this is our institute, not only for the host nation, but for the all ASEAN member states. So, but how we can promote, how we can make it stronger, how we can make it more operational, this is time for all of you to make your great input. And may I start by allow me to ask you, to Dr. Vera, that as a host organization of the AIDHM, if you wish to ask something or if you make some comment, would you please start this panel discussion, please? Yes, may I, so you can question or ask anything as you wish. Please open it. I think it works. Yeah. No? I will ask all of you what you can do for this network. Please be ready, everybody. It working? No?
Okay, thank you.
Yeah.
Okay, thank you, Mr. Chair. Yeah, I have a question for the our first of all to our member state maybe, because as you know that ASEAN Institute is not belongs of the UGM or Indonesia, but belong of us, ASEAN. So you know that we just like a newly born, and we have a mandate like for the curriculum developing and consulting, regional training collaboration drills, supporting for ANDHM, and including building a training center. So maybe you have, from the ASEAN member state, we have a responsibility to contributing or to, yeah, because me and our team now in the UGM, without you, we can work like to include all the mandate. So maybe from ASEAN member state, you can give like what the contributing or responsibility you need to push to all the to our ASEAN Institute. And so I have question to yeah, for the ASEAN, you know that ASEAN Academic Network, we have a member from ASEAN member state and non-ASEAN member state, and now we have Dr. Don from WADEM, and President of GEDEM and WHO. Yeah, we met in Ireland. So we need you give the insight or input to our Asian Institute how we can work together with you to make like a journal or publication, and we need input from you or insight to our institute. And maybe Dr. Acharya, I have a question too. How that we can draw the commitment from the Asian member state? Yeah, because we can work without support them to us. Maybe it's all.
Thank you very much, Dr. Bera. So may I ask Dr. Acharya for your kind input. Thank you very much, sir.
Thank you for give my time to speak something. I think this is a very good opportunity for our ASEAN member state to have this group of us. May I remind something that our friend talked a lot about the beginning from the ARCH project. I think the ARCH project is very important starting point. From the first 5 years, is not see much about the activities, but except meeting. And then now we grow more. That's why we have RCCDHM. It's under ASEAN Leader Declaration ALD. We have the RCCDHM, we have AIDHM. And now we have ASEAN Academic Network. For the ASEAN Academic Network itself, for the intention of the objective of this network is not only for 10 ASEAN member states. It means we can invite a non-ASEAN member state also. This is why we have our friend from WADEM, JADEM, and WHO. For me, I think this is a very important time for us. We listen from friends from Costa Rica and from another region of the world. They have the group of them, and also now we established already. For this time, for the ASEAN Academic Conference itself, unfortunately in Thailand we host that, but we do online, only short. It's not much to see and face-to-face and discuss something like this. But I think this is even there's a second ASEAN Academic Conference, but is the first time that we could meet each other face-to-face and talk more closely. For this situation or this environment, I'm very happy, and also I would like to encourage our friends from 10 ASEAN member states to support this and also to make it progress. And also for myself, I think I'm very happy to support Indonesia to be a secretary office for the AIDHM, because Thailand have the role of RCCDHM already. But for the academic, Indonesia can do that. But not only Indonesia, I think I proposed to Professor Yodi, the Dean, already that I want to make our ASEAN member state feel we are the same team. We should have the same symbolic, not only put in UGM, but it could be put in national focal point in our 10 member states. This is something that we are same family, we are same team, and also it could have some support from ASEAN-SEC also. I think it's very important. That is the thing that I would like to express from the beginning. Thank you.
So the integration of Asian Institute not just only belongs for us, but all the ASEAN member states join to develop, right? Yes, thank you.
Thank you very much.
Sure,
Very well
sure.
noted. Yeah. Dr. Acharya, please. Yeah, please. If you have, no? Good? Yes. Okay, thank you very much. So I remember that Professor Yogi says now we have many friends when we all visited your great institute, and so there's many friends, and but also Dr. Pumin says we are arch families, so we all need to make a good commitment, but that is a background we are here. Thank you very much, Professor Dr. Acharya. And so next, may I allow me to ask to President Don, from your viewpoint, how WADEM see this network, and what is a possible contribution you may make to this great network? Thank you, please.
I'll start off by saying I don't at all anticipate AAN supporting WADEM. What I foresee is WADEM and AAN working as equal collaborators to advance disaster medicine management. We can function. WADEM is, I'd like to believe, we are a global voice, an honest broker, and an unaligned voice when we go to the World Health Cluster. There's all sorts of people, all sorts of groups who have an agenda. We don't have an agenda. So that's part of it. My colleagues here the presentations encapsulated and stole my thunder. Basically everything you outlined, we hope to do. What I believe WADEM can do for AAN is act as a bridge. I mean, I can bring you our member who instructs CBRN to the European Parliament. I can connect us to Abu Dhabi and the Department of Health there and their very active program. I could also align us with the Harvard Disaster Medicine Fellowship, whose faculty includes me. But great, and Harvard's faculty is global. They're on every continent, and they're well established. So we have a strategic priority to promote the research, to promote the distribution of knowledge, and particularly to promote expertise and excellence on young and emerging scholars. I mean, they're our future. I have gray hair, but the young scholars entering a realm that's, I think you mentioned it, it's really not well defined. Disaster medicine is relatively new. Disaster medicine research is in its infancy. So I see this as a powerful alliance to align our resources and move what we do with a passion forward.
Thank you very much, President. So we can expect WADEM as a kind bridge to the international community and the partners. Thank you very much, sir. And may I also ask to Professor Honma, President of JADEM, how do you see this network? What is a possible contribution from JADEM to this AAN and GHM? Please.
Thank you very much for asking me. In the Asian country, we have a lot of disaster, and this area, I think, disaster-prone area. So, if I have a disaster this time, I think the next disaster occur anywhere, any country. So, what I should learn the experience at the time is, I think, when I told that when I visited Thailand, I thought I should have done much before Japan affected the tsunami. So the important thing is to share the information and keep a passion. I think the passion is a very difficult thing. Passion is passion. If continue to do the passion, we should hear another experience of the disaster or share the communication with experts. And visited the affected area as, for example, is the EMT team. So I think it's important to share the information. Yes.
Thank you very much, sir. So JADEM will just by not only the JADEM contribution would not only limited to the technical issue, but also to share the passion, facilitation. So that kind of the energy we can expect on JADEM. Thank you very much, sir, for your kind suggestion. Ryoma, what we can expect to you from your WHO Kobe Center, please.
Our contribution to this network. Thank you for your question. Very simple. Let's join. Please join our network too. The research network of health EDRM of WHO currently works as more about the information sharing platform. So we do a lot of global collaborative research, global collaborative projects. We just share the information about for example, offer the opportunity for you to be involved in these types of the collaborative activities. For example, when we developed the guidance of the research methods for health EDRM, we called the contribution from the participants of the research network to be part of the co-author of the guidance. And then we convened more than 150 experts from all over the world to work together to write the textbook, the guidance together. Then we also asked several WHO colleagues and the other experts to do the peer review. So these types of collaboration was enabled by this network. Same thing, we just share the information with you about some possible new project or new ideas for you. And ASEAN network also can do the same thing among your regional colleagues and participants. And then I also want to know what's going on in ASEAN countries. And if possible, I want to be in part of your project too. I can support your project too. So this type of very loose but kind of close communication, collaboration will be the good opportunity for us to work together. That's the first thing I can say, Tatsu.
Thank you very much, Ryoma. So can I ask also about the importance of your framework or implementation of the guideline of the WHO? Can you say something about those things?
It's about the guidance?
Yes.
Okay.
Research guidance.
The research guidance is, so when you think about how to do research before, during, after emergency disasters, maybe most young scholars and students will be lost. How to do it? No guide, no textbook. But please visit the website, and then there is a textbook. Of course, it's not perfect guidance, but we are doing the revision every year, every 2 years, to make it more useful. And that is why we created the video lecture for each chapter, slideshows for each chapter, which are available all online. And now we are organizing the global kind of network or initiative or partners to universities partners to work together to use the guidance for your lecture, for your training, for students and young scholars. And if you use the guidance for your lecture, please give us a feedback. What would be the space to improve? What would be the another topic to deal with? If you want to know another chapter, so for example, we are planning to add implementation science. For example, we are going to add the research translation to policy and practice. Those new chapters will be added depending on the needs of the on-site the health professionals and researchers. So yeah, it means, I want to say that, so use like EMT activities, if there is a kind of the common tool to use for your global activities, regional activities, it's very big power. So let's use the guidance and then please do the research and then report it on the ASEAN journal and WADEM journal and JADEM journal and increase the number of the publication. It will increase our presence in the whole medicine world. So that will make another motivation for young scholars and students to be involved in this arena. Thank you.
Thank you very much, Ryoma. Great. And so may I ask all of you, what is your thought? Do you have any idea how you yourself can contribute in this great network? If I may I ask to the great participant who come far away from over to this great city, Dr. Mario, may I ask you, would you please? How do you see the network? What is your thought?
Yes. Well, I have seen incredible networking, incredible project of the arch, execution and planning. I'm sure you are already working on the long-term sustainment of the arch project, not only on the academic network, but of the whole project. And I think one of the most dangerous things for a successful project is to be a victim of its own success. And so what I could say is that we should never lose the ability to erase the board completely and try to innovate and make the future new again, so that you don't limit yourselves to the already great achievements you have already reached, but aim very far, farther and farther away, so we can all could go together in this direction. Thank you.
Thank you very much. We should not limit our success. Thank you very much for a great comment. Thank you very much. So may I, if I may, can I ask Dr. Luke for your some input or make some comment? Would you please, sir?
Thank you very much for inviting me to this session. And I apologize if what I might say might not be appropriate to some of us. But I must say that I'm quite impressed with one ASEAN, one response concept that I've learned. As I have presented yesterday, this is something that we've been brainstorming around in the Pacific for one Pacific response. And this is a learning opportunity. And when I was invited to come into this conference, I had a look through the program. And even when I was looking at where I was placed in the program, and I saw and I find myself, here I am coming from a very small country and with a big region. And what have I to say into a region that is so rich and so experienced in disaster response, so resilient, innovative. I'm impressed with the way the training has been going on. But the biggest question I was asking myself as I was listening to all the countries that have presented, they've already got the network in responding to disasters. And I think one of the things that we usually struggle also in the Pacific is how do we break the culture? And I think in our ASEAN region, we are also culture rich and we respect culture. And I think we need to find a way to break the culture, because culture is linked to belief and how we are being brought up, and it shapes also our society and how we live. And I think if I have something to live into this great conferences, how can we break the culture so that we move into the EMT framework? Thank you.
Thank you very much, sir. So okay. So as Dr. Luke said, for my understanding, on his keynote, he said that the one ASEAN approach is something very interesting and could be applied in the further in her project and so on. And you said that your team is, or Ireland is just developing, but we also believe your team is already classified and you have great knowledge already. Like Professor Acharya says, everybody here can learn from your great experience. We do believe. So please keep communicating with us. That is our small prayer to you. Thank you very much, sir. So it's coming almost. Is there any other thoughts or any other comments you wish to make for the future. Professor Eger, please. Thank you very much.
Thank you very much for this wonderful session. I'm Shinichi Egawa from Tohoku University, and I would like to comment to the young people here. And as noted by Mr. Ikeda, ASEAN Journal of Disaster Health Management will invite young researchers to submit a research paper. And it is so important to get a degree with published papers. The master course students and doctoral course students need a paper to be accepted as a degree and your research accomplishment. And the reason why I'm saying is that it is not so easy to eat on disaster medicine. The disaster medicine is not an established discipline yet. Many universities does not have a professor of disaster medicine yet. So it is important to have a paper and get a degree, PhD, and become a university professors to lead the next generations and next generations to be sustainable. And in order to do that, I would like to invite young researchers to actively submit your practices or case studies to the journal. And most importantly, the reviewing process is so critical in the scientific journal. It is not possible without reviewers. So I also recommend you to contribute the reviewing the papers that was submitted in the journal. Thank you very much.
Please, President Don. Thank you very much, Professor Egawa.
I do have one, if I could put my professor robe on, and everybody in this room has done research. We've all done research. I have served as an editor on disaster medicine and public health preparedness and a reviewer on several other journals. And I can tell you that publishing research is different. It's different than just writing a paper. It's more detailed. There are more specifics you need. You need to back up what you're writing. So I encourage everybody to take advantage of the Kobe Center's your work, your voluminous work. We will be at Wadham in the Harvard Fellowship. We had Dr. Jeff Frank from the University of Alberta just gave a presentation about how to look at 10 Delphi studies and come up with a conclusion. I'll be posting that. Well, I won't be. Our executive officer will be posting it to the website. But learn to do quality research. And the research of what we publish is our advocacy. When what we believe is put out there in black and white and in electrons, when you go to your government and your Ministry of Health, that's the power you need to back you up to make your point and convince them to support what we do.
Thank you very much, John. Okay, great. And we are almost left 5 minutes. And so now we are coming very clear on the one page, I believe. But also, just before the closure, may I ask Mr. Ikeda and highlight this thing. I mean, the ARCH project will end in coming 2 years. And so we need, but this network, or AIDHM, will last, everlasting, I do believe. So is there any key suggestion about how we can spend these 2 years? What should we consider to go forward after 2 years after? Please.
Thank you. Thank you, Chair. Yes, ARCH work, especially to making some kind of the framework at the start, at the beginning. But yes, now we have the ASEAN network. And but network itself, if this ASEAN network just a closed network, and those kind of the closed network getting weaker. You have to continue the effort to expand this network. Because within the region, you have to also invite many other members. The brain cell cannot be survived without the network. Brain cell with how can I say, a network that can be function. And anyway, the network, ASEAN network, have to continue strengthen your network itself. And it is necessary for the network to expand, and outreach networking activity is essential. without finding about some another friend outside of the region. This kind of network is isolated. You cannot have really a knowledge hub in this region. You have to strongly working with other many different partners and external player, WADEM, of course, and WHO Kobe, also WHO, the academic network also very important, and JADEM also key player, and not only those, maybe you may have more different the possible partner to expand your network. That we expect that you will continue such kind of effort on outreaching. And also one more thing, now we are very lucky we can have many big, how can I say, people from the very important organization from the WADEM as well as JADEM and WHO Kobe. Yes, nobody maybe oppose that. Yes, collaboration with external partner or those kind of different societies are important. Nobody oppose, nobody deny about the importance of the expanding and collaborating with those kind of different network. However, how we can get the actual linkage, continue some kind of the relation with those kind of very good another network. That we have now the many big name, and maybe yes, the Professor Kubo says that here is many of them are the arch friend, but maybe we have to say that we are the friend of GHM, and yes, we can say that yes, the Professor Dan are also our friend of the DHM, also some kind of the relative friend of relative friend of the ASEAN Academic Network. Professor Honma and Dr. Kaino also, they are also friends. Anyway, this is a very good occasion. We have to catch them to work together with them. If so, we have to have some kind of some more concrete idea how we can continue this kind of good relation. Yes, once we, how can I say, close this conference, some of may forget about this good relationship. We would like to continue this good the relation continuously. Maybe we have to think about more concrete idea how we can continue this kind of relation even after this conference. I have some proposal. The WADEM Tokyo is a very good opportunity for the targeting to work and strengthen such kind of relation between the ASEAN Academic Network, WADEM, WHO Kobe, the JADEM. Those three important players also very involved for the WADEM Tokyo conference. And targeting for the organizing the WADEM conference. ASEAN Academic Network shall also try to have some kind of the presence in the occasion of the WADEM Tokyo. If so, targeting for the participation or more active contribution to the occasion of the WADEM Tokyo, we would like to continue some kind of relation, and we propose that those different three players to have, how can I say, periodical contact with us and talking with each other. Sometimes we can organize some kind of online meeting to share about the progress. Of course, AIDHM and some of the key players of the participants here also join to such kind of meeting and continue the collaboration and the sharing about the information. I would like to propose such kind of the mechanisms for the further and realization of the actual relation between and strengthening the pipe between the different organizations. Thank you very much.
Thank you very much, Mr. Ikeda. Yoma, do you have some additional
Thank you. Just I want to echo what Mr. Ikeda says. As he mentions, it's very important. Network is network, but we need something to do together. So WADEM Conference 2025 will be the good example to model to work together, work together. And periodic discussion will be the key to continue our relationship. Thanks.
Thank you very much, Ryoma. So before the closure, may I also ask to Mr. Jim, our network hub, AHA Center, if you allow me, could you please, ASEC, please, sorry, ASEC, please.
Yeah, thank you very much for giving us the opportunity to also share some insights. The contributions, the information being shared are really encouraging to hear that there's really a very good and strong potential that while we have already achieved a lot of things with regards to strengthening disaster health management at the national and the regional level, there are still many things that can be done. And that's in terms of the discussion of what happens after 2025, after the completion of the ARCH project. We are, as also mentioned during the handover discussion between the outgoing and the incoming chair of the steering committee, is that we have already planted something that has also started to germinate, and it's up to now for us to really nurture and have that really grow. And that's the ASEAN Institute for Disaster Health Management. We should not be, or Indonesia should not be concerned that that the ASEAN member states will not contribute. It's being guided by terms of reference. It's already adopted by the ASEAN Health Ministers meeting. So in fact, with that adoption, we can really start with the operationalization of the institute. Perhaps in a month or so, the host country will be asking the ASEAN Secretariat to facilitate the nomination of representatives to the governing board or the board of directors. Because as an ASEAN center or as an ASEAN institute, everybody will be represented. Any decision, any project or any concern that will be addressed, that will be through a consensus, through discussion and a consultation of everybody. So yeah, not a concern for Indonesia. The ASEAN Secretariat will also be there, also endeavoring to bring other partners so that we can really continue the work, what we have started. Yeah, we need to sustain this. So those are some insights from the ASEAN Secretariat. Thank you.
Thank you very much, Mr. Jen. Round of applause, please. So any final comments? Good. Allow me to challenge. So thank you for a great commitment to this final session. And it was confirmed that ASEAN Institute of Disaster Medicine, for this, we have a strong support from the ASEC, very structured support from the ASEAN mechanism, and all ASEAN member states have the roles and responsibilities. And Dr. Achira said, your nations all have some specialties or something great knowledge. So there's a great, significant possibility for all of your member states to have to contribute in this network and the institutes. Also, we have confirmed and observed that there's a non-ASEAN member states great partners. WADEM will be a bridge to the international partners. JADEM can bring the passion and knowledge, and WHO give us a framework and the research protocol and so on, guidelines and so on. And also, it was mentioned also from Dr. Luke and Dr. Mario, we should not satisfy with this great success. We can go more, and if we can communicate with non-ASEAN member states, that will give us more understanding of the diversity of the culture and more depth understanding of our disaster response. And at the end, this is a long-lasting project, and we need to think about the post-ARCH period. But honestly speaking, I expect ARCH 3 project, honestly. We all hope, but some years after, maybe the ARCH project will end it. But even taking this moment, network will help us. And the network, namely, we are the arch family, arch friends. That is a face-to-face relationship. That is something we can go strongly and we can improve this network. Thank you very much for all of your commitment, and thank you all to the all distinguished panelists. Round of applause, please. Thank you very much.
Thank you very much, Mr. Moderator, Mr. Tatsuhiko Kubo. Arigatou gozaimasu. And may we invite you to please join us. Kindly stay seated, speakers. We would like to take this opportunity to present our tokens of appreciations to our delegates who have yet to receive their tokens. May we invite the following names to please take up a position front and center. First, our moderator for the final session today, Mr. Tatsuhiko Kubo from JAG. Join us front and center, please, sir. May we also invite Ibu Bella Dona of Indonesia to join us front and center. Also inviting Mr. Acharya Pangma from Thailand, Mr. Masato Honma from Jaidam, and Mr. Rioma Kayano, please. And to present, get together, please, at the center. And to present the tokens of appreciations, may we humbly request again from ASEAN Secretariat, Mr. Jim, to join us, please. Mr. Jim Katampongan, on behalf of the ASEAN Secretariat, now known as the ASEAN Headquarters, will now present first to our moderator of the final session from JAG, Mr. Tatsuhiko Kubo. Arigatou gozaimasu. Thank you very much. Terima kasih banyak. Next to Indonesian's colleague, Ibu Bella Dona. We thank you very much indeed. And the next token to our colleague from Thailand, Mr. Acharya Pangma, on behalf of NIAM. Kapkom Ka. And next up to our delegates from JADM, Mr. Masato Honma. Thank you very much. And last but not least, from WHO, Mr. Rioma Kayano. And for a group photo, may we invite the rest of the panel, Mr. Shuichi Ikeda from Arch Project, and also Mr. Donald A. Donahue from Wadham to join us for a group photo. Mr. Jim, kindly take up a position at the center of the group, please. Come closer together, ladies and gentlemen, please. Right, on the count of three, please, to the master photographer at the center. 1, 2, 3. One more time, give the biggest smile for the final session. 1, 2, 3. And the biggest round of applause, ladies and gentlemen. What an inspiring final sessions of our conference. May we invite all delegates to please kindly return to your seats. Thank you very much. Ladies and gentlemen, please allow us some time to set up our stage for the closing sessions of the conference. Distinguished delegates, ladies and gentlemen, we almost come to the end of our conference here in the beautiful, the inspiring Yogyakarta Special Region of Indonesia. And we have been inspired beyond belief. And to cap off our days of conference here in Yogyakarta, allow us now to invite not one, but two esteemed closing remarks from our delegate. For the first closing remarks, may we now invite the chairman of the Japan Advisory Committee, or JAC, Mr. Tatsuro Kai, please.
Good afternoon, everybody. I'm Tatsuro Kai, Japanese Advisory Committee on this Arch project. Mr. Agus Hendroyono, Chairman, Second ASEAN Academic Conference on Disaster Health Management from Center for Health Crisis, Ministry of Health, Republic Indonesia, and Ms. Hajaria Pandya, Center for Health Crisis, Ministry of Health, Republic of Indonesia, and Professor Yogi Mandala Tada, Dean of Faculty of Medicine, Public Health and Nursing, University Gajah Mada. Invited delegates, ladies and gentlemen. It was great pleasure to be you today at the second ASEAN Academic Conference on Disaster Health Management. On behalf of Japanese Advisory Committee for the project to strengthen the ASEAN regional capacity on disaster health management, named ARCH project, I'd like to express my appreciation to Indonesia for hosting the first in-person conference after the pandemic, which interface with our physical communication, and extend a congratulations for the successful achievement of a lively discussion and exchanging the numerous insights for knowledge co-creation for resilience disaster health management toward one ASEAN, one response. As you know, Japan is a disaster-prone country and one of the Asian countries that can share the sense of disaster risk with ASEAN by facing it all the time. The common sense is also fostered by sharing knowledge and experience from past national disaster in Japan with other countries through various training courses. Japan has accepted training from disaster medicine from more than 50 countries worldwide since 1988. For a more strategic approach to deal with a common problem between Japan and ASEAN, the survey on the current situation on disaster medicine and emergency medicine in ASEAN region was conducted between 2015 and 2014 to create ARCH project as a technical cooperation project. Based on this background, the ARCH project starts support ASEAN to strengthen this regional capacity in disaster health management by sharing the Japanese knowledge and experience on domestic and international disaster medical response. Throughout the project activity, we have recognized that the ARCH project is a platform for promoting the lively human resource exchange for the development of disaster health management between Japan and ASEAN. For instance, we have worked together for the development of the training program, such as a regional collaboration drill, which was successfully conducted in Malaysia last month. And since the project has been running, we have realized that the knowledge sharing and co-creating are the key factor for the successful accomplishment of a mutual goal, not only just one-way support, but also learning from each other between Japan and ASEAN member states. Thanks to mutual effort to ASEAN member states to commit the development of a regional capacity expansion of disaster health management in the region. The project also tried to keep the right track, which ASEAN member states in terms of the providing the occasion for the mural learning and knowledge co-creating. So now I'm very grateful to see the historical moment for the establishing the ASEAN Academic Network on Disaster Health Management. That was officially launched in the 2021, which is one of the 21 targets for the plan of action to implement the ASEAN Leaders Declaration on the Disaster Health Management. The network will support the academic, research, and learning component of the capacity building effort on disaster health management in ASEAN. Since the network was established, thousands of discussions have been had among ASEAN member states for developing an effective network structure and mechanism. As you have seen in the 17th October, the day before yesterday, the ASEAN Institute of Disaster Health Management was officially inaugurated, which is one of the entities for the sustainable development of disaster health management in region by collaboratively working together with the steering committee on ASEAN Academic Network on Disaster Health Management. ASEAN Academic Conference on Disaster Health Management is one of the network of key activity which is planned to conducted once in 2 years, as well as ASEAN Journal of Disaster Health Management, and joint research has already been started in earnest for its operationalization. In addition, I'd like to highlight the fruitful outcome of this conference by inviting them not only the all over the ASEAN country, but also from the non-ASEAN region. The guests from United States, Costa Rica, Fiji, and Switzerland. This is a great opportunity to spread our perspective and elevate our motivation to move towards to accomplish our goals. Disaster health management is a new academic field. At the same time, it was a huge opportunity and capacity for the expansion and the enhancement. Through this newly established academic network and mechanisms, I hope that many colleagues from ASEAN member states, as well as from the non-ASEAN countries, will proactively join this academic activity to empower our capacity of disaster health management together, which leads to effective healthcare service provision to save and ensure the disaster affects people's lives and save. To end my speech, once again, congratulations on the great achievement of the aim for the second ASEAN Academic Conference on Disaster Health Management. I hope that our continuous tight collaboration and cooperation among Japan, ASEAN, and North ASEAN countries for further mutual learning and knowledge co-creating through the ASEAN Academic Network for realizing the one ASEAN, one response, and move forward to the contribution for the beyond the region hand in hand with colleagues who have the same hope and passion for the future development of disaster health management. Thank you very much.
Thank you very much, Chair of the Japan Advisory Committee, our Jack, Mr. Tatsuro Kai, for the concluding remarks. And for the next closing remarks, ladies and gentlemen, we are privileged to invite a representative on behalf of the government of the Republic of Indonesia from the Center for Health Crisis, the Ministry of Health of the Republic of Indonesia. Please welcome Mrs. A. Hadijah Pandita.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Honorable Steering Committee of ASEAN Academic Network on Disaster Health Management, Secretary General of National Institute for Emergency Medicine, colleagues of ASEAN member state, ASEAN Secretariat, Chief Advisor of Japan International Cooperation Agency and Project for Strengthening the ASEAN Regional Capacity on Disaster Health Management Project Team, Dean of Faculty of Medicine, Nursing and Public Health, Universitas Gadjah Mada, Distinguished Resources Person from World Health Organization, the United Nations Officer for Disaster Risk Reduction, the World Association for Disaster and Emergency Medicine, Japan, Costa Rica, Fiji, Timor-Leste, Japan's Association Disaster Medicine, Japan Advisory Committee, and all the participants. A pleasant afternoon to all. Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera bagi kita semua. Om Swastiwastu, Namo Buddhaya, Salam Kebajikan. We have reached the end of our conference. I believe that during these 3 days, we have learned a lot from the speakers and experts to enrich our knowledge and insight on the disaster health management in various settings. Therefore, I would like to sincerely thank all the resources persons that have shared your experience and expertise during the meeting. Furthermore, this meeting is meaningful because of the active engagement from all participants. In occasion, I would like also to thank all participants who have joined this conference. Your presence made it truly special. I do hope that through our sharing and discussions, all of us can contribute to implement the knowledge from the conference to our policies and practice and strive to improve not only national capacity, but also regional capacity and the mechanism on disaster health management as one ASEAN, one response. Finally, I would like to thank ASEAN Academic Network on Disaster Health Management and Arts Project and all the committee members from Ministry of Health and Universitas Gadjah Mada for organizing this conference and ensuring that it proceeds smoothly. I would like also to apologize for any inconvenience that you might experience during this conference. Ladies and gentlemen, there is saying in bahasa Indonesia, ada perjumpaan, ada perpisahan, which means when there is meeting, then there will be goodbye. I'm certain that you are looking forward to get back to your respective homes. So I thank you once again for your participation and wish you all safe your journey home. I hope that you enjoy your stay here in our lovely city, Yogyakarta, as well as our conference. And I do also hope that we can meet again in third ASEAN Academic Conference, the third ASEAN Academic Conference. Thank you. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you very much, Mrs. Hadijah Pandita from the Center for Health Crisis of the Ministry of Health of the Republic of Indonesia for the closing remarks. Distinguished delegates, ladies and gentlemen, and now we have a very special book in the name of National Guidelines for Health Crisis Management and a special photograph that we would like to present to representatives of participating ASEAN member states. And thus, may we kindly invite to join us on stage representatives of each ASEAN member states. May I call upon in alphabetical order. Representatives from Brunei Darussalam. Please join us on stage, please. May we call also upon representative of Cambodia. Come join me on stage, please. Next, our representatives of delegates from Indonesia. And next, from Laos PDR, join us on stage, please. And our fellow neighbor Malaysia, our representatives, come and join us on stage. And next, calling upon the Philippines. On behalf of your delegates, do join us, please. And Singapore, please join us. And from Thailand, do join us on stage. And lastly, from Vietnam. Let's make sure that I have everyone on stage because we believe we will have 9 because we've been informed that our delegates from Myanmar have not been able to join us here in person, and thus, once again, for the country check, Brunei Darussalam, in alphabetical order please, Cambodia, Indonesia, Laos PDR, Malaysia, Myanmar in absentia, the Philippines, Singapore, Thailand, and Vietnam. We are still missing plenty of representatives. If you hear your country being called, please, someone on behalf of your country, someone from the delegations, kindly join us on stage. Or if you know your colleague from a country I just mentioned, give her or him a nudge and ask him to go on stage and join me. We are missing 5 more, please. Let me recount again. Brunei Darussalam already on stage, Cambodia, Indonesia, Laos PDR, Malaysia, please, Myanmar in absentia, the Philippines, Singapore, Thailand, and Vietnam. Now we have everyone, thank you very much, ladies and gentlemen, to present our appreciations on behalf of the government of Indonesia. May we call upon from the Center of Health Crisis of the Ministry of Health of the Republic of Indonesia, Mr. Agus Hendroyono, and also may we invite our Dean of the Faculty of Medicine, Public Health and Nursing of Universitas Gadjah Mada, Professor Yodi Mahendra Datta. Do join us, please, Prof. Mr. Agus and Mr. Yodi will in turn present the book and also the special photograph. First, Mr. Agus to our delegates from Brunei Darussalam, please. Thank you very much, Brunei. And now, Mr. Agus to delegates from Cambodia. Thank you very much, Cambodia. Next to Indonesia. Thank you. And next to Laos PDR. Thank you very much, Mr. Agus. Wait a minute. May we now request Professor Yodi to present. Yeah. Professor Yodi, shall we now present to our delegates from the Philippines? And just before that, from Malaysia. Thank you very much, Malaysia, Philippines, and then next to Singapore. Thank you, Singapore, for the experience sharing. And next up in the line, Thailand. And last but not least, Vietnam. Thank you very much. Mr. Agus and Mr. Yodi, may we have you at the center of the group, please, for our final group photo. And Mr. Agus, Mr. Dean, if you'd be so kind for just a few moments to take off the mask so we can see your smile. Thank you, Prof. Everyone, get together for the group photo. ASEAN member states for the conference here in Yogyakarta on the count of 3. 1, 2, 3. 1, 2, 3. A big round of applause, ladies and gentlemen, for our delegates of ASEAN member states for the second ASEAN Academic Conference on Disaster Health Management. Thank you very much. Ladies and gentlemen, kindly return to your seats, please. Distinguished delegates, ladies and gentlemen, we have now arrived to the closing ceremony of the second ASEAN Academic Conference on Disaster Health Management here in Yogyakarta, Indonesia. And to mark and officiate the closing, we have now arrived to the handover session. To start this session, may we invite on behalf of the current chair of the steering committee, the Secretary General of National Institute for Emergency Medicine of Thailand, to give his remarks. Mr. Acharya Pangma, please.
Hello. Okay. Ladies and gentlemen, I think this time is a time to close for ASEAN Academic Conference that we have. It. First one is a pre-conference. The second and third one is a main conference. I think it's very important time that everyone here should be share the knowledge. Someone speak, someone listen, but all are there, all are we share the experience. I hope this conference will be fruitful for anyone. And I hope that we could have this opportunity again for the next third ASEAN Academic Conference. And on behalf of steering committee, the current one, I would like to hand over my responsibility to the next chairperson of the steering committee, Professor Yodi and his colleague. I have to say thank you for everyone, especially for the team from Japan, the JICA team, and expert from many parts of the world. And also have to say thank you for all ASEAN member states and all participants today. Thank you. Thank you again.
Thank you very much, Mr. Acharya Pangma. Please kindly take up positions at the center of the stage for the handover ceremony. And may we invite Dean of the Faculty of Medicine, Public Health and Nursing of Universitas Gadjah Mada Yogyakarta, Mr. Yodi Mahendra Datta, for the handover ceremony. Ladies and gentlemen, we will now present a folder on behalf of the previous steering committee of Thailand to be presented to Indonesia. Ladies and gentlemen, I've been informed that the handover will be officiated by a handshake. Now, may we have Mr. Acharya Pangma and Mr. Yodi Mahendra Datta shake their hands, and congratulations, Indonesia, for the next steering committee and chairmanship of DHM. Thank you very much, gentlemen. May we invite you to return to your seats. Mr. Yodi, now, please, your congratulatory remarks for the next steering committee of Disaster Health Management of Indonesia. Thank you.
Okay, that was the most unforgettable handshake. I was thinking there must be a firework or something. Yeah. Assalamualaikum warahmatullahi wabarakatuh. Distinguished guests, colleagues, friends, ladies and gentlemen, it's with great honor and at the same time profound sense of responsibility that I assume the role of the new chair of the steering committee for the ASEAN Academic Network for Disaster Health Management. I stand before you today humbled by the trust and confidence that you have placed in me and our team to lead this esteemed network into the future. First and foremost, I would like to express my heartfelt appreciation to my predecessor, Dr. Acharya, for his exemplary leadership and dedication in steering this network to where it stands today, a very solid state. His dedication has set a very high standard, very difficult to match, but I will try my best to uphold and build upon as we continue our collective journey towards strengthening disaster health management in the ASEAN region. I count on Dr. Acharya as our senior mentor to our steering committee, someone who we would run to for advice and guidance now and then. And as we embark on this new chapter, our focus remains steadfast on the shared vision of fostering resilience and strengthening disaster health management toward one ASEAN, one response. To my fellow steering committee members, tomorrow we will literally hit the ground running when we convene the steering committee meeting, because we have a packed agenda for the whole day to discuss. We will discuss the annual plan for the ANDHM. We will discuss membership for ANDHM. We will discuss the plan for the ASEAN Institute on Disaster Health Management. We will discuss joint research program, publication plan for the ASEAN Journal, and other outstanding issues, including the prospect of the third ASEAN Academic Conference on Disaster Health Management. So for our fellow steering committee, please have a good sleep tonight, because tomorrow we will work very hard. So I encourage all the steering committee to have a good rest, and tomorrow please bring forward your innovative ideas and contribute your unique insights and actively shape the initiative and projects that we will define our journey ahead. To all members and friends of ANDHM, I'm confident that with your unwavering support and dedications of our esteemed steering committee, we will collectively navigate the intricate landscape of disaster health management in the region. Thank you again for the trust you have placed in us. I eagerly look forward to working with each and every one of you as we forge ahead towards a brighter and more secure future for our beloved ASEAN community. Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Thank you very much, Dean of Faculty of Medicine, Public Health and Nursing of Universitas Gadjah Mada Yogyakarta, Mr. Yodi Mahendra Datta, for the remarks on behalf of Indonesia for the next couple of years, assuming the chairmanship of disaster health management here in the country. Thank you very much indeed. Distinguished delegates, ladies and gentlemen, the second ASEAN Academic Conference on Disaster Health Management here in Yogyakarta, Indonesia has come to a conclusion, signifying a milestone, significant strides that we've all made in terms of the management of disaster health, not only in the region and beyond. May our conference here in Yogyakarta forge new paths of cooperations between ASEAN and more partners in the time coming. Finally, I'm Rahmat Idris. This has been a distinct honor. We wish you enjoy Yogyakarta, and please bring home great stories and great souvenirs from our city. And with that, thank you so much for your enthusiasm and participations. Goodbye and see you again. Wassalamualaikum warahmatullahi wabarakatuh.